ACIP meeting. Copies of the slides being presented at today's meeting are available on the ACIP website. Additionally, slides are available through a share file link for ACIP voting, liaison, and ex officio members. A few notes on meeting logistics for those who are listening in on the Zoom line. Please mute your lines at all times until you're called on for discussion. When Dr. Lee opens the meeting for discussion, please virtually raise your hand. During the discussion period, Dr. Lee will take questions first from voting ACIP members and then from ex officio members and liaison representatives. Please disable your video. A profile picture is fine, just no live video. ACIP voting would ask ACIP voting members to turn their video on during the votes. The Advisory Committee on Immunization Practices is, at its heart, a public body. Next slide, please. Engagement with the public and transparency in our processes is vital to the committee's work. For this meeting, we'll be holding 2 oral public comment periods. The first oral public comment will occur today at approximately 12:10 Eastern Time. The second oral public comment period will occur tomorrow at approximately 3:45 Eastern Time. To create a fairer and more efficient process for requesting to make an oral comment, people interested in making an oral comment are requested to submit a request online in advance of the meeting. Priority is given to these advance requests, and if more people request to speak than can be accommodated, we conduct a blind lottery to determine who the speakers will be. Speakers selected in the lottery for this meeting have been notified in advance of the meeting. Members of the public can also submit written public comments via regulations.gov using docket number ID CDC 2021-0112. Information on the written public comment process, including as well as information on how to make a comment, can be found on the ACIP meeting website. Next slide, please. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forego participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains on all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflict of interest. I will now turn things over to Dr. Lee for roll call.
Thank you. Before we get started, I would like to let you know that Dr. Rochelle Walensky, the director of the CDC, has asked to join us and would like to make a few brief comments to the committee. So we are working to get her video on so that we can hear her speak. Just a moment.
I think my video is on and I think my audio is on. Can you hear me, Dr. Lee?
We can hear you and we are just about to see you. Give us 1 second. Please go ahead.
Wonderful. Good morning, and thank you, Drs. Lee and Wharton, for giving me the opportunity to speak with you once again today. Today is a monumental day in the course of this pandemic, and one that many of us have been very eager to see. Ever since your vote on December 12th last year, recommending COVID-19 vaccination for those 16 and older, we have been asking when we will be able to expand this protection to our younger children. In the nearly 12 months that have passed since that vote, we have learned a tremendous amount, both about COVID-19 disease and the vaccines that combat it. And today, you have the opportunity to review those data, discuss the benefits of expanded vaccinations, consider the risks, and make a recommendation that is likely to have tremendous impact. As you review the data today, it will be key to keep in mind the specific risks to children from this virus and this pandemic. and to put that risk into context of other vaccine-preventable diseases. Let's take varicella. In the 5 years prior to recommendation of varicella vaccination for children, each year there were somewhere between 4 and 31 hospitalizations per 100,000 children less than 20 years old. In those 5 years, 16 children aged 5 to 9 died from the virus. As you are all aware, in this most recent Delta wave, we saw pediatric admissions peak higher than they had in any previous wave of the pandemic, reaching a rate of 25 hospitalizations per 100,000 per year in children between the ages of 5 to 11. And there have been 745 deaths in children less than 18 and 94 deaths in children aged 5 to 11 since the start of this pandemic. Yes, fortunately, these most severe outcomes are generally rare. The chance that a child will have severe COVID, require hospitalization, or develop a long-term complication like MIS-C remains low. But still, the risk is too high and too devastating to our children, and far higher than for many other diseases for which we vaccinate children. There are now over 5,200 children diagnosed with MIS-C and living with the complications of that disease. We also know that beyond the clinical impact of COVID on children, there have been detrimental social and mental health impacts that we are just beginning to fully understand. For almost 2 full years, school has been fundamentally changed. There are children in second grade who have never experienced a normal school year. There are students in middle school who missed out on school sports and extracurricular activities. There are missed proms and homecoming dances and too many missed graduations. We have watched as the education gaps that exist in this country have widened as this virus has disproportionately impacted racial and ethnic minority communities. Pediatric vaccination has the power to help us change all of that and to let us move towards schools as we once knew it and hope it can be, a safe and enriching environment for all of our children. I also think that I share with you a perspective that pediatric vaccination is just one important piece to this puzzle. It is important that we also continue to vaccinate as many adults as possible to provide protection to children in the community, including those younger than 5 who may not be eligible yet for vaccination. Looking at data from August through October of this year, as we saw Delta cases increasing sharply across the country, there were stark differences in pediatric cases based on community vaccination level. In a stepwise fashion, as the percent of eligible population fully vaccinated increased, the number of pediatric hospitalizations decreased. It is our ongoing responsibility to make sure as many people as possible are vaccinated and protected from COVID-19. I know that you have much to discuss today, and I look forward to listening to your deliberations. As always, I am most interested in hearing how you interpret what we know and acknowledge areas of uncertainty. I greatly appreciate your dedication to getting this right and to making sure that we continue to move forward in our efforts to end this pandemic with science leading the charge. Thank you for giving me the opportunity to speak with you this morning, and thank you for all you are doing for all of us. With that, I'll turn things back over to Dr. Lee. Thank you.
Thank you very much, Dr. Walensky, for addressing the committee this morning. Our advisory committee very much appreciates your engagement in our work, and we look forward to providing the advice and guidance that you need to support decision-making for the country. So we will begin our meeting with roll call, starting with ACIP members and then ex officio members and liaisons. And as a reminder, I'll ask that you state your name, affiliation, and whether you have any conflicts of interest for the ACIP members. And today we will start with Ms. Bata.
Good morning. This is Lynn Bata. I'm the immunization clinical consultant at the Minnesota Department of Health, and I have no conflicts.
Thank you and good morning. Dr. Bell.
That's Bell, clinical professor, University of Washington School of Public Health. No conflicts.
Thank you. Dr. Brooks.
Oliver Brooks, Chief Medical Officer at Watts Healthcare Corporation. Good morning, and no conflicts.
Good morning, and thank you. Dr. Chen.
Good morning. Wilbur Chen. I'm a professor of medicine, and I'm an adult infectious disease physician scientist at the University of Maryland School of Medicine. My employer, the University of Maryland, Baltimore, has a grant from Emergent Biosolutions that supports the work that I do on developing a Shigella vaccine. No other conflicts.
Thank you, Dr. Chen. Dr. Sineas.
Dr. Sybil Sineas. I am an internist and a pediatrician. I'm an associate professor of medicine and pediatrics at the Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you, Dr. Daly.
Good morning. I'm Matt Daly. I'm a senior investigator at Kaiser Permanente, Colorado. I'm also an associate professor of pediatrics at the University of Colorado School of Medicine, and I have no conflicts.
Thank you. Dr. Cotton?
Good morning. Camille Cotton. I'm the clinical director of transplant and immunocompromised host infectious disease at Massachusetts General Hospital and associate professor at Harvard Medical School. I have no conflicts.
Thank you. Dr. Lair?
Dr. Jamie Lair. I'm a private physician in family medicine in Ithaca, New York, taking care of both adults and children, and I have no conflicts of interest.
Thank you. Dr. Long?
Good morning, this is Sarah Long. I'm a pediatric infectious disease doctor and professor of pediatrics at Drexel University College of Medicine. I have no conflict.
Thank you. Ms. McNally?
Good morning, Veronica McNally, president of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you. Dr. Paling?
Good morning, this is Kathy Paling. I am professor of pediatrics and epidemiology and prevention at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist. I have no conflict. Thank you.
Thank you, and good morning. Dr. Sanchez?
Good morning, Pablo Sanchez. I'm a professor of pediatrics at Ohio State University College of Medicine, and I'm a neonatologist and pediatric infectious disease specialist at Nationwide Children's in Columbus. And I have no conflict. Thank you.
Thank you. Dr. Talbot?
Good morning. I am Kip Talbot. I'm an associate professor at Vanderbilt University Medical Center, where I am an adult infectious disease doctor, and I have no conflicts of interest.
Thank you. Dr. Alt is unable to attend today, and I am Grace Lee, professor of pediatrics at Stanford University School of Medicine, associate chief medical officer at Stanford Children's Health, and I have no conflicts. Next, we'll move on to our ex officio and liaison members. And as a reminder, I will announce the organization name, and please indicate who you are and if you're present in your first and your last name. So with our ex officio representatives, we will go to the Centers for Disease Control and Prevention first.
Good morning, Sam Posner, Acting Director, NCIRD, present.
Thank you. Center for Medicare and Medicaid Services.
Good morning, Mary Beth Hance, representing CMS, present.
Thank you. Food and Drug Administration.
Good morning, Doran Fink, representing the U.S. Food and Drug Administration, Office of Vaccines, present.
Thank you. Health Resources and Services Administration.
Good morning, this is Mary Rubin from the Division of Injury Compensation Programs, HRSA, present.
Thank you. Indian Health Service. Sorry, I'm not sure if I was muted. Indian Health Service. We'll move on to National Institutes of Health.
Morning, John Weigel, National Institute of Allergy and Infectious Disease, NIH.
Thank you. Good morning. Office of Infectious Disease and HIV/AIDS Policy. Good morning. This is David Kim representing OIDP. Thank you. Thank you, Dr. Kim. We'll move on to our liaison representatives. First, American Academy of Family Physicians.
Good morning, Pamela Rockwell, liaison to the American Academy of Family Physicians. I'm a professor of family medicine at the University of Michigan Medical School. Thanks.
Thank you. American Academy of Pediatrics.
Good morning, Bonnie Maldonado, professor of global health and infectious diseases, Stanford University School of Medicine, and chair of the Committee on Infectious Diseases for the American Academy of Pediatrics.
Thank you. American Academy of Pediatrics Red Book.
David Kimberlin, Professor of Pediatrics at the University of Alabama at Birmingham and editor of the AAP Red Book.
Thank you. American Academy of Physician Assistants.
Good morning. Marie-Michelle Léger, Director of Clinical Education, representing AAPA.
Thank you. American College Health Association.
Morning, Tavi Chai, and with my co-liaison, Sharon McMullen, present. Thank you.
Morning, and thank you. American College of Nurse Midwives.
Carol Hayes, present.
Thank you, Ms. Hayes. American College of Obstetricians and Gynecologists. We'll move on to the American College of Physicians.
Good morning, Jason Goldman, General Internal Medicine in Coral Springs, Florida, also affiliate associate professor at Florida Atlantic University. Pleasure to be here representing the American College of Physicians.
Thank you. American Geriatric Society. American Health Insurance Plans.
This is Bob Gluckman representing AHIP, present.
Thank you. American Immunization Registry Association.
Good morning, Rebecca Coyle representing ERA.
Good morning. American Medical Association.
Sandra Freihofer, practicing general internist in Atlanta, adjunct associate professor of medicine at Emory, representing the American Medical Association.
Thank you. American Nurses Association.
Good morning, Chad Riddle representing the ANA.
Thank you. American Osteopathic Association.
Good morning, Stan Grog, present.
Good morning. American Pharmacists Association.
Good morning, Michael Hogue, Dean and Professor of the School of Pharmacy and Professor of Preventive Medicine in the School of Medicine at Loma Linda University in California, representing the American Pharmacists Association.
Thank you. Association of Immunization Managers.
Hi, this is Molly Howell, Immunization Director for the North Dakota Department of Health, representing AIM.
Thank you. Association for Prevention, Teaching, and Research.
Richard Zimmerman, University of Pittsburgh, representing the association and present. Thank you.
Thank you. Association for State and Territorial Health Officials.
Morning, Dr. Lee. This is Nirav Shah. I'm the Director of the State of Maine Center for Disease Control and Prevention and the President of ASTO. Thank you.
Thank you. Biotechnology Innovation Organization.
Good morning. Phyllis Arthur, representing BIO.
Good morning. Thank you. Council of State and Territorial Epidemiologists.
Yeah, Dr. Christine Hahn, representing CSPE.
Thank you. Canadian National Advisory Committee on Immunization.
Good morning, Shelley Deeks, Chair of Canadian NACI.
Good morning, Dr. Deeks, and welcome. Infectious Disease Society of America.
Good morning. This is Jeff Duchin. I'm the Health Officer of Public Health, Seattle and King County, Professor in Medicine in the Infectious Disease Division, the University of Washington, and Professor at the School of Health, Public Health, University of Washington, representing the Infectious Disease Society of America.
Thank you. International Society for Travel Medicine.
Elizabeth Barnett for ISPM, present.
Thank you. National Association of County and City Health Officials.
Good morning. This is Matt Zahn representing NACHO, present.
Thank you. National Association of Pediatric Nurse Practitioners.
Good morning. Patsy Stinchfield representing NAPNAP.
Good morning. National Foundation for Infectious Diseases.
Good morning. This is Bill Schaffner, Professor of Preventive Medicine and Infectious Diseases at Vanderbilt and Medical Director of the NFID.
Good morning and thank you. National Medical Association.
Good morning. Virginia Kane, Director and Chief Medical Officer for the Health Department in Indianapolis and Associate Professor of Medicine in the Division of Infectious Diseases at Indiana University School of Medicine, and no conflict.
Thank you. Pediatric Infectious Disease Society.
Good morning, Sean Leary, representing PID.
Thank you. Pharmaceutical Research and Manufacturers of America.
Good morning, Corey Robertson, President.
Thank you. Society for Adolescent Health and Medicine.
Hi, good morning. It's Amy Middleman representing SAM.
Morning. Society for Healthcare Epidemiology of America.
Good morning. Marcy Dries, Chief Infection Prevention Officer at Christiana Care, representing SHEA.
Wonderful. And I'll just ask if there are any liaison organizations or individuals who joined after roll call.
Good morning, Dr. Lee. This is Dr. Matthew Clark, representing the Indian Health Service.
Thank you, Dr. Clark, and welcome. Okay. So with roll call now complete, we'll move on to the first session for the morning. During today's meeting, I will invite individuals to contribute to the discussion as always. Please raise your hands electronically and I will call on ACIP members first, followed by our ex officio members and liaisons. If you wish to respond to a particular comment or question, please try and indicate this electronically. And Dr. Matt Daly, chair of the COVID-19 vaccines work group, will provide an introduction and an overview of today's meeting. Dr. Daly, the floor is yours.
Well, thank you so much. So I'm going to introduce today's session on behalf of the ACIP COVID-19 vaccines work group. Next slide, please. So this is a graph that we have seen before. This presents the daily trends and number of COVID-19 cases in the United States for all ages from January of 2020 through October 28th of 2021. And as you can see, we're in the middle of a second wave, which is only exceeded by the wave we experienced in December of 2020. And there have been in the United States almost 46 million cases of COVID-19 that have been reported. Next slide, please. So to introduce the topic of burden of COVID-19 in children 5 to 11 years of age, just a couple points I wanted to highlight here. There have been 1.9 million cases reported in children of this age. In addition, there have been more than 8,000 hospitalizations, again, in this age group, and 2,316 cases of multisystem inflammatory syndrome in children, or MISC, and 94 deaths reported in children 5 to 11 years of age in the United States. It's also important to highlight the fact that the burden of COVID-19 in children in this age group extends well beyond these case counts. Just to mention a few factors, including school being tremendously interrupted and lives entirely disrupted. Next slide, please. So to describe the COVID-19 workgroup activities for the month of October 2021, the workgroup has been reviewing data regarding pediatric COVID-19 vaccines. This has included reviewing data on SARS-CoV-2 seropositivity in children, a detailed review of pediatric COVID-19 epidemiology. In addition, the workgroup has heard from Scenario Hub regarding modeling the results of impact of pediatric vaccination on the pandemic. In addition, we've had the opportunity to review the results of the Pfizer BioNTech clinical trial in children 5 to 11 years old. We have reviewed the grading of the scientific evidence regarding vaccination in this age group. And then we've had detailed discussion regarding the evidence to recommendations framework for the decision before us today. Next slide, please. So as folks are well aware, the Food and Drug Administration expanded emergency use authorization, or EUA, regarding Pfizer BioNTech COVID-19 vaccine to include children 5 through 11 years of age. To highlight a couple features of this, the pediatric formulation is a 10 microgram dose given intramuscularly, administered as a 2-dose series, 3 weeks apart. And we're going to hear much more about the evidence today, but to highlight a few points, in 5 to 11-year-olds, there were 4,600 participants in a clinical trial, and this was randomized 2-to-1, so 3,100 roughly received vaccine and 1,538 received placebo. In addition, we have the knowledge and experience gained by vaccinating more than 247 million individuals 12 years of age and older in the United States with Pfizer BioNTech in the 30 microgram formulation in the United States. And as those listening are well aware, this vaccine was fully licensed in people 16 years of age and older in August of 2021. And this licensure was based on longer-term follow-up data. Next slide, please. So here's the agenda for today. First, we'll hear a presentation by Dr. Gertman from Pfizer regarding Pfizer BioNTech BNT162b2 use in children 5 to 11 years of age. Following Dr. Gertman's presentation, we'll have a break, and this will be followed by public comment. After the public comment, we'll hear a presentation from Dr. Jones at the CDC regarding SARS.
Dr. Daly, I think your microphone cut out. Can anybody hear us?
I can hear you just fine, Dr. Lee.
Oh, thank you. Okay. Perfect. Thank you. We'll just try and get Dr. Daly back on the line. Just one moment. I'm just going to finish up for Dr. Daly. He's logging back in, but he was just going through the events for today. I believe we were at SARS-CoV-2 Epidemiology in Children by Dr. Jones. Dr. Matt Oster from CDC will discuss myocarditis in adolescents and young adults. Dr. Tom Shimabukuro will provide an overview of vaccine safety surveillance in children. Dr. Chatham Stevens will discuss implementation of COVID-19 vaccines pediatric program. After the break, we will then come back and return to Dr. Woodworth to discuss clinical considerations. And Dr. Oliver, as always, will take us through the evidence to recommendations framework for pediatric COVID-19 vaccines, followed by a vote. And I anticipate we will have robust discussion after each of these sessions throughout the day. So we appreciate everyone's patience. And would just like to clarify to get us started that, the overall discussion for today will follow the FDA emergency use authorization regarding the question of should we recommend the Pfizer-BioNTech BNT162b2 use in children 5 to 11 years of age. And so we look forward to having that conversation with the committee members today. With that, I think I am ready to turn it over to Dr. Alejandra Gertman from Pfizer. Oh, I apologize, our work group members. I just want to acknowledge the work of the work group. And, as many people have said in the past, we can't thank our CDC colleagues who have been leading this work throughout, the ACIP members and our liaison members and our expertise that is on the work group. It has been a very robust set of discussions that have led us to today. And it has been incredibly helpful for really focusing in on the data that's critical for decision making and making sure we have the information today we need as a committee to move forward. We can move to the next slide. And this extensive list of CDC participants, it really takes a village to be able to provide as much data as possible. It is clear that we always want more data and we always want perfect data, but we have the data we have today. We're very much looking forward to making sure we have a good understanding of what we need to move forward to make a decision. And I believe that is it. Next slide. Thank you. Okay, perfect. We'll move on to Dr. Alejandra Gertman from Pfizer to present on the Pfizer-BioNTech pediatric COVID-19 vaccines in kids 5 to 11 years of age. Dr. Gertman.
Good morning, and thank you, Dr. Lee and the ACIP committee for the opportunity to present today. My name is Alejandra Gertman, and I am in the Vaccine Clinical Research and Development Group at Pfizer. I am really pleased to present to you today the Pfizer-BioNTech clinical data that has received emergency use authorization in individuals 5 to less than 12 years of age. Next slide, please. I will focus primarily on the clinical data that demonstrates clear and compelling vaccine safety and efficacy that supported the EUA in this age group. Next slide, please. Pfizer-BioNTech received emergency use authorization of a 10 microgram dose of the vaccine for use in children 5 to less than 12 years of age. A lower dose of 10 micrograms was selected as the optimum dose for this age group based on favorable reactogenicity profile and robust immunogenicity results from a dose finding and a phase 2/3 study. The indication is for the active immunization to prevent COVID-19 caused by SARS coronavirus 2 in individuals 5 to less than 12 years of age, administered as a primary series of 2 doses of 0.2 ml each, 3 weeks apart. Next slide, please. I will share information with you today that the vaccine met EUA guidance for children 5 to less than 12. You will see that the vaccine met all safety data expectations as well as immunobridging criteria. 90.7 efficacy was observed. Plans are established for active follow-up of safety under the EUA, and the vaccine benefits outweigh these risks. Next slide, please, which is brief. I will now share with you the clinical data, and we can go to the next. We will begin by looking at the experimental design of the vaccine study. This began with a phase 1 to identify a preferred dose level based on immune response and a safety profile. The 10 microgram dose, 1/3 of the adult dose, was chosen because it had the right balance between immune response and satisfactory reactogenicity profile. This 10 microgram dose was advanced into a phase 2/3 with a randomization scheme of 2-to-1. Please keep this in mind when we're looking at both the safety and efficacy later. The first group of safety information includes approximately 1,500 individuals that received the vaccine versus 750 that received placebo. At the request of the FDA, we also enrolled approximately 1,500 additional individuals who received vaccine and 750 placebo recipients, most of whom have at least 2 weeks of safety data after dose 2. Non-inferior immune responses have been established comparing responses in children 5 to less than 12 to individuals 16 to 25-year-olds from the pivotal phase 3 study. Although not required for emergency use authorization, COVID-19 surveillance was conducted permitting evaluation of vaccine efficacy. Next slide, please. This represents a phase 2/3 timeline of participants in this age group. This scheme is similar to the scheme for other populations in which the doses are administered 21 days apart. Reactogenicity data was captured for 7 days, non-serious adverse events were captured for a month, and serious adverse events were captured for 6 months. To enhance possible detection of the rare event of myocarditis observed in adolescents and young adults, should it occur, specific instructions were provided to investigators to be vigilant for symptoms and signs of this condition, including chest pain, and to perform workup in the event of suspected myocarditis. Blood draws were obtained as shown to measure immune response, and as for nearly all our trials, we continue to obtain surveillance on the population to look for the potential to demonstrate efficacy, and this proved possible in this trial as well. On the next slide, please. This represents the 2 data sets that have been submitted to support the emergency use authorization. One is the initial cohort of 2,268 participants for which the median follow-up time is 2.3 months, which is shown at the top on the blue bar. In the latest submission, follow-up of this group has been extended as shown in the light blue. However, I will not discuss further this piece in this presentation. Additionally, as I mentioned before, and represented now in the slide by the lower bar graph, we also enrolled an additional cohort of 2,379 participants. In conjunction with the original cohort, this permits evaluation of a total of approximately 3,000 vaccine recipients to define rare events for at least 2 weeks for most of the 3,000 vaccine recipients and for 2 to 3 months for over 1,500 vaccine recipients in the submission done to the FDA. I will describe safety in the initial safety enrollment group first. In the next slide, please. Here are the demographics for those aged 5 to less than 12 in the initially enrolled safety population. Demographics for the additional safety group and efficacy population are similar. You can see that there was good representation in terms of gender, race, and ethnicity. The mean age of vaccination was in the middle of the age span between 5 to 11 at 8 years of age. More than 11% of the population had obesity as an underlying condition, and comorbidities, including obesity, were represented in approximately 20% of the population. Next slide, please. Shown here are local reactions by maximum severity within 7 days after each dose. Dose 1 is at the top, and dose 2 is at the bottom. You can see the reactions in the 5 to less than 12 age group compared to the 16 to 25. There is some increase in mild to moderate redness and swelling, both after dose 1 and dose 2 in the 5 to less than 12 age group. Pain and injection site was comparable between the two age groups, and in general, the local reactions meet a satisfactory safety profile. Next slide, please. Systemic events are shown in this slide by maximum severity within 7 days after dose 2 in children 5 to less than 12 compared to the 16 to 25-year-olds. Reactions were typically higher in vaccine recipients. Dose 1 reactions tended to be less frequent and are not shown in this presentation. The vaccine group is shown at the top of the graph and the placebo group at the bottom. I would like to draw your attention particularly to fever and chills. You can see that, if anything, the incidence of fever was lower and mostly mild to moderate in individuals who were 5 to less than 12 compared to the older age group. And this was true for chills, and likewise, across the other systemic event parameters, you can see that responses were comparable or less to those seen in the 16 to 25-year-olds, again representing a satisfactory systemic reaction profile for 5 to less than 12-year-old children. Next slide, please. Now I am showing you local reactions by maximum severity within 7 days after each dose by baseline SARS-CoV-2 status. Again, dose 1 is at the top and dose 2 is at the bottom. You can see that local reaction rates were very similar regardless of baseline status, with a slight increase after dose 1 in participants who are SARS-CoV-2 positive at baseline, which is similar to what we have seen in the adult pivotal study. And in the next slide, please. When looking at systemic events by maximum severity within 7 days after both doses, you can see that there are almost no differences between the two doses regardless of the baseline SARS-CoV-2 status. I will now, if you go please to the next slide, we'll review the unsolicited adverse events. And next again. Thank you. This graphic represents overall adverse events from dose 1. The initial enrollment group is shown at the top, and the safety expansion group is shown at the bottom. In both groups, you can see comparable levels of any adverse events or related adverse events. There were very few serious adverse events and no related SAEs and no deaths. One female participant was withdrawn from the study due to a fever of 40 degrees centigrade on day 2 after the first dose, accompanied by neutropenia. The fever resolved in 1 day. This child carries a pre-existing diagnosis of benign neutropenia, and she's been followed by a hematologist, and she recovered uneventfully. Next slide, please. This now represents adverse events occurring at an instance of greater than 1% by system organ class for this age population in the initial enrollment group. You can see comparable rates between vaccine recipients and placebo recipients, whether we're talking about any adverse event or any of the categories specified underneath. This again reflects a satisfactory safety profile in events common to this age group. Lymphadenopathy has been infrequently observed in other populations after vaccine, and it was observed in 0.9% of vaccine recipients in this enrollment group. Next slide, please. This now represents comparable analysis of adverse events, but now I'm showing you the safety expansion enrollment group. And you can see that the rates are very similar between vaccine and placebo as in the initial group. And again, in our opinion, representing a satisfactory safety profile. Next slide, please. And if we want to look at the rates of adverse events from dose 1 to 1 month after the second dose by baseline SARS-CoV-2 status, you can see that the rates are very similar or a little lower in those who are positive compared to those who are negative prior to vaccination. Next slide. Serious adverse events from dose 1 to the cutoff day are shown here for both safety groups. All SAEs were considered unrelated. 3 events are related to trauma and 1 related to the ingestion of a foreign body. In the expansion safety group, 1 participant reported infective arthritis of undisclosed etiology 15 days after dose 1. It resolved 21 days later. Next slide, please. We follow participants for adverse events of special interest as designated by either the FDA or the CDC. Summaries for both enrollment groups are shown here. For FDA adverse events of special interest, no anaphylaxis, no myocarditis, no Bell's palsy, and no appendicitis were reported. For the CDC adverse events of special interest, angioedema and hypersensitivity were uncommonly observed in both vaccine and placebo recipients, and they were short-lived. Rashes tended to be more common after vaccine, but in general, they were uncommon. Overall, they were mild and short-lived as well. The 1 case of arthritis is the infective arthritis I already described to you. And there is a case of vasculitis, which was reported as a mild case of henoch-shunite purpura, considered unrelated to vaccine, that occurred 21 days after dose 1, and follow-up of this child is ongoing. In the next slide, I will want to show you the safety conclusions for the 5 to less than 12 years old. Reactogenicity was mostly mild to moderate and short-lived. Observed mild to moderate local reactions, redness, and swelling, which were captured by the e-diary, were more common, and systemic reactions, including fever, were less common than those in the 16 to 25-year-olds. The observed adverse event profile in this study did not suggest any safety concerns for BNT162b2 vaccination in children 5 to less than 12. The database of approximately 3,000 enrolled active vaccine recipients provides a high degree of confidence for the following rare events proximate to vaccination, such as myocarditis or anaphylaxis, and are unlikely to occur at the rate of 1 in 1,000 or higher. In the next slide, I would like to turn now to the examination of the immune response to the vaccine. Next slide, please. Immunobridging criteria comparing the 5 to less than 12-year-olds to the 16 to 25 were met, both for the geometric mean ratio and for the sero response as shown on this slide. SARS coronavirus 2 neutralizing antibody titer is represented at the top. You can see the geometric mean titers represented after the second dose in the middle 2 columns in blue. The geometric mean ratio of 1.04 is shown on the right-hand side with the lower bound of the confidence interval well above the 0.67 criterion. The observed GMR was above the pre-specified criteria of 0.8 and also above the GMR of 1.0 requested post-hoc by the FDA. In addition, seroresponse rates are shown at the bottom. You can see the seroresponse rates were virtually identical in the 5 to less than 12 age group compared to the 16 to 25 at 99.2% apiece. And this criterion was also made with a lower confidence bound value of -2%, well above the -10 that was required. In the next slide, please. Shown here are the GMTs by baseline SARS-CoV-2 status. You can appreciate that titers are higher in those who are positive at baseline, which is shown in the middle panel in green, compared to those who are negative on the right. Please keep in mind that the number of positive participants in this subset is relatively small. And in the next slide, when looking at GMTs by age subgroup, you can see that titers are virtually identical across all ages, whether 5 to 6, 7 to 8, or 9 to 11. Next slide. It was also important and requested by the FDA for us to look at the response to the Delta variant, given its prominence as a cause of COVID-19. As we have seen in older populations, the responses were quite robust. not only to the wild type shown on the left-hand side, but also to the Delta variant on the right. This is done in the subpopulation of 34 individuals that were studied. Please note the comparable post-vaccination titers at 1 month for the wild-type vaccine strain and for the Delta variant, with high geometric fold rises shown at the top. This comparable response predicts efficacy for the 5 to less than 12 age group during a time when the Delta variant is prominent. And in the next slide, you will see that high efficacy against COVID-19 was in fact observed when examining COVID-19 occurrence from 7 days after dose 2. Remembering that the randomization in this study was a 2-to-1 vaccine versus placebo, the case split of 3:16 with surveillance time shown, it is an efficacy of 90.7 with a high degree of confidence shown as well. No severe cases of COVID-19 or multi-system inflammatory syndrome in children were reported in either group. Note that the cases occurred in July to September when the Delta variant was the most prominent variant in circulation. At this time, 14 of the 19 samples had been successfully sequenced and all yield the Delta variant, confirming high efficacy against this highly transmissible strain of SARS-CoV-2. In the next slide, I would like to show you the curve with cumulative incidence of all available COVID-19 cases beginning after dose 1. The mean length of follow-up time after dose 2 is 3.3 months. The placebo cases are in red, vaccine cases are in blue. Efficacy was durable for this period of follow-up to date, and surveillance is continuing. In the next slide, I would like to summarize the immunogenicity and efficacy conclusions. Immunobridging success criteria were met for 5 to less than 12 years old compared to the 16 to 25-year-old group. The vaccine immune sera effectively neutralized both the wild-type vaccine virus as the highly transmissible Delta variant of concern. BNT162b2 as a 2-dose series demonstrated high efficacy against COVID-19 in this population of 5 to less than 12 when the Delta variant was prominent. Next slide, please. Pharmacovigilance activities are a critical component of activities to detect unexpected safety events rapidly. Pfizer continues to conduct robust pharmacovigilance activities and collaborate with regulators and international groups. Proactive risk mitigation activities such as labeling, educational materials, and biodifferentiation will continue. Pharmacoepidemiology studies will include children 5 years and up to evaluate for myocarditis occurrence and sequela, as well as other possible rare adverse events. This includes one study that will follow up identify U.S. post-vaccination myocarditis and pericarditis cases for 5 years within the Pediatric Heart Network. And in the next slide, I would like to conclude my presentation by acknowledging and thanking all those who made this possible. The clinical trial participants and their families foremost, the sites, investigators, the CRO, our partner and their staff, and the FDA for the guidance to help us assess and address these urgent medical needs. Thank you.
Thank you, Dr. Gertman. This session is now open for questions. I see Dr. Long's hand is raised. Dr. Long?
Yes, 2 clarifying questions. One is, what were the dates of the studies so that we can understand the prevalence of and which strains of the virus were circulating at the time? Maybe answer that, and then I have one follow-up question, if that's okay, Dr. Lee, about the same thing.
Of course.
Thank you, Dr. Long. The study, the phase 1 study, which was the dose finding, was initiated in March, but the phase 2/3, which is the data that I presented mainly today, the study was started at the end of June, and the cutoff day for the data that I showed with the cases was October. So it's really, and considering the 2 doses that we were given is mainly July to September is when we saw all the cases.
Okay. So the second question is, I see that you said day one, I assume, and you gave some neutralizing antibody geometric mean titers. And I saw that what I must understand then is pre-dose 1 titer of 10. And I am a little surprised about that, because if it were truly negative, wouldn't you have assumed a lower titer? So my question is, I know you did not try to enroll patients who had previously had coronavirus infection, but the question is, what percentage of patients had antibody prior to dose 1?
Thank you for the question. So the prevalence that we had in the study between the placebo and the active vaccine recipients was between 8.7 and 8.8. So we did allow for prior infection, and we also did, PCR swabbing and binding protein prior to the first vaccination to determine the seroprevalence, and the rate was about almost 9%.
Okay. And then when you calculated your vaccine efficacy, I didn't quite understand the title of the slide and the data. Did you, in that, only include those who were seronegative at first vaccine, or did that include the 9% who were seropositive?
Yeah, so the data that I show you is in those who were seronegative. However, we did look at both seronegative and seropositive, and the vaccine efficacy is virtually identical because there were no additional cases in the seropositive children.
Thanks very much.
Thank you. We'll move on to Dr. Paling.
Thank you, Dr. Gertman, for this presentation. And I also want to say thank you for making sure the enrollment included diversity. I think that's really important. My question for you is, I believe you showed us the immune response across age groups, and that was similar. My question is, did you look at the safety, local and systemic effects by age group as well? And what did you learn?
So thank you, Dr. Paling, for the question. We did look at both safety and immunogenicity by age groups, and as much as we didn't see almost any difference in immunogenicity, there were no differences in safety either.
Okay. And then the second question I have for you is I wanted to learn a little bit more about lymphadenopathy. That was, I believe, 0.9% of the original cohort. And can you share the characteristics of that lymphadenopathy, please?
I lost your voice. If I can share on the second cohort, is that the question?
Could you share the characteristics of the lymphadenopathy you saw in the trial, please?
Yes. So as I mentioned, in the initial cohort was 0.9%, and in the expansion safety cohort was 0.4%. The characteristics were, and I'm trying to pull one of my slides. If you just give me 1 second. So in the 0.9, 13 participants in this age group reported lymphadenopathy, and most of them were in the vaccine recipient group. 9 of them were being related by the investigators. The mean onset was 2.6 and 6.2 days for the first dose and for the second dose, and the duration was 4.7 days. And all of them were restored by the time of the initial safety data cutoff, which was September the 6th.
Dr. Gertman, which slide was that? Would you be able to, is it a slide we have that we could post?
Oh, no, sorry, this is in my backup slide for myself for notes.
Okay, thank you.
I'm happy to share after.
Thank you. Dr. Paling, any additional questions?
I will turn the floor over to others.
Thank you. Dr. Sanchez.
Thank you, and thank you for that presentation. Certainly exciting results. A few questions. First of all, I'm interested in the ones who previously had, who had tested positive for SARS-CoV-2. I assume that none gave the history of having been positive because you were trying to enroll those who have not had COVID before. First of all, is that correct?
Well, so in the phase 1 part of the study, we didn't allow for prior diagnosis of COVID-19. However, on the phase 2-3, we did allow for children to be entered into the study. So the majority of the 8.7 that I referred is actually either serology or PCR testing. But there were a number of children, not many, and I have to go back. Maybe I can ask if one of my Pfizer colleagues has that number. But there were less than 20 kids, I can tell you that with some certainty, that carry a diagnosis of prior COVID-19.
So that was not a definite exclusion?
No, it was not for the phase 2-3.
Okay. And then in your slide 24, when you look at the SARS-CoV-2 positive before and then geometric mean titers, there's actually quite an increase. I mean, it's really quite high after dose 2. Do you have data after dose 1? I guess my question is there's an amnestic response that do all these kids need 2 doses, or do past ones, would they, and I know that there's few of them, but do you have data on the geometric titers after dose 1 to see if the amnestic response is as similar as those who were seronegative after the second dose?
So no, we don't have the data. We try to minimize the number of bleeds to ensure that kids, and their families wanted to be part of the study. And so we only have the baseline and the 1 month after dose 2. So I'm not able to answer that question from this particular study.
And then another question. So generally these were healthy, but some had some risk factors, which you mentioned the majority were obese. And did you have any immunocompromised patients at all?
So to answer the first part, about 11% of the children had a diagnosis or, by BMI of obesity, 20% overall comorbidities. The most common comorbidity after obesity was asthma, with about 8%. And by design of the study, we did not allow for children who carry a diagnosis of being immunocompromised to be allowed to be part of the study. However, we are conducting a study in immunocompromised children, which will expand the whole age group from 2 years of age all the way to 18. And depending on the age group, we will have different doses according to what has been now either under the EUA. So hopefully we have that data in the future. And that study will include a third dose as a booster, but not in this one.
And among the obese patients, and I'm sorry, Dr. Lee, I hope that this is okay.
Okay. Go ahead, Dr. Sanchez. We want to make sure all your questions are answered.
And in terms of the obese patients, did you see any change in the geometric mean titers between the obese ones versus those who were normal, were not obese?
I may ask Dr. Gruber if he's online, if he remembers if we have done that analysis, because honestly, at this time, I don't remember.
Yeah, hi, this is Bill Gruber, the head of Vaccine Clinical Research and Development. And yes, we have looked at that. I think maybe John Perez may be on as well, and did not see a difference. I might just add that my recollection too is that in terms of looking at outcomes, we didn't have, as I recall, individuals that were obese in terms of cases in either group. But I think the 3 cases that we had in individuals with underlying disease, all of whom were in the placebo group, had asthma. But others can correct me if I'm wrong about that.
No, that's correct, Bill. Thank you.
Okay, thank
Then
you.
finally, and this has come up from a practical standpoint, did any of your patients turn 12 at the time of the second dose? And if they do, would you recommend that, or did you give them the usual dose, or any recommendations from your company and from your experience as to whether that dose should be increased if they reach, with the second dose they turn 12?
Yeah, so we did have children who turned 12. I believe that we have about 7 children. All of them received a second dose of 10 micrograms. So the study was designed knowing that this could happen and with the intention that the second dose will mimic, will be the same as the first. And in terms of recommendations for, what to do with this situation, I will leave that to maybe the ACIP committee to make recommendations. But we did have that.
Thank you, Dr. Gertman. Thank you, Dr. Sanchez. I just want to make sure I understood that. So those who were per protocol stayed on the 10 microgram dose, even if they changed age during the middle of the trial.
That's correct.
Okay, thank you. That's very helpful. Actually, while we're on this slide, I'm just going to make one quick comment, which is on slide 24. I actually think it's really helpful that the neutralizing titers were captured specifically on day 1, because if you look at the SARS-CoV-2 positive patients, their titers are actually not that high, which I think is really helpful to us to understand that boosting that immune response could be of a significant benefit to those children. And I'll also just highlight that a comment made earlier about age-specific sort of breakdown in terms of safety profile would similarly be helpful. If you go to slide 25, I really appreciated that you did this for immunogenicity. A parallel slide for safety, I think, would be really helpful for clinicians as well. We'll move on to Dr. Paling.
Hi. I wanted to follow up on a little bit of what we were just talking about. One of the questions that I have is, could you describe the level of obesity that was included in the trial?
Thank you for the question. We use the definitions for BMI. I am not able to describe farther than that 11% actually met criteria according to BMI for this age group.
Okay. Yeah, I think, this is Bill, maybe just Bill Gruber again. I think it's actually at the bottom of the slide, slide 9, where BMI had to be greater than the 95th percentile, if I'm reading that right.
Okay. So that's how you defined it, but you didn't get into the grades of obesity, if I understand it correctly.
We didn't, no.
Okay. The other question I have is, on your slide showing the COVID positivity among people, the children who received the vaccine and those who received the placebo, were any of those children hospitalized?
No, we didn't have any hospitalization or severe disease in this age group.
Okay. And then the second question is, I believe it looked like 3 children tested positive for COVID-19 who were vaccinated. Can you please describe those cases, and were there anything that predicted that breakthrough disease?
Yeah. So the 3 cases in the vaccine recipients actually had no comorbidities. They had the onset time after the second dose was somewhere between a month to 32 days to 91 days. The symptoms lasted for 2 to 9 days. However, in these 3 age groups, which is really important, is there were no fevers compared to about 62% of the kids who had a fever in the placebo group. And when we look at the number of symptoms, so in these 3 cases, the symptoms were mild and only 2 symptoms were mainly cough and a sore throat. And when you look at all the placebo cases, more than 50% of the placebo cases actually has 5 or more symptoms. So it seems from the description and the information that we have that clearly the cases in the vaccine recipient group were milder with no fever. and especially when you compare them to the placebo.
Thank you. We'll move on
Does
to.
that answer your,
Oh,
does that
sorry.
answer your question? Sorry.
Yes, it does. Thank you.
Thank you. I think I'm going to ask if the hands that are raised, we have 4 more hands raised, and I'd like to ask if you could just keep it to 1 question each. Dr. Long.
Yes, it's a question about those who were seropositive at the beginning. So now that we know that you looked at the efficacy separately for those who were seropositive at the beginning, and you said I think you said quickly there were no cases in the vaccinated. Were there cases in the placebo group who were seropositive on the day of vaccination? And then the adjacent question is, in those who were seropositive on day 1 of vaccination, did you see any difference in reactogenicity between those who were seronegative and seropositive? So cases in seropositive placebo recipients first, and then reactogenicity.
Yeah, so I'm going to start with the second part, which is Dr. Long, with the reactogenicity, and as I shown to you, there were very minor differences between those who were SARS-CoV-2 positive and negative, as we have seen in adults, maybe a slight increase after dose 1 compared to those 2. And in terms of cases in seropositive subjects, I believe that we didn't have any, but I'm going to ask Dr. Gruber again just to confirm what I'm saying.
Yeah, so again, Sarah, obviously, I think you're getting at the nature of in this population where those individuals protected. Obviously, it's a relatively small sample, but there were no individuals in seropositive children, either in the vaccine group or the placebo group. And that's why, frankly, the efficacy in terms of documents we submitted to the FDA, when we talk about without prior infection yields an efficacy of 90.7%, and the with and without yields 90.7% because we had no cases in either group.
Okay, and in the approximate number in the placebo group seropositive was what?
So the rate was about 8.8% of seropositive in the placebo group.
No, I'm talking about what number was the N for the placebo group who were seropositive who did not get disease in your follow-up period? Sorry. Are we talking about 100 or are we talking about 20?
Yeah, I think
perhaps
again, that would be essentially the entire denominator of the placebo group, right? That were seropositive. So what, 10% or so, that'd be about 75 individuals in that group, and in the vaccine group would be about 150. You know, I mean, it may be a little bit less than that, since 8 to 9%, but that gives you a rough ballpark figure.
Okay, that's what I thought. Thank you.
Thank you. And if you could, we're happy to let the team comment after, but I just want to get through these questions because we have to get to the next session. So if our colleagues could just ask 1 question each, I'm going to go to Dr. Grog, who's been waiting patiently.
Yeah, well, thank you for the presentation, Dr. Gutman. I just had more of a comment than a question, and that is how do we, somewhat of a question, how do we explain to our parents that there's only a couple thousand participants in a particular study? And I congratulate you on your further studies, and excited to see what events show in the future, especially with the immunocompromised. So thank you.
Would you like me to address, thank you, the comment about how to explain to parents? I think that probably will be discussed later. I can share with you that actually the study was recruited in record time. Obviously, as I mentioned to you, this was happening during, the Delta variant and, high and at the peak probably. We had no problem actually recruiting this age group. And after the FDA requested for us to expand to the new safety group of another, 2,250 kids, we were able to do that in less than 2 weeks. So and the study actually, as I explained and showed to you, number one, we have shown, not only non-inferiority, but actually vaccine efficacy. And I think that with great degree of confidence, we know that this vaccine will be protective. And in terms of safety, the study, as I mentioned, has the 3,000, the N of 3,000 on the vaccine recipients. And obviously with all the activities that will be carried by CDC and by us and other groups in terms of looking at, adverse events following vaccination, will have to come from real data. I will hope personally that the parents are feeling as they felt when they wanted to enroll the kids in the study. But I will leave that to the discussion later today.
Dr. Fink, did you wish to make a comment?
Sure. I just wanted to make sure that it's understood that the safety database size for this age group that supported the emergency use authorization for use of the vaccine in this age group really is at the upper end or even beyond of the safety database size that has supported licensure of other preventive vaccines for infectious diseases for use in pediatrics. And you can add to that the extensive experience that we've had to date with the vaccine in older age groups as well. Thank you.
Thank you, Dr. Fink. Ms. Stinchfield?
Yes, thank you, Dr. Lee. Dr. Gertman, thank you so much for this encouraging data. I have more of a comment on slide 11 related to fever and chills. I was very happy that you emphasized that in this age group, the 5 through 11 or less than 12, that fever and chills is uncommon and certainly less than the 16 to 25-year-olds. And the reason I think that is important to call out is that there are many people who choose to either not get vaccinated or delay vaccine because they frequently will hear either from clinicians or on the media that your common side effects are fever, chills, and body aches. And when you look at the data, that is actually not correct. That the most common, of course, is you see the pain at the injection site, fatigue and headache. And I do think it's important for all of us as we care for kids and families to be evidence-based in what we're asking families to expect. And fever is a very uncommon symptom. So thanks so much for pointing that out.
Thank you. We'll move on to, did you wish to make a comment?
Oh, no. I fully agree with what was said. No, thank you.
Thank you. Dr. Freihofer.
Sandra Freihofer, American Medical Association, speaking as a practicing physician. And I'm thinking about the questions that my patients ask me when they come into the office. On slide 10, I think I might have misheard you. My understanding from looking at that is the side effects are less in those that are seropositive. But the big question I wanted to ask was one that was actually brought up at the FDA meeting and alluded to earlier. If a child's 11 years old and they're about to turn 12, should they go ahead and get the 10 microgram dose now or wait until they're 12 and get the 30 microgram dose? Dr. Gruber showed a slide at the FDA meeting, but it was so blurry I couldn't read it. And I would greatly appreciate if you could show that slide so I could, and maybe I could take a look at the data. Thank you.
Thank you. Before you respond, I just, we discussed what the trial contained. I don't know if Dr. Fink, I'm going to put you on the spot, apologies, could just make a brief comment about what FDA has authorized based on the trial data.
Sure. So what FDA has authorized is that either the 10 microgram formulation that is authorized for use in ages 5 through 11, or a 30 microgram formulation that is authorized for use in ages 12 and above can be used for either dose 1 or dose 2 in the situation where a child will be 11 years old when they are set to receive dose 1 and then turns 12 before they are set to receive dose 2. Of course, the most data-driven approach, the approach for which the data are actually available, would be for a 10 microgram dose be given to a child who is 11 at the time the dose is administered, and for a 30 microgram dose to be given to a child who is 12 at the time that dose is administered. However, FDA did recognize that there may be some situations in which there would be a need for flexibility, and the totality of data did support this more flexible approach where there would be a change in age occurring in between the 2 doses. And it's up to CDC to make an ACIP to make whatever they consider to be the most appropriate recommendations for implementation of the doses such as they're authorized.
Thank you, Dr. Fink. And Dr. Freihofer, there will be... Oh, Dr. Freihofer, just one moment. There will be a whole discussion and presentation specific to this issue later this afternoon in the clinical considerations. Would it be okay in the interest of time if we come back to your question in the afternoon when we can have a more full presentation?
Sure. And would they be able to show that slide with the data?
This slide 25 that's up here now?
No, there was a slide that they showed that Dr. Gruber showed at FDA that addressed that question, that compared the neutralizing titers at age 11 to those with getting a 10 microgram dose, with those at age 12 to 15 getting a 30 microgram dose. That's the slide.
So I Dr. Lee, if that's okay, I have that slide, but the one in the backups,
Which slide number is it?
Hold on a second, maybe to go to my own.
If need be, we can always come back to this later in a later session, just in the interest of time. I will put this on our question list to come back to perhaps ask Pfizer to respond to if need be. But why don't we go to the last question, which is Dr. Kane, while you're trying to identify that slide.
May I comment just, even if we don't have the slide, and I'm happy to refer to this later. That slide actually that Dr. Gruber showed it reflects the phase 1 part of the study, where we did compare the younger kids to the 16 to 25 as well as the 12 to 15. And I'm happy to point that to you later so you can show it in the afternoon.
Thank you, and it's also available on the FDA website. So in the meantime, let's go to Dr. Kane, who has the last question for this session, and then we will take a break. Dr. Kane. Dr. Kane and then Dr. Sanchez, and then we'll take a break. Dr. Kane, we can't hear you. You're still muted. Okay. We'll move on to Dr. Sanchez.
Thanks, Grace. I just have a quick question. I assume that no concomitant vaccinations were given to these children. What was the time period? And are you planning studies looking at concomitant vaccines in these age groups? Thank you.
Thank you for the question. Yeah, so no concomitant vaccines were administered during the study. It was a temporary delay criteria if somebody received one. We are considering doing some concomitant vaccine studies, although CDC now has a recommendation that vaccines can be given at the same time. So at the present time, we don't have any additional data in this age group for concomitant administration of this vaccine with others.
Okay, thank you. Dr. Kane?
So yes, I maybe should wait for this question for later, but I was concerned about, because we have such a high rate of obesity in African Americans, the question has to be that if I'm getting close to the 12 years of age because of the high rate of obesity, should I be waiting to wait till I get to 12 years in order to get the larger dose, where I may have a much more prolonged and higher rate of geometric mean titer because of that significant overweight that I'm sure it's greater than a 30% in our African American children?
This is Dr. Oliver.
We also have significant comorbidities associated with as well. It's like a double whammy.
Yeah, this is Dr. Oliver. I just want to highlight that we will be having a presentation this afternoon on the clinical considerations that will get into, proposed.
I will wait for that this afternoon and bring it up again. Thank you.
Okay, promise. Thank you. Just wanted to make sure people were aware. We'll have this where we'll address kind of these variety of scenarios and propose CDC guidance. Thanks.
Thank you. And so if you didn't get your question answered, I promise we will offer opportunity for questions later in the day. Right now, I would like for the committee to take a break. Let's take a break till 30 minutes after the hour. Thanks, everyone. We'll recess. Thank you, everyone. It is now 12:31 p.m., and we will now reconvene the meeting to begin public comments. I'd like to welcome and thank our public comment speakers for addressing the committee today. All the speakers submitted a request in advance of the meeting, and the final list of public commenters was determined via a lottery. For our speakers today, we have a limited public comment period, and in order to make it through all of the listed speakers, it's extremely important that each speaker limits his, her, or their remarks to 3 minutes. We will be displaying a timer on the screen so you know how much time you have left. And as a reminder, our committee appreciates diverse viewpoints that are respectful in nature and focused on the issues instead of comments directed at individuals. We thank you again for your willingness to provide public comment, and we look forward to hearing your comments. Our first public comment speaker for today is Mrs. Christina Dietrich. Mrs. Dietrich, are you on the line?
Hello, yes I am. Can you hear me?
Yes, please go ahead.
Okay, great. Thank you so much. Oh, 1 second, I'm sorry. I speak on behalf of Delaware Moms Oppose Mandates. Like most of us, I vaccinated my 4 children right on schedule. We trusted pediatricians, FDA, and the CDC. The response to COVID has shattered the trust that many Americans used to have. We're confused and upset. We see FDA members resign, facing political pressure to make approvals. We sounded the alarm on myocarditis long before you acknowledged it. We're told not to trust our lying eyes with a barrage of talking points. There are lies, damned lies, and statistics. This week, Director Walensky said, those unvaccinated with the recent infection were 5 times more likely to have COVID-19 than those recently fully vaccinated without prior infection. Sounds pretty definitive, but actually, among adults hospitalized for COVID-like illness, those with lab-confirmed COVID in the same hospital system within 3 to 6 months were more likely to test positive for COVID-19 than those who had an mRNA vaccine within 3 to 6 months. Can you really extrapolate that to the general public? On the same day, the CDC website was updated to include a systematic review and meta-analysis, which found no significant difference in the level of protection provided by infection as compared to vaccination. When the agency, politicians, and the press tout the hospital MMWR and ignore the meta-analysis, parents wonder when else they promote or ignore research in order to advance a narrative. Immunity is a very salient point in your deliberations today. We know that as of June, the seroprevalence for these kids was 42%. What is it now in November? Parents are already being forced to vaccinate their children in order for them to participate in certain activities. Their risk is so low, and many are immune. They don't do it for the health reasons, but for social consequences. I today propose a compromise. Doses are sent out. We know you will approve this. We beg you to say that kids 5 to 11 may receive the vaccine, not that they should. Otherwise, your approval will be used to enact mandates unjustified by an EUA. They will mandate without evidence that it reduces severe disease or death in children, when it doesn't prevent transmission and the effectiveness wanes over time, when the dosing schedule is suboptimal, when a new buffer is being used, not the one from the trial, when 40% of hospitalizations in these kids are incidental and the remaining 70% of kids have a comorbidity. You won't even acknowledge that the risk-benefit ratio is different for healthy children versus those with risk factors. There are enough unknowns that parents should be able to wait for more data without suffering pressure and coercion. Mandela said that there can be no keener revelation of society's soul than the way in which it treats its children. Our children have given up so much. The benefits of this vaccine for kids are minimal. There are also risks. Protecting the community is not their job. We do not sacrifice the health of a single child to protect adults. That is counter to our nature. Please say that the children may receive the vaccine and not that they should. Words matter. Thank you so much for your attention, and I appreciate the work you're doing today.
Thank you for your comment. And we'll move on to Ms. Patricia Neuenschwander.
Thank you for allowing my public comment today. My name is Patricia Neuenschwander, and I have been a nurse for 27 years. I am not sure if there is anything I can say to you today to reach you, but I must try. Pfizer's clinical trials did not detect any health benefit at all from their shots. They did not prevent a single hospitalization, ICU visit, MIS-C case, asymptomatic infection, nor death in the treatment group. There was a total of 19 mild infections out of 2,300 children. The injection has not been shown to stop transmission or infection. In a meta-analysis combining from 11 countries, Stanford researchers found that children 0 to 19 infected with COVID have a 99.9973 survival rate. This is a mild illness in the vast majority of children. The science being used for this are small studies using immunobridging, short follow-up times, vaccinating the control group as soon as possible, and excluding any immunocompromised or significantly ill children. It is estimated over 40% of children have already been infected. Prior natural immunity is being ignored. We don't know if giving this vaccine after infection is safe or the consequences to the immune system post-infection. Does it destroy the natural antibodies that you created? Does boosting those antibodies impair the innate immune response to future or other infections? Pfizer's clinical trial in kids was intentionally undersized to hide harms. If the rate of a particular adverse outcome in kids is the result of the shot is 1 in 5,000, the trial only enrolls 1,500, then you are unlikely to spot any particular harm. Supplemental data was obtained from an expansion group of another 1,500, but that data was only followed up for 2 weeks. The follow-up period is intentionally too short. 2 months of follow-up will not provide information on the immediate or long-term safety of this experimental shot. Vaccine effectiveness was inferred by immunobridging data from 16 to 25-year-olds, or junk science. You know this injection will kill and maim some children, some immediately, some in the intermediate, and some in the long term. You know that if you make this general recommendation for all children, it will be viewed as a mandate for all children ages 5 to 11. You can say no. The science does not support this as safe or effective in preventing serious complications or death. Please use your critical thinking, your wisdom, your experience, and be brave. Admit that this data does not support injecting perfectly healthy children. If you listened to the discussion from FERBAC meeting last week, you heard several of the committee members had concerns. They were hesitant to recommend the full authorization of this. There is no amount of money, career advancement, or prestige that will make up for the crime against humanity of you recommending this experimental intervention on innocent, healthy children. May God have mercy on the souls of the millions of children who will receive this based on your recommendation.
Thank you for your comment. Your time has expired.
Children. Please do not recommend this for children. Thank you.
We will move on to the next public comment. Speaker, Dr. Andrea Klein-Tilford.
Greetings. I am Andrea Klein-Tilford, and I do not have any conflicts to report. I'm a pediatric nurse practitioner and the president of the National Association of Pediatric Nurse Practitioners, NAPNAP, a professional organization representing more than 8,000 pediatric-focused nurse practitioners. We support the timely and complete immunization of all infants, children, and adults in an attempt to maximize the health and well-being of all people. The last 20 months have brought immense strain to the world, including our nation's more than 20 million 5 to 11-year-old children. Our children have been pivoting in all areas of life. Children can and do suffer acute illness, multi-system inflammatory syndrome, and long-haul physical symptoms from SARS-CoV-2. Data shows children of marginalized racial and ethnic groups have suffered greater disparities. The strain has been immense and has resulted in mental health challenges that will undoubtedly have lasting impacts on social, emotional, and mental health. In a poll conducted by researchers in Chicago, 71% of parents or caregivers believe the pandemic impacted their child's mental health. Pediatric nurse practitioners are on the front line in primary and acute care settings, encountering these challenges in our children each and every day. There has been an alarming increase in child and adolescent anxiety, depression, and suicide. According to the CDC, mental health-related emergency department visits by adolescents increased 31% in 2020. At one point during the pandemic, emergency department visits for suicide attempts in girls 12 to 17 years of age was up 51% from 2019. Eating disorders, serious and sometimes deadly, have increased 62%. And more than 140,000 children have lost a parent or caregiver during the pandemic. Children have paid a significant toll associated with COVID-19, and we have the ability to alter this trajectory. Right now, we rely on masking, physical distancing, hand hygiene, and surrounding children with adolescents and adults who are vaccinated. Without other options, these strategies were acceptable, but are not a long-term solution and leave a tremendous gap in protection for our children. NAPNAP urges the ACIP to authorize the Pfizer-BioNTech COVID-19 vaccine for all children 5 to 11 years and supports widespread equitable rollout to every eligible child in the U.S. using all possible vaccination sites, including primary care offices, schools, pharmacies, pop-up sites, and mobile units. COVID-19 vaccination is safe and effective, and with the adjusted dosing for children 5 to 11, we can protect our school-age children immediately to further shield them from short and long-term physical and mental health consequences and to reestablish more ordinary daily activities. Let's use the newly provided data on the Pfizer-BioNTech COVID-19 vaccine to deliver comprehensive, equitable immunization to all children 5 to 11 years of age. NAPNAP offers provider and family-focused resources about COVID-19
Thank you for
vaccination.
your comment. Your time has expired.
NAPNAP.org.
Thank you. We'll move on to Mrs. Tia Severino.
Yes, this is Tia Severino. I appreciate the opportunity to speak today. I requested to speak after watching the FDA VRBPAC meeting last week. I was heartbroken and outraged at the vote to recommend this vaccine despite legitimate concerns raised by voting members about unknown adverse events and known events such as myocarditis, which has already been observed in 12 to 17-year-olds at startlingly high rates, especially for boys. One member even said, "We won't know the rare events until we start giving the vaccine." This is not okay. The adverse events, which are underreported, are very disturbing. VAERS data as of October 22nd shows 17,619 deaths, 86,542 hospitalizations, 8,656 heart attacks, 2,712 miscarriages, 27,277 permanent disabilities, and 10,956 cases of myocarditis, pericarditis, and this is just scratching the surface. By recommending these vaccines, which are still under emergency use authorization, you are paving the way for mandates in workplaces across the country and in schools. This is an illegal emergency use authorization because there are effective alternative treatments for this virus, which has a greater than 99% recovery rate. I'm begging you to do something you've never done before. Vote no today. There is no reason to give this vaccine to children who are not at risk for severe COVID. We have already seen severe adverse events in the vaccine in the 12 to 17 age group. I will share one with you now. Maddie DeGuerre, a 12-year-old girl, was a participant in the Pfizer COVID trial. Previously healthy, energetic, and full of life, now she is confined to a wheelchair and has to be fed through a tube in her nose. She has been hospitalized numerous times. Maddie and her family have been ignored and dismissed by Pfizer and the CDC. Her voice matters. As the vaccine mandates roll out and people are losing their jobs over a personal medical choice that is their right, it appears you have found a way to get rid of the shaky front line of healthcare practitioners, and soon there will only be compliant first responders, law enforcement, and military. At the same time, you are galvanizing those of us who are against the vaccine and creating greater vaccine hesitancy, including among those who previously believed in the vaccine program. Please, please vote no. I cannot stress this enough. It is wrong to use our children as lab rats, and it is equally wrong to use children as a shield with a failing vaccine. This vaccine is not preventing infection.
Thank you for your comment. Your time has expired.
How many people you vaccinate or how many boosters you give. If you do vote yes, be prepared to face more distraught parents of infant
Thank you for your
children.
comment. Your time has expired. We need to move on to the next speaker. Thank you. Next is Mrs. Claire Hannon.
Good afternoon. I'm Claire Hannon, Executive Director of the Association of Immunization Managers. Thank you for the opportunity to provide comment on behalf of the state, territorial, and local public health immunization program managers. I'd like to take this opportunity to express the critical importance of vaccinating children against COVID, as well as draw attention to two implementation challenges that continue to test public health response. First, I express strong support for universal recommendation for children aged 5 to 11 years old to receive COVID vaccination as authorized by the FDA. As of October 21st, there have been 6.3 million children who have tested positive for COVID-19, and of those, greater than 1.9 million aged 5 to 11. 8,300 cases have resulted in hospitalization, and 745 children have died. I want to repeat that. There have been 745 deaths in children under 18 from COVID. Some say this illness is mild, but there is no acceptable number of deaths in children. Death is preventable with the vaccine, which is effective and safe. I look forward to the opportunity for children aged 5 to 11 to receive protection through vaccination. Vaccinating kids minimizes disease spread in school settings, and it's the best way to keep our schools safe and open. Next, I want to draw attention to two ongoing implementation challenges. First, the logistical and IT challenges involved with giving half dose of Moderna vaccine as a booster. Jurisdictions and providers have been working diligently over the course of this pandemic and previously through 27 years of the Vaccines for Children program to manage vaccine inventory and avoid waste. But now a 14-dose vial can yield up to 20 booster doses or 14 regular doses or anywhere in between. And providers must manually track how many times they have drawn from the same vial. With the addition of the half-dose Moderna booster and no change to the technology and coding tied to the 14-dose vials, there is no way to accurately track inventory and wastage. The second implementation challenge is the need to provide electronic verification of vaccination and the lack of national standards to do so. There is no standard way for consumers to show digital proof of vaccination. Many states already provide consumer access to vaccination records through immunization information systems, but the lack of a nationally approved standards for QR codes and electronic verification has limited the ability of states to provide an electronic COVID vaccine record to consumers. I draw attention to these challenges so that efforts can continue to develop solutions and improve future pandemic response. Thank you.
Thank you for your comment. Next speaker is Martha Nolan.
Sorry. Good afternoon. My name is Martha Nolan, and I am speaking today on behalf of Healthy Women, the nation's leading nonprofit health information organization for women, providing consumers and healthcare providers accurate evidence-based information about diseases, conditions, and innovations in research changes in policy that impact the treatment and care women receive. Healthy Women is also a convener of the COVID-19 Vaccine Education and Equity Project, where we are joined by over 220 organizations representing patients, caregivers, families, diverse communities, healthcare workers, older Americans, veterans, frontline workers, and scientists, all who believe we have a responsibility to come together to provide information about the clinical trials process, regulatory review, and distribution and access to COVID-19 vaccines in a way that promotes equity and trust. Since the start of the COVID-19 pandemic, Healthy Women has been diligent in working to understand the facts of COVID-19 and the related vaccines. COVID-19 vaccines have saved a significant number of lives. A National Institute on Aging funded study published in August 18th in Health Affairs found that COVID-19 vaccines prevented more than 139,000 deaths during just the first 5 months they were available, saving 2,285 lives per day. And the estimated economic value of preventing these deaths is close to $1 trillion, but the value to families is priceless. Women are the predominant caretakers in our society and are often called upon to make critical decisions for the health and well-being of their families and communities. Since COVID-19 vaccines were approved by the FDA for adults, women have led in the vaccination rates, with 60% being fully vaccinated compared to men at 55%. But everyone eligible should be encouraged to get vaccinated as soon as possible if we are going to stop the spread of the current COVID-19 Delta variant and, more importantly, the development of new variants not covered by the COVID-19 current vaccines. We need to protect ourselves and, more importantly, our kids and grandkids. Vaccinating our children is the best protection against serious infection, hospitalization, and deaths from COVID-19. Rates of COVID-19 hospitalization among children and adolescents rose to the highest levels in August and September of 2021. Over 8,300 children in the 5 to 11 age group have been hospitalized since the beginning of the pandemic. And sadly, the pandemic has taken a serious toll on our children's emotional and mental well-being. Children need access to safe and effective COVID-19 vaccines to reestablish that safe environment where they can once again learn, play, and socialize without fear of serious illness. We adults started to feel that relief almost a year ago, and finally it's our kids' turn. The COVID-19 Vaccine Education and Equity Project supports the robust regulatory review of the vaccines for children ages 5 to 11 and urges the ACIP to provide the American people with clear guidance on their use. Thank you for the important work you are doing on behalf of Americans of all ages. We remain committed to partnering with you to ensure everyone understands the facts about this critical tool for protection. Thank you.
Thank you for your comment. Next, Dr. Julie Boom.
On behalf of Texas Children's Hospital, I would like to thank the CDC staff and ACIP members who have so diligently analyzed COVID-19 disease burden, vaccine safety, and efficacy data, and then so adeptly provided risk-benefit assessments based on this information. Using your in-depth analyses, my colleagues and I have been able to assure families about the safety and efficacy of COVID-19 vaccines in adolescents and adults. As a general pediatrician with 26 years of experience and director of the Immunization Project at Texas Children's Hospital, I know that vaccines are the best way to protect children from COVID-19. As you continue your discussions today, I urge you not to minimize the disease burden and risk of COVID-19 in children. To date, COVID-19 has proven to be more contagious and deadly than influenza, having killed almost 800 children ages 0 to 17 years, with 172 deaths in children 5 to 11 years. Even though the number of pediatric deaths pales in comparison to the number of deaths among adults, especially the elderly, the risk to children shouldn't be minimized. To frame the number of pediatric deaths, let me offer the following comparison. COVID-19 has killed more children than would fill 2 packed 747 airplanes. COVID-19 has killed more children than would fill 26 full classrooms or 16 full school buses fitting 2 children per seat. During any other year, these deaths would have made national headlines and created an outcry to mitigate the risk to these young persons. Unfortunately, pediatric deaths have been largely overshadowed and as a result may have questioned the risk-benefit ratio of COVID-19 vaccination for children. In addition to the risk of death, we know that many children have experienced the long-term effects of COVID-19. Similar to adults, children are experiencing symptoms such as persistent chest pain, fatigue, and cognitive difficulties long after their acute COVID-19 infection. These debilitating symptoms have prevented their return to normal activity. In addition, over 5,000 children have been diagnosed in the U.S. with MIS-C, multisystem inflammatory syndrome in children. Most often, these children present with symptoms severe enough to require hospitalization in an intensive care unit. Unfortunately, 46 children have died from the severe post-COVID inflammatory process. As mask requirements in schools and public places have been lifted in many parts of the country, recommendations for vaccinating children 5 to 11 years of age with COVID-19 vaccines cannot come soon enough. Children younger than 12 remain a vulnerable population among which COVID-19 can spread. Please give these factors your strongest consideration as you weigh the benefits and risks of COVID-19 vaccine among children. Thank you.
Thank you for your comment. Next is Joan Edelstein.
Thank you. I'm Joan Edelstein, professor of nursing and faculty in the school nurse credential program at California State University, Sacramento. As a pediatric nurse for over half a century, I've seen the devastating long-term effects of infectious diseases. I've personally cared for infants and children with rubella syndrome, polio, tuberculosis, and inclusion body encephalitis from measles. We all know people who've had months of painful shingles due to having had chickenpox. And I have several friends who've had polio and now suffer the effects of post-polio syndrome decades later. As we try to address the highly unlikely long-term effects of clearly safe and effective COVID vaccines, we do not yet know the long-term damage of having COVID in childhood. We do know that children suffer from long COVID, as has been well demonstrated by long COVID kids in the UK. We do know that COVID causes organ damage that may lead to long-term health problems. We do know organ damage can affect children with COVID, as reflected in multi-system inflammatory syndrome. We don't know if organ damage will affect them weeks, months, years, or decades after having been infected with COVID-19, and we should not wait to find out. We ask that you provide emergency use authorization for this clearly safe and effective vaccine now for children ages 5 to 11. Implementation purposes, as a credentialed school nurse, I'd also like to make a statement about the need for the CDC to support school nurses in vaccination administration that will impact the success of pediatric vaccine programs. Our pediatric public health population is right here in our schools, the ideal place to implement primary prevention measures such as vaccines. School nurses are responsible for the entire school health program and are the health experts in this non-healthcare setting. Nonetheless, school nurses have been disregarded. We've been specifically excluded in planning for safe schools in my own state in spite of repeated requests to be at the table. In order to advocate for students and have effective mitigation programs and successful vaccine programs, school nurses nationwide are the public health experts in partnering for successful school-located vaccine clinics and educating families, staff, and the community on the importance of vaccines. The CDC should include in all school-related recommendations that school nurses be actively included in assessment planning, policy, program development, implementation, and evaluation of both vaccine programs and mitigation efforts. Funding should be targeted to school nurse positions as they've now twice the work, uncompensated in time or money for inadequate pay. Rather than eliminating or ignoring school nurse positions in districts, the CDC should take the lead in recognizing the importance of including school nurses in all recommendations and enjoin state, county, and city health departments to partner with school nurses at the district and school levels to carry out this most critical task of getting our pediatric public health population vaccinated. Thank you.
Thank you for your comment. Our last public speaker for the session is Dr. David Wiseman.
Good morning.
Go ahead, Dr. Wiseman.
Thank you, Dr. Lee. Please refer to our previous submissions for disclosures. Former FDA medical officer, Dr. David Gortler, just wrote that FDA failed in its duty to ensure vaccine safety for children. After criticizing the UK for rushing to approve Pfizer's vaccine, Dr. Fauci called FDA the gold standard of regulation. With extensive medical industry experience, I say this is the gold standard of regulatory dereliction. FDA touted its children's vaccine review as thorough and transparent. Far from it. For safety, 1,500 patients followed less than 3 months and another 1,500 only 2.5 weeks. A small immunobridging study against Wuhan, still with no immune correlation of protection. A similar study against Delta was marked assay not validated, analysis not verified by FDA. Where is FDA? The efficacy study yielded only 16 placebo and 3 vaccine outcome events. With a large imbalance of mysteriously excluded vaccinated subjects, bias in this observer-blinded but not double-blinded study could drop the 90% efficacy to 0. See today's BMJ for allegations of trial unblinding. Where is FDA? Why was the efficacy analysis not verified by FDA? Where were FDA? Where is Pfizer's sub-study on troponin levels and subclinical myocarditis? Where is FDA? FDA's risk-benefit analysis failed to consider a 42% seroprevalence and non-myocarditis serious AE reports as many as for myocarditis, and improperly modeled waves and waning efficacy. When properly accounted for, we find risks outweigh benefits by nearly 2 to 1 before underreporting. The one thing FDA got right was revealing an almost 5-fold VAERS underreporting at least, and a database more reliable than VAERS that CDC didn't know about. Pfizer have changed to a tris buffer that could change particle charge, but no assessment of particle distribution in animals, no safety, no efficacy studies. Where was FDA? With no cancer or mutagenicity studies, especially in young animals, FDA has not assuaged the concern for radiation-like toxicity of this gene therapy product. With CDC's study on all-cause mortality and vaccination, we find correlations between vaccine coverage and mortality. Adults benefit from 4 to 26 weeks, outside of which there are detriments. In non-vaccinated children, all-cause deaths correlate with adult vaccine coverage. Vaccination already appears to harm non-vaccinated children. Will ACIP request our analysis? no emergency, unblinding, but unverified efficacy data, missing and limited safety data, faulty risk-benefit analysis. You have nothing to work with, and FDA have shunted the work of defining risk groups onto you. And one VRBAC member callously remarks, we're never going to learn how safe this vaccine is until we start giving it. FDA have abandoned their responsibility to our children. Will you?
Thank you for your comment. Your time has expired. And with that, we want to thank all of our public comment speakers today. The committee will now recess until 17 minutes after the hour. You have exactly 15 minutes. Thanks, everyone. It's now 17 minutes after the hour, and we will now reconvene the meeting and move on to the next session for the afternoon. I believe Dr. Jefferson Jones is up first, and he will begin our session with a presentation on SARS-CoV-2 epidemiology in children. So Dr. Jones, the floor is yours.
Good afternoon. In this, next slide, please. In this presentation, I'm going to give an overview of the epidemiology of COVID-19 in children aged 5 to 11 years, covering incidence and seroprevalence estimates, COVID-19 associated hospitalization rates and mortality, multi-system inflammatory syndrome in children, MIS-C, and additional post-COVID conditions. Finally, I'll briefly talk about transmission. Next slide. First, incidence and seroprevalence. Next slide. As of October 22nd, there have been over 45 million cases of COVID-19 reported in the U.S. The majority of these have been in adults, as of most hospitalizations and deaths due to COVID-19 illness. However, children have been greatly impacted by the pandemic. Here are the reported cases by age group, with children aged 5 to 11 years in dark blue. In total, there have been over 1.9 million cases of COVID-19 reported among children aged 5 to 11 years. Starting in July and August of this year, there was a sharp increase in cases in this age group. Next slide, please. Over the past few months, we are seeing children aged 5 to 11 years, shown in dark blue near the bottom of the figure, making up a greater proportion of total cases, representing 10.6% of all cases reported to CDC in the week of October 10th, 2021, while making up 8.7% of the total U.S. population in the 2020 census. Next slide. Data shown on the previous two slides were for cases reported to CDC. However, many infections are asymptomatic or result in mild illness and are not tested and reported. To estimate all infections, CDC conducts an ongoing nationwide seroprevalence study in collaboration with commercial laboratories. A screenshot of the CDC data tracker seroprevalence webpage is shown on the right. Every 2 weeks, approximately 50,000 de-identified serum specimens are collected by commercial laboratories for preventive or acute clinical care and are tested for SARS-CoV-2 antibodies. However, many jurisdictions have limited availability of pediatric specimens. People presenting for acute or clinical care or screening and having their blood drawn by commercial laboratories might not represent the general population, particularly in children who do not frequently require blood tests. The most common reasons for the clinical visits, as documented by ICD-10 codes among children, include general examination, which could include cholesterol, as all children are recommended to have cholesterol screened between ages 9 to 11 years, obesity, long-term drug monitoring, and fatigue. Next slide, please. Displayed are the weighted infection-induced antibody seroprevalence estimates by age group for September 2021 for 47 U.S. jurisdictions. These results are preliminary and are subject to change. Seroprevalence in children aged 5 to 11 years is estimated to be 38%, which is higher than seroprevalence estimates among adults and similar to estimates in children aged 12 to 17 years. Seroprevalence varies greatly by state and jurisdiction. Among 23 jurisdictions with at least 75 specimens collected from this age group during September, the state or jurisdiction level estimates ranged from 11% to 61%. And this seroprevalent estimate is different than the estimates presented at the FDA VRBPAC meeting. It includes 47 jurisdictions for September, as opposed to 15 jurisdictions for May to June. Using seroprevalence to estimate the cumulative number of infections, the number of infections per reported cases by age was calculated. For the general population, including adults, the jurisdiction level infection to case ratio was a median of 2.4 with a range of 2.0 to 3.9. For children, the infection to case ratio was substantially higher with a median of 6.2 and a range of 4.7 to 8.9. Next slide. Numerous children aged 5 to 11 years have been previously infected, but what does this mean for vaccination? Based on data in adults, infected individuals have a low risk of infection for at least 6 months, but protection is not 100% and is likely lower against the Delta variant. Of note, the antibody response after infection is lower and less consistent, meaning there is a wide range of antibody titers in response to infection, compared with mRNA vaccine-induced antibody response, which produces higher and more consistent antibody titers. Additionally, antibody titers generated after infection are lower in people with mild or no symptoms. Infections resulting in mild or no symptoms appear to be much more common in children with SARS-CoV-2 infection than in adults. Data among children are lacking, and data in adults might not apply to children. Substantial immunologic evidence and a growing body of epidemiologic evidence indicate that vaccination after infection significantly enhances protection and further reduces risk of reinfection. Among those eligible, CDC recommends vaccination regardless of a history of infection, and serologic testing to assess for prior infection is not recommended for the purpose of vaccine decision-making. Next slide. Seroprevalence data suggests infection in children are less likely to be reported compared with adults. Seroprevalence estimates in children aged 5 to 11 were approximately 38% in September 2021. Seroprevalence indicates that children are at least as likely as adults to be infected with SARS-CoV-2. Note that residual serospecimens collected by commercial laboratories, again, may not be representative of the general pediatric population. Antibody tests cannot determine if a person is protected from infection or not. The assay used for the analysis, a total antibody test that maintains high sensitivity for at least 6 months after infection, is good for detecting previous infection, but unlikely to correlate with protection from infection. Next slide. Next, hospitalization. Next slide. I'm now going to review pediatric hospitalization data from the COVID-19 Associated Hospitalization Surveillance Network, or COVIDNet, a population-based surveillance system that collects data on laboratory-confirmed COVID-19 associated hospitalizations among children and adults through a network of over 250 acute care hospitals in 14 states. Data are preliminary and subject to change. Cases are identified in COVIDNet if they test positive for SARS-CoV-2 through a test ordered by a healthcare provider and are hospitalized within 14 days of the positive test. This chart illustrates weekly rates of COVID-19 associated hospitalizations by age group, with children aged 5 to 11 years in red. The cumulative hospitalization rate was 32.3 per 100,000 population for this age group as of October 23rd. As you can see, rates for this age group have been consistently lower than other age groups. Note, however, that in September 2021, for children aged 5 to 11 years, population-based hospitalization rates were higher than in any other previous point during the pandemic. Next slide. Variations in hospitalization rates by race and ethnicity are seen, with American Indian and Alaska Native, Hispanic, and non-Hispanic Black children having cumulative hospitalization rates that were 3 times as high as the hospitalization rates in non-Hispanic White or non-Hispanic Asian children. This disparate impact of the pandemic, including higher rates of hospitalizations on these groups, is similar to disparities seen in other age groups. Next slide. To further put the burden of COVID-19 illness in context, we compared COVID-19 and influenza-associated hospitalization rates among children aged 5 to 11 years using data from COVIDNet and data from the Influenza Hospitalization Surveillance Network, or FluSurvNet. FluSurvNet, a long-standing platform that was leveraged to create COVIDNet, conducts population-based surveillance from October 1st to April 30th each year, which is roughly MMWR weeks 40 to 18 as shown on the x-axis of the displayed figure. This time frame is the typical U.S. influenza season. Influenza-associated hospitalizations occur seasonally, with very low influenza detection during May to September, which is shaded in the gray in the figure, suggesting that few influenza-associated hospitalizations are missed during that gray area that is outside the October to April surveillance window. Therefore, FluSurvNet rates from October to April were used to approximate the annual influenza hospitalization rate. FluSurvNet has a similar catchment area to that of COVIDNet and uses similar methods for case ascertainment and data abstraction. So displayed in blue, green, and red are the rates of influenza-associated hospitalizations from October to April during the 2017 to 18, 18 to 19, and 19 to 20 seasons. For ease of comparison, influenza-associated hospitalization rates were extended out in a dashed line. Next slide. Here, the influenza 2020 to 21 rate is added and displayed in black. It was extremely low, with only 9 hospitalizations being reported across all pediatric age groups. This is likely because during this season, mitigation measures such as school closures and mask wearing were in place, decreasing influenza transmission. Next slide. During this same time frame, here the COVID-19 associated hospitalization rate is added, shown in yellow. It was calculated for a 1-year period, October 1st to September 30th, 2021, because COVID-19 transmission has been occurring throughout the year. The 2020 to 21 annual COVID-19 associated hospitalization rate, in yellow, was similar to influenza associated hospitalization rates for the 2017 to 18 and 18 to 19 seasons, shown in blue and green. And the COVID-19 rate was lower than the rate for the 2019 to 2020 season for influenza, shown in red. The low influenza hospitalization rate for the 2020 to 21 season, shown in black, suggests that the annual rate of COVID-19 hospitalizations might have been much higher, including higher than influenza hospitalization rates, during typical influenza seasons, had these COVID-19 mitigation measures not been in place. Next slide. To compare outcomes and interventions in children hospitalized with COVID-19 with another disease, we compared with influenza, combining 3 pre-pandemic influenza seasons from 2017 to 2020. The median length of stay among children hospitalized with influenza was 2 days versus 3 days for children with COVID-19. 21% of children with influenza versus 32% of children with COVID-19 required ICU admission. 4.6% of children with influenza versus 7.2% of children with COVID-19 required invasive mechanical ventilation. And a similar proportion of children with influenza versus COVID-19 died in the hospital, approximately 0.6%. Next slide. Of 562 children aged 5 to 11 years who were hospitalized with COVID-19 during March 2020 to August 2021, 68% of children were Hispanic or non-Hispanic Black, which make up 1/3 of the general population. 32% of hospitalized children had no underlying conditions, and the most common underlying conditions were chronic lung disease, primarily asthma, and obesity. Next slide. Next, I'll discuss COVID-19 associated mortality in children aged 5 to 11 years. Next slide. As of October 22nd, there have been over 730,000 COVID-19 deaths reported in the United States, the vast majority in adults. However, deaths in children have been reported. Displayed are counts of reported COVID-19 deaths by age. Between January 1st, 2020 and October 16th, 2021, there were 94 COVID-19 deaths reported among children aged 5 to 11 years. Among deaths in this age group, COVID-19 associated deaths account for 1.7% of all deaths during the same time period. And please note there is a lag in death reporting. Next slide. To put this into context, this table displays the top 10 causes of death for children aged 5 to 11 years for the year 2019, the most recent year with complete NCHS mortality data. Restricting to the 12-month period of October 3rd, 2020 to October 2nd, 2021, a 12-month period, there were 66 COVID-19 associated deaths reported for this age group. This would be equal to the 8th leading cause of death for 2019. In contrast to COVID-19, during the 2020 to 21 flu season, only 1 death in all age groups for children from influenza was reported, likely because of reduced transmission due to COVID-19 mitigation measures. As displayed in the table, during 2019, 84 influenza pneumonia-associated deaths occurred among kids aged 5 to 11 years, the 7th most common cause of death. This suggests, similar to COVID-19 hospitalizations, more COVID-19 associated deaths would likely have occurred had these mitigation measures not been implemented. Next slide. I will now discuss multisystem inflammatory syndrome in children, or MISC, followed by additional post-COVID conditions. Next slide. MISC is a severe hyperinflammatory syndrome, typically occurring 2 to 6 weeks after acute SARS-CoV-2 infection, resulting in a wide range of clinical manifestations and complications. Incidence has been estimated as 1 MIS-C case in approximately 3,200 SARS-CoV-2 infections and varies with race, ethnicity, age, and region. Approximately 60 to 70% of patients with MIS-C are admitted to intensive care and 1 to 2% die. Next slide. Nationally, 5,217 MIS-C cases have been reported. Children aged 5 to 11 years are the age group most frequently affected by MIS-C. The median age of cases is 9 years, and 44% of all reported MIS-C cases have occurred in children in this age group. A disproportionate 61% of children with MIS-C are Hispanic or Latino or non-Hispanic Black. And again, these populations comprise only 1/3 of the overall population of persons aged 0 to 20 years. Among children aged 5 to 11 years, 9 MIS-C associated deaths have been reported, which is 20% of all MIS-C deaths. Next slide. Beyond MIS-C, additional post-COVID conditions occur in children. These encompass a wide range of new, returning, or ongoing health problems, including physical and mental health consequences, experienced by patients 4 or more weeks after initial infection with SARS-CoV-2. Few data on post-COVID conditions in children exist. It appears that post-COVID conditions in children is less common than among adults. In published reports, frequencies of occurrence have varied depending on the characteristics of the children studied and other factors. Further investigation is needed to better characterize post-COVID conditions in children. However, a national survey in the United Kingdom found that 7 to 8% of children with COVID-19 reported continued symptoms greater than 12 weeks after their initial diagnosis. Post-COVID conditions in children may appear after mild or severe infections or after MIS-C. Symptoms are similar to those seen in adults and include fatigue, cough, muscle and joint pain, headache, insomnia, and trouble concentrating. Next slide. Lastly, I'll review SARS-CoV-2 transmission among children. Next slide. Multiple factors impact the transmission of SARS-CoV-2 virus, including presence and type of symptoms of the index case, type and timing of the exposure, viral load, and variant. Some studies have reported similar rates of transmission from infected children as from infected adults, while others have found lower rates of transmission from infected children compared with rates from infected adults. Some data are from earlier studies that likely underestimated infections in children. However, it is clear that secondary transmission from children, both to other children and to adults, can and does occur, and has been reported in both household and school settings. Studies have shown vaccination decreases transmission. Next slide. Multiple household studies, outbreak, and contact tracing investigations have demonstrated efficient transmission among children and adults in multiple settings. Displayed is a recent MMWR article describing Delta variant transmission within a classroom setting in an elementary school, with an attack rate of 50% among students too young to be vaccinated. You can see from the figure on the right that some students, in dark blue, were links in transmission to other students, to siblings, in light blue, and to their parents, shown by circles with the diagonal stripes. Next slide. In summary, children aged 5 to 11 years are at least as likely to be infected with SARS-CoV-2 as adults. Over 1.9 million reported cases have been reported, and seroprevalence is estimated to be approximately 38% for September 2021 using the data set previously described. Seroprevalence data suggests that infections in children are less likely to be reported as cases than infection in adults. Children aged 5 to 11 years are at risk of severe illness from COVID-19. Over 8,300 hospitalizations have occurred to date. Hospitalization rates are 3 times higher for non-Hispanic Black, non-Hispanic American Indian and Alaska Native, and Hispanic children compared with non-Hispanic white children. Hospitalization rates are similar to pre-pandemic influenza-associated hospitalization rates. Severity was comparable among children hospitalized with influenza and COVID-19. Approximately 1/3 of hospitalized children aged 5 to 11 years require ICU admission. At least 94 COVID-19 associated deaths occurred in children aged 5 to 11 years. MIS-C was most frequent among children aged 5 to 11 years. post-COVID conditions have been reported in children. All of these adverse outcomes would likely have been more numerous had pandemic mitigation measures not been implemented. Finally, secondary transmission from school-aged children occurs in household and school settings. Next slide. Thank you to the numerous people who contributed to the data presented today.
Thank you, Dr. Jones, for that excellent presentation. This presentation is now open for questions. Thank you, Dr. Paling.
Thank you, Dr. Jones, for this great presentation. It's very clear and demonstrates the illnesses and the epidemiology of COVID in children 5 to 11. One of the questions that I have is we talk a lot about MISC. And do we have any data on MISC in children 12 to 17 and any data on how that frequency has changed since vaccine has been approved for children 12 to 17? Thank you.
I know I have some MISC experts on the line, and I'll defer to them. Thank you.
Hi, can you hear me? This is Angie Campbell.
Yes, we can. Thank you.
Okay. Hi, Dr. Paling. We don't have that data yet. We are hopeful that a couple things, I guess. There's such a lag to our MISC National Surveillance System reporting that the cases were really quite low through the summer. And now that vaccination has become more common in the 12-year-old and over group, maybe that will make a difference with what we see in the current wave of cases that are being reported to us, but we just don't have that yet. And then the other piece that we hope to have in a few weeks when we get enough cases is we do hope to look specifically at vaccine effectiveness against MISC in hospitalized children, but we don't have those numbers yet either.
Thank you. Dr. Daly?
Yeah, thanks so much. I have a comment and then a question. A comment is that it's around severity. As a general practicing pediatrician, if I see a child with COVID who I admit to the hospital, if I come back to work the next day and hear that child's been admitted to the ICU, that's very concerning. It's not just a change in room number. It's an indication to me that illness for that child I just saw a couple of days ago is potentially life-threatening. And it looks like, based on these numbers at least, that the severity is at least as great as influenza or perhaps more. And then my question is around the seroprevalence. And thank you for describing that so clearly. It seems to me that those who get blood drawn may be different than those children who do not get blood drawn. And for example, if a reason for getting blood drawn is fatigue, which I think you mentioned, then that would suggest to me that it could have been a asymptomatic case of COVID that led to that blood draw. And so I would think that it's more likely that it would be an overestimate of the seroprevalence in the general population. But I wanted to ask you if that interpretation is reasonable.
Thanks for the question. The seroprevalence, as you mentioned, it comes from a unique group of children who are having their blood drawn. If anyone is specifically having blood drawn for COVID-19, then those serum specimens are excluded from the study. But as you mentioned, there may be other reasons, and an ICD-10 code for COVID-19 was not mentioned. So it is possible. Unfortunately, there are not many randomized household-based studies to compare to. These results are somewhat similar to other seroprevalence studies that have been in children, but most of those studies were using a very similar approach that are taking a convenient sample from laboratory sampled children. So your thinking is reasonable, and we don't have a great way to confirm it. Thank you.
Thank you. Ms. Bata.
Thank you for this presentation. Kind of in the same vein of seroprevalence,
When you describe the number of infections per reported case, how do you determine that? How is that determined?
Can I clarify, this is the infection to case ratio?
Yeah.
So we did a particular study that was narrowed to, I believe, 6 or 7 jurisdictions. And for just in those jurisdictions that had complete age data, which we defined as greater than 90%, we compared the cumulative number of reported cases in children to the projected number of cumulative infections in children using the seroprevalence data. So if 5% of the population had been reported as a case and 20% would be projected to be infected per seroprevalence, then that would be a 4-to-1 ratio.
Thank you.
Thank you. Dr. Sanchez?
Thank you. No, it's very helpful data as we evaluate the vaccination strategies, Dr. Jones. But my question is, in the analysis of the hospitalizations and certainly mortality, did you take into account or exclude those patients, those children who were just tested for being hospitalized but did not have, who may have just been may have been asymptomatic from a COVID infection, but a lot of hospitals now, especially children's hospitals, we're screening on admission, irrespective of what they may be having for any. Sorry.
Dr. Sanchez, is that your audio? Dr. Sanchez, for some reason your audio is not working well, but Dr. Havers, were you planning to respond?
Yeah, this is Fiona Havers. Can you hear me okay?
Oh, it might be Dr. Havers, actually. Your line is the one that's causing the audio interference. Dr. Jones will respond. Thank you.
All right. So the question is whether children in COVID had an infection that, say, due to they had a trauma and then tested positive for COVID-19 as opposed to being hospitalized for COVID-19. The COVID-19 team looked through medical records for all children, and if I remember correctly, it was 79% of children were confirmed to be hospitalized for COVID-19, with other cases being somewhat more difficult to determine. And I do not believe they were excluded from the analysis. If anyone else from the MISC team wants to add anything, they can.
Hi, this is Shika Garg. I can also comment on that, and that's correct, what Dr. Jones said. So among the 5 to 11 year age group, about 80%, 79 to 80% of those children were specifically admitted related to COVID-19 related illness. We've also looked at symptom data to look at it in a couple of different ways. And among children 5 to 11, about 87% had any one of the symptoms that we collect data on. And also that is correct that these people were not excluded from either the rates or from the table that was comparing severity among those with COVID versus those with flu.
Thank you. Dr. Paling.
Yes. When we looked at the hospitalization rate, it was clear that Black, Hispanic, and American Indian and Alaskan Natives had threefold higher rate of hospitalization than non-Hispanic white. When you look at the COVID-19 deaths, which are fortunately uncommon in children, do we see disparities in there as well? Thank you.
I do not know of an analysis of COVID-19 deaths by race and ethnicity that's available at this time. If anyone else on the phone knows of it, they can mention it. But that's something certainly that we will look at and would be expected. since both infections, hospitalizations, MIS-C have all followed similar patterns, and that's happened in adults, and deaths in adults follow similar patterns to that, that we would expect that to be the same in children.
Okay, thank you. Are there any additional questions that folks have on the phone?
Dr. Lee, this is Veronica McNally. May I ask a question?
Of course. Ms. McNally, please go ahead.
Dr. Jones, do you happen to know what percentage of children in this age group are considered to be obese?
According to the 2019 data, I believe it was 20.2% in this age group. There has been recent study out of Southern California that showed there was a significant increase in obesity during the pandemic. So it could have increased.
Thank you.
Thank you. While I'm waiting to see if there's any additional questions, I just wanted to remark on the stark disparities that continue to exist, and it's being highlighted in the pediatric population as well in terms of severe disease and hospitalization. And I think we recognize that those disparities in health that occur are, a consequence of decades of compounding inequities that impact both health and education of these kids. So just to say that I think there is much that we need to do to actually, not only through our recommendations, but through implementation, really continue to address those disparities. I'm just sad that this far in the pandemic, we continue to see that data that looks like there's such differences in the outcomes for kids and adults. And I see Dr. Campbell has raised her hand. Did you wish to respond to a prior question?
I did, thank you. I just wanted to address the death question. I can address it specifically for deaths associated with MIS-C. We published a paper, it was led by Anna Bowen and OFID, and we did actually see increased odds ratios in Black non-Hispanics and Hispanics relative to whites. And we didn't have large enough numbers to do adjusted analyses for AIAN and Native Hawaiian Pacific Islanders, but the crude ratios for those were very elevated relative to the white population as well.
Thank you. I see no further hands raised, so I think we'll move on to the next presentation, which is Dr. Matt Oster, who will be providing the committee with information on vaccine-associated myocarditis. Dr. Oster?
Great, thank you very much. And thank you for inviting me to speak on mRNA COVID-19 vaccine-associated myocarditis. I spoke a little bit about this last week at FDA, but I have some updated information to present as well today. Next slide. So today I'm going to be talking about some cases of myocarditis after COVID-19 vaccination, primarily in adolescents and young adults. We'll be talking about comparing the different types of myocarditis, and then some early information on some of the 3 to 6 month outcomes of myocarditis. Next slide. So first, I wanted to remind people of the updated numbers as reported to VAERS. These are reporting rates per 1 million doses administered of myocarditis after mRNA COVID-19 vaccines, looking at a 7-day risk period. In the interest of time, I'm just going to show the Pfizer data today, since that is the topic for discussion today. And this is looking at all ages for Pfizer, broken down by age group and males and females. As you can see, the reporting rates of myocarditis within 7 days after vaccination exceeded the background incidence for males after the first dose in ages 12 to 24, and after the second dose in ages 12 to 49, with a peak in that adolescence and young adulthood area. Amongst females, we did not see an increased risk or reporting rates after dose 1, but we did see a slight increase in risk after dose 2 in females ages 12 to 24, again with a peak in that 16 to 17 year range. Next slide. So those cases reported to VAERS. Further investigation was performed to get some more clinical information and to verify cases. 877 were able to be adjudicated as meeting case definition. A number still were under review and needed more information. Of those 877, 829 were known to have been hospitalized, with at the time of their report, 789 discharged. Now, of those, it was reported that they had recovered from their symptoms at the time of the report, with about a quarter of them having ongoing symptoms at that time of their report. Small number were not hospitalized. A proportion of them did get MRIs, so about 312 of those 877. Of those, the cardiac MRI was abnormal in 72% of cases, or 223 of them. Next slide. I did want to take a moment to address the question of deaths that have been reported to VAERS with concern for myocarditis. This is the reports of deaths in persons aged less than 30 years among about 86 million doses from about 47 million individuals. When CDC receives reports of deaths, primarily through VAERS or through other means, a very extensive process is undertaken. This includes reading in reports that are sent to us, reaching out to the reporter to get more information, trying to obtain extensive medical records and autopsy reports if they're available, just having discussions and meetings with the state health departments, as well as with the medical examiner, and then whenever possible, offering to review pathology samples at CDC to look for, to answer any questions that may be pertaining to the case in terms of diagnosis or potential causes. So we are aware of 9 cases where there was concern for myocarditis raised in death. There was one case where fully vet information was not available. This is a case that has been published in the literature. It's a 27-year-old trisomy 21. This is available online. This individual did not have an MRI done, so we could not see if this is a confirmed myocarditis case. It was reported as fulminant myocarditis, and an autopsy was not available. The full investigation to look for other potential causes was not able to be undertaken. But 8 did have information available. Of these, 2 have an evaluation ongoing. 6 have their evaluation that has been complete. And these 6 have fallen into 2 categories. 3 were found to have myocarditis. 3 were found not to have myocarditis on review of pathology samples. These are thought to be other causes, cardiac causes of sudden death, which were not due to myocarditis, with no evidence of that. Certainly there's a background rate of that as well. For those cases with myocarditis, further investigation was completed looking for other potential infectious causes. As I'll talk in a couple of slides, with classic myocarditis, there are a number of different infectious causes, both bacterial and viral, as well as some other causes that can lead to myocarditis. And in these 3 cases of myocarditis, a potential infectious cause was identified in each of those. And that leaves us with no cases thus far that have undergone full evaluation in which no other potential cause has been identified. Next slide. Now I'm going to talk a little bit about the different types of myocarditis. We use this term a lot, myocarditis, and technically it means just inflammation of the heart muscle. But there appear to be different varieties of myocarditis that can differ in the way that they present, the way they are treated, what their short-term outcomes are, and what their long-term outcomes are. Certainly we have classic myocarditis, and that's for lack of a better term. When I use that term, I really mean myocarditis in the pre-COVID era. And with the COVID era, we've now seen 3 different types of myocarditis. So myocarditis related to COVID-19 with the active infection itself, myocarditis related to MIS-C, myocarditis, and then COVID-19 vaccine-related myocarditis. Next slide. So classic myocarditis, or myocarditis in the pre-COVID era, as I mentioned, can have a number of different etiologies, particularly infectious etiologies. This is a partial list of common, viral, parasitic, bacterial, fungal, and protozoal agents that can cause myocarditis. And there are a number of non-infectious etiologies as well. Next slide. So the epidemiology of this myocarditis in children, annual incidence is about 0.8 per 100,000 per year, but it does peak as well in adolescents, about 15 to 18 per year. You can see in that graph on the left, there's an early peak before age 1, thought to be primarily related to some genetic causes, but then it rises again in adolescence. About 66% of cases are male, and there can be some significant morbidity and mortality in myocarditis, especially in the pre-COVID era. In adults, similarly, in this study from Quito et al., we see the peak in adolescence and young adulthood, especially amongst males, and the percent of males over time generally decreased. For females, it was pretty static over time with maybe a slight peak in the 50s and 60s. Next slide. For MIS-C myocarditis, on the left, you'll see in this paper published earlier this year about the first 1,700 cases of myocarditis. First 1,700 cases of MIS-C that were reported to CDC. Myocarditis was listed on the case report form in 17% of cases, about 300 cases. On the right, you see some data from COVIDnet, which shows that there's more than just myocarditis. It's more than just myocarditis that pertains to heart involvement in MIS-C, where 80% of the first reported cases of MIS-C had some sort of cardiovascular involvement, with 50% have elevated troponin, 73% elevated BNP, and about just under 40% having decreased ejection fraction. Next slide. What about COVID-19 myocarditis? There have been some reports and concerns of this. This seems to be a problem more in adults than in children, myocarditis due to COVID-19. This is some data showing, from some large healthcare systems or healthcare aggregate data from EPIC and from Children's Hospital Association's FIS database. And the myocarditis that we see in pediatric patients is really mostly due to MIS-C. This is at least for the clinical myocarditis. There could be subclinical myocarditis that would not be captured by clinical databases, of course. Next slide. So how do these types of myocarditis, compare? So this study that is published online at medRxiv, and I did supervise one of our fellows at my clinical institution in this project. She looked at comparison of MIS-C-related myocarditis, classic viral myocarditis, and COVID-19 vaccine-related myocarditis. Did not include COVID-19 myocarditis because we had hardly any cases that we would call that. Next slide. What we found is that at least on presentation, cases of vaccine-related myocarditis looked very similar to the classic myocarditis or pre-COVID myocarditis. This slide shows the laboratory evaluations at presentation. You can see for troponin, BNP, lymphocytes, white blood cells, C-reactive protein, and platelets, the vaccine-related myocarditis group looked very much closely to the classic myocarditis group. Next slide. But when we looked at their cardiac function as measured by ejection fraction by echocardiogram, we saw a little bit of a different picture. On initial presentation, as you'll see there on the left, the blue group, the classic myocarditis group, and the red group, the MIS-C myocarditis group, about 2/3 of them had a decrease in their ejection fraction. So just over 30% had normal ejection fraction at presentation. Whereas in the vaccine-related myocarditis group, 7 of the 9 had a normal ejection fraction at presentation. For the classic myocarditis group, again the blue group, it took a while for a number of them to reach normal function, with about 1/3 of them not reaching normal function by 2 weeks. Contrast that with the MIS-C myocarditis group, where almost all of them regained normal function by 10 days after presentation. And then the vaccine-related myocarditis group, all of them regained normal function. The 2 that had decreased function both regained normal function within a couple of days. Next slide. Well, what about the long-term outcomes? So that's the short-term acute outcomes. What do we know about long-term outcomes? This study published earlier this year looked at the outcomes in pre-COVID myocarditis and what are different risk factors that can be associated with the long-term outcomes. slide. And they broke different variables down into what would be, what characteristics of that variable would be associated with a good outcome versus those would be concerning for a poor outcome. So I put in this yellow box here those variables which are similar with the pre-COVID myocarditis group and the vaccine-related myocarditis group. Like the pre-COVID myocarditis group, or the classic myocarditis group, those with vaccine-related myocarditis tend to have chest pain at clinical presentation with little to no heart failure symptoms. That's the New York Heart Association classes. Their electrocardiograms tend to, if they show abnormalities, will show ST elevation. For biomarkers, their troponin can certainly be elevated, as shown on the earlier slide, but they tend to have a fast decline. Echocardiogram, many will have preserved ejection fraction at the onset, but if it is decreased, we tend to see early improvement or normalization of that. Next slide. One variable associated with poor outcomes, though, that we also see in those with vaccine-related myocarditis, compared to the classic myocarditis, is the cardiac magnetic resonance imaging findings. I showed earlier, 72% of those who had an MRI had some sort of abnormalities, often with presence of late gadolinium enhancement. What exactly this means for this particular group, though, still remains to be seen. Next slide. And it's because of the pre-COVID, the classic myocarditis group, and some of those long-term outcomes, with the concern really being sudden cardiac events, that the American Heart Association and American College of Cardiology have these guidelines that were put in place in 2015. And they recommended that after someone is diagnosed with myocarditis, that before they return to competitive sports, they should undergo extensive cardiac testing, including echocardiogram, rhythm monitoring, and EKG. Though it's unresolved as to whether resolution of LGE, that's late gadolinium enhancement, should be required. And importantly, the recommendation at the time was independent of age, gender, and function. And so for lack of data in the current era, since we're still learning about vaccine-related myocarditis, these guidelines have often been applied to those with vaccine-related myocarditis as well. Next slide. So what are we seeing, though, in the 3-month outcomes, at least? This is data from Vaccine Safety Data Link. This includes a large network of health systems and looking at electronic health records. This data comes from just looking at chart reviews, so looking at visits that people may have had. And in the for those who are considered recovered, now on no medications, without any sort of exercise restrictions or symptoms, that was the case in about 30% of 12 to 17-year-olds, about 40 to 50% of those 18 to 39. About a quarter to a third of cases were still symptomatic, listed on their charts. And a number were still on medications, the older groups more likely than the younger groups. Although the younger groups, the 12 to 17-year-olds, were more likely to still be on exercise and physical activity restrictions. Next slide. So beyond just looking at the chart, CDC has launched an investigation to look at long-term effects of myocarditis. This involves 2 parts. Number 1, calling the patients or the parents of the patients that have been reported to VAERS. And then number 2, asking them to identify a healthcare provider, usually a cardiologist, that they have been following up with to identify more detailed clinical information. Next slide. CDC has been able to reach just under 250 patients thus far, and have asked for a self-report of whether they had any of these symptoms within 2 weeks, the prior 2 weeks of the phone call, and the phone calls were about 3 months after their initial myocarditis diagnosis. And for fatigue, palpitations, shortness of breath, and chest pain, each of those symptoms were reported by about a quarter of patients as having it happened at any point in the prior 2 weeks, not just at the time of the phone call. Overall, about half of patients reported no symptoms, but half reported at least one within the prior 2 weeks. Next slide. We're looking at cardiac testing that's been done. with much less data to date, this is a little bit more incentive to reach out to the providers. But those who had an electrocardiogram, it was normal, about 83%, borderline, about 14%. Echocardiogram was usually normal, about 88%. Cardiac MRI was not done much, only 15 so far that we have results for. 2/3 were normal, a third of those abnormal. Again, but we don't know whether this is being selectively ordered, whether there's any other concerns prior to the cardiac MRI. So it's certainly not being done for all patients. And the troponin, when it's been checked in the 25 cases, was normal at 96%. Next slide. So when the cardiologists or other healthcare providers were asked, though, in their opinion, and based on their evaluation thus far, did they think that the patient was fully or probably recovered? About 91% said yes. So 74% said yes, I think this patient has fully recovered by now. And 17% said, I think they probably recovered, but we're waiting additional information, such as further testing with rhythm monitoring and MRI. Next slide. So thank you very much. I'd like to acknowledge the help of a lot of people who contributed to this study and a lot of the projects that are going on, especially Tom Shumakor and John Su, who shared some slides, and Nikki Klein from Vaccine Safety Data Link, as well as Sam Butler from EPIC, Matt Hall and Carrie Thurman from Children's Hospital Association for sharing some of their data. Thank you, and be happy to answer any questions.
Thank you, Dr. Oster, for that presentation. We really appreciate you providing your expertise and sharing it with the committee. This presentation is now open for questions. And as we're waiting, I did have one question for you, Dr. Oster, which is, we recognize that myocarditis in general seems to be more common in males and females at baseline, and also, as we've seen with vaccination. Have you noticed any differences in severity or like distinguishing features in terms of the phenotype and the outcomes between males and females, or is that something you might study going forward?
Yeah, certainly something worth looking at. We haven't really noticed a big difference. One thing I'll mention, I showed those slides earlier with the overall just epidemiology of classic myocarditis, and I failed to mention that what we're seeing so far with the vaccine-related myocarditis does seem very similar to that in terms of peaking in adolescents, not as high in the older population. If the post-vaccine side effects follow for what we've seen for classic myocarditis in the younger age group, we don't expect it to be as prevalent in the adolescents. But yes, for males and females, we will be following it for all ages for sure.
Thank you. Dr. Paling.
Yes, thank you, Dr. Oster, for this great presentation and education about myocarditis of all your different types. One of the questions that I have for you is we have been seeing disparities by race and ethnicity in hospitalization. And I wanted to ask about the COVID-related myocarditis. Are you seeing disparities, and what have you been seeing? Thank you.
Yes. So by COVID-related, if you mean, so the COVID infection-related myocarditis, again, at least in the younger population, we don't see a lot of that with hospitalization, certainly some. With the MIS-C myocarditis, just we know for MIS-C in general, it's definitely higher in African Americans. That's not fully explainable by their baseline COVID infection rates. Higher in Hispanics, that is partially explained by their baseline COVID infection rates in the population. And for the others, not enough data to really make strong determinations. For the myocarditis after vaccination, I can say that most of the cases for which we know the race and ethnicity, it does actually tend to be more often white, but with two caveats to that. Number one, that data is not always well listed on the VAERS report form. There's an option to report that, but it's often missing or not reported or unknown by the reporter. And second, we have not been able to really look at, the percentages compared to just the underlying vaccination rates. Because certainly if there is, disparities in just the number who are getting vaccinated, it's hard then to interpret necessarily the disparities in the number having the vaccine adverse events. But it's definitely something we're considering and want to look and learn about more.
Thank you. Dr. Brooks?
Yes, thank you. An excellent presentation. Dr. Oster, a couple of quick questions. Was there an increased incidence in myocarditis in those under 30, I guess in the VAERS reporting, with underlying cardiac disease? And I kind of think of that more either electrophysiologic or structural, like CCHT.
Yeah, so excellent question. So we do ask, for comorbidities and underlying diseases. We have not seen any strong patterns in that yet to really, say much about that yet. We've certainly not seen any major upticks or anything jumping out at us yet. We need to try to collect data a little bit more rigorously in that, but in the ones we've been able to reach and do full investigations on, and there are, some limitations to that when we're reaching out to the providers and to the families, we really haven't seen anything of that nature popping up.
And Dr. Lee, if I may ask a second question.
Please go ahead.
I will note that there was no summary slide on this presentation. The questions that have been coming to me as a member have really focused on myocarditis. I'm really trying to summarize a lot of information that you presented, and it's excellent that you have this much information. So you had 877 cases reported to VAERS of people either less than or equal to or less than 30. That was out of 86 million doses. And out of that, it looks like there were either 9 or 10 deaths, and none of them could be linked directly to myocarditis. After all, when you distill down these 877, is that correct?
Yes. So of those 877, we could not identify vaccine-related myocarditis as the cause of death in the ones that have been fully evaluated thus far.
And I think that's really important as it relates to a lot of the questions and the comments that have been generally given to a lot of us. Thank you. I probably have another question coming back, but that's it for right now, Dr. Lee. Thank you.
Thank you, Dr. Brooks, and thank you for summarizing and clarifying that for all of us. I think that was really helpful. Dr. Hoag?
Yes, thank you. My question is very similar to Dr. Brooks, but with a finer point. Dr. Oster, thanks for your wonderful presentation. What data, if any, do we have about the risk of myocarditis in individuals who specifically have congenital heart defects? Or I know this is an issue that I believe some parents, so we're not talking about a large number of parents here, but some parents are concerned about whose child may have been born with a heart defect, that they're concerned about whether their child's going to have some increased risk of myocarditis resulting from getting vaccinated with the Pfizer vaccine. And I know there's so much we don't know about kids at this point from the study. So I'm wondering if you can opine on anything you have on congenital cardiac abnormalities in the adolescent group.
Certainly. So yes, I'm a practicing pediatric cardiologist, so I get this question all the time. And I participate in some other studies just looking at the congenital heart disease groups in general and how they have been affected by COVID. And so what I can tell you is two things. One, we have not seen an increased risk for myocarditis in those with congenital heart disease, either through my work with CDC or through taking care of these patients. Number two, I can tell you though that there are some data. One study has been published, another that's going through its channels that I know of there, that of kids with congenital heart disease who have severe COVID, meaning they need to be hospitalized for it. Once they're hospitalized, they're more likely to have kind of those critical outcomes, requiring ICU level support or more. So my advice to the number of families that call asking about that, I tell them that I am much more worried about what would happen to their child if they got COVID for a patient with congenital heart disease than I am if they were to get this vaccine.
Thank you. We're going to go back to Dr. Sanchez, and then we'll go to Dr. Duchin next.
Thank you, Dr. Oster. I think, and actually your previous comment was extremely helpful as well. But I just wanted to go back with what Dr. Brooks had commented on with the deaths. I just want to clarify because I think it is really critical and important in terms of the deaths in persons. I think there's slide number 5. Age less than 30 with possible concern for myocarditis. So of those who were reported deaths associated with myocarditis, just want to clarify this. So cases with concern for myocarditis, of the 3 whom it was decided that they did have it, what were the potential? So none of them, so all of them had another etiology and potential infectious cause identified. Do you know what those were? Or
Yeah, so there were, I don't want to get into the details of any individual case for patient confidentiality reasons, and I'm not sure whether these are coordinated by the states and they are responsible for contacting the families. But I will say that those infectious causes, had been both viral and bacterial that had been found, and viruses and bacteria that are known to, be associated with potential myocarditis. So I can share that now, and this is part of the reason why having these full investigations, though, is so important, especially in these cases of mortality, to really look for other things. There still is the background rate of myocarditis that is out there, and what we've seen so far is the background rate of myocarditis can have, we know that it has very significant morbidity and mortality, and we don't think that this vaccine-associated myocarditis has nearly those same acute outcomes.
Just to reiterate that as of now, there has not been a case of myocarditis resulting in death that has been attributed to the vaccine.
That's correct. So there's still stuff ongoing, and we are still constantly trying to see, any reports and learn more information if anything comes in. But for those that have the evaluation that has been completed, we've not identified any.
Thank you.
Thank you. We'll go to Dr. Duchin and then Dr. Long.
Thank you, Dr. Lee, and thank you, Dr. Oster, for your ongoing scrutiny of this adverse event. It's reassuring to see that the rates remain low, between 4 and 7 per 100,000 in the highest risk young males. I just wanted to clarify your conclusions with respect to the relative severity of vaccine-related myocarditis and the classic viral myocarditis. And we previously understood that vaccine-associated appeared to be less severe and the patients recovered more quickly. I just want to confirm with you that that's still your conclusion. And then secondly, very reassuring to see, the epidemiology of myocarditis shows very low cases for viral myocarditis in the 5 to 11-year-old group, and wondering if you can comment on whether there's a pathophysiologic basis to think that vaccine-associated myocarditis will be similarly low. And then finally, wondering if you can comment on the study out of Israel that showed that myocarditis from COVID-19 was approximately 3 times more common than that associated with vaccination. Thank you again for your ongoing help with this issue.
Okay, I apologize if I didn't follow all that, so I'll try to take them in piece by piece. All right, so the first thing, just write down what you asked me. So the first one was the conclusion that to recover well. That's part of the reason why we're doing the study, to look at the long-term outcomes, to, doing ongoing surveillance to figure out what will these, young adolescents, young adults look like down the road. And, we've got some early data. I showed the symptoms data, which showed that at some point in the last 2 weeks, it wasn't that surprising. I think a lot of people, certainly, are more keen, can be more keen and aware to symptoms once they've had a diagnosis of myocarditis. But it was very reassuring to see that when you ask the cardiologists who were evaluating these patients, do you think that they have fully recovered? About over 90% of them said, yeah, I do, at least by the 3-month point. We'll certainly keep following up that and watching that, and we continue to add on to those number of patients and the ones that we do have follow up to continue following them. Second, that 5 to 11 year group, yes, as I said, so far the epidemiology for this vaccine-related myocarditis, both by age and sex, appears to be following what we have seen for kind of this classic myocarditis. We don't have any reason to suspect that it'll be different once you go to the below 12 range, but it's certainly something we'll keep looking at. There are a number of different pathophysiological mechanisms and rationales for why that is, which I won't go into right now. One of the most common thoughts, though, is that certainly hormones play a role, specifically testosterone, how that can alter, what receptors are present on cardiac myocytes. And that would certainly kind of fit the profile over time by sex and age. But this is an area that we certainly want to learn more. And then third, I think your question was looking at the rates of COVID myocarditis compared to higher rates than vaccine-related myocarditis. So, what I would say is that, yes, I like to think of it as the risk of having some sort of, bad heart involvement is much higher if you get COVID than, if you get this vaccine. Whether it be COVID, related myocarditis in general, or just COVID cardiac side effects like palpitations or other things, or MISC, which has a strong cardiac component to it. So I think that, you can break it down different ways as to what you call a COVID-related illness, but, the bottom line is getting COVID, I think, is much riskier to the heart than getting this vaccine, no matter what age or sex you have.
Thank you again for your ongoing careful study of this problem.
Thank you. We'll move on to Dr. Long.
Yes, thank you so much. I know you've heard me say some of this before, Dr. Oster, and I completely agree with all of your assessments. I think of the typical viral or para-infectious myocarditis as the apple. And you and I are least comfortable treating this patient. They don't present usually with chest pain. They usually present with cardio or respiratory symptoms and exercise intolerance, and they get better very slowly and with great difficulty, and sometimes don't get better. So they're the apples. I think the oranges are the coronavirus infection-associated myocarditis. And I think looking at these patients and most of the case reports, that more than half of them are MISC. And MISC is such a different disease than viral typical myocarditis. It's like a stunned myocardium. They have function problems and their heart just doesn't work for a couple of days, and then they usually turn around and they're oranges. I don't say that I know anything about coronavirus-associated myocarditis in adults with COVID, but in children, this is, somewhere between worse of what I think is myopericarditis, the vaccine-associated, which is better, and viral myocarditis, which is worse. And then so there's an apple and an orange and an avocado. This vaccine-associated pericarditis is predominantly parietal pericarditis. They have chest pain. It's worse with movement. And they have much less, although their cardiac MRIs are abnormal, yes, they have maybe edema, maybe myocytes, maybe inflammatory changes, but their function is much more usually normal and they're better. But one thing I want to challenge a little bit for you to think about is the 3 cases that you reported that were vaccine associated, reported to VAERS, that had other causes. I have managed a couple of manuscripts of patients who had myocarditis for other reasons. One was a typical viral type myocarditis who was recovering, who got the vaccine and 2 days later had chest pain and had a recurrence of their myocarditis, their dysfunction, but with a flavor of the pericarditis, the vaccine associated. So I think we'll talk later about what might be clinical considerations of underlying conditions. And then the other one was a young man who 20 days after his first dose of vaccine got typical vaccine-associated myopericarditis, and then got vaccine again 2 to 3 weeks later and had typical 2 days later myopericarditis. So you could think that you had typical myocarditis and you could still have vaccine-associated myopericarditis. So I think it would be hard in theirs, unless you told us that those vaccine-associated cases where there were three other plausible causes, were they 2 days after vaccine, and were they typical? And if they were, it's possible that they did have underlying typical viral myopericarditis, which was exacerbated with vaccine. Long questions, comment?
No, thank you very much for those comments. And it's certainly tough sometimes because, as you know, some of the long, myocarditis, some people, and I think of this classic myocarditis, people can be walking around for weeks or months with myocarditis, and then something pushes them over the edge, whether it be some sort of, infectious stressor or something else. And could the vaccine be the stressor in those cases? Who knows? Without knowing what their baseline looks like, that's going to be a hard question to really answer, but certainly something worth considering and trying to capture when we can.
Thank you. Dr. Shaw.
Great. Thank you, Dr. Lee. Dr. Oster, this is Neerav Shah from the state of Maine. Thank you so much for your outstanding presentation. The theme of my question has been largely covered by Dr. Long and Dr. Duchin, Dr. Brooks's questions. It's largely about the relative risk of myocarditis associated with vaccine versus myocarditis associated with COVID-19 infection itself. For many parents, I suspect that the issue for decision with respect to vaccinating their 5 to 11-year-old children will be this one, which is the risk of myocarditis. Very much appreciate the discussion that's unfolded. It will be very helpful for state officials as they are answering questions. My question for you is it possible to further quantify the relative risk reduction or the differences in risk from vaccine-associated myocarditis versus COVID-19 associated? In effect, I'm sort of asking if you could translate what is on your slide 10 into a rate and an incidence and have that on a bar graph alongside what is on your slide 4, which is the risk of vaccine-associated myocarditis, given that came from VAERS data. A simple bar graph demonstrating the relative risk of those two, I think would be extremely helpful from a communications perspective. Not looking for an answer, but would appreciate your perspective. Thank you.
Yes, I think it's always important to think of these as risk benefits, and we're talking about one risk that people are focusing on with the vaccine, and I would just keep in mind that there's a lot of different risks from having COVID, which were talked about in the earlier talk by Dr. Jones. But yes, trying to put these in context for each other, I think, is important. And having taken care of these kids, and Dr. Long has alluded to it as well earlier, that seeing some of these kids who have had COVID and have had those, even just putting numbers isn't always the same. We've had, at my institution, a number of kids who've been on ECMO just from MISC, and it can be pretty severe. Fortunately, they do get better, but it can be scary. So just the numbers themselves don't always tell the full picture.
Thank you, Dr. Oster. One last question for you, actually. So I guess it seems to me that there's an underlying, perhaps individual predisposition to developing myocarditis through some trigger. Is it possible that we're just looking at what's underlying in terms of baseline rate and, should an individual who developed myocarditis after vaccination instead were to get COVID infection, it turns out that they might have significantly worse disease. So I guess my question really is, and it gets back to what everyone has been saying, sort of the risk is there, regardless of whatever the trigger is. And it seems like the severity of disease is much worse with COVID-19 associated infection and or honestly like other viral myocarditis cases that we've seen. Is that sort of your understanding of how we should think about the risk here?
Yeah, I mean, there's certainly some factors that may make certain people higher risk than others, and we don't really know all of those, or whether those are the same ones that make them, at risk for classic myocarditis versus, this vaccine myocarditis. Unclear, but the epi so far seems to go that way, but we certainly need to, to learn more, and for everyone trying to understand, what is their, personal risk of having bad outcomes from either. And if the same person were to get severe COVID versus get the vaccine, whether those risks are the same or different, sometimes hard to tell, but I think those are important considerations.
Thank you. And I see Ms. McNally, you've raised your hand. Please go ahead.
Thank you. Dr. Oster, my name is Veronica McNally, and I am the consumer representative. I have just a couple questions for you. So first, can you talk about the current management approach of myocarditis in the adolescent age group?
Yeah, so the primary management is starting off symptom-based, meaning that we look and see how is this person presenting. Certainly if someone's having pain, so chest pain is a prominent feature, treating with pain medicines is going to be first line. And so for many of the kids with the vaccine-related myocarditis, all they've gotten is NSAIDs, like ibuprofen. If there are cardiac problems such as poor heart function or other cardiac manifestations, again, which we have not seen much of in the vaccine-related myocarditis kids, more in kind of the classic ones, then you start thinking about cardiac medications, whether that be diuretics or rhythm monitoring agents or other things like that. And then if people are really critically ill, then stepping up and instituting critical measures as needed, which we really haven't seen a whole lot of in the vaccine-associated myocarditis, but is certainly a common feature in many cases of kind of the classic myocarditis. So, it's a lot, as I said, just supportive care at the mainstay for treatment. And then in certain cases, some people may do some other inflammatories besides just the NSAIDs, but that's not always common.
Can you just briefly touch on whether or not imaging is a part of the workup through these cases?
Yeah, so for the workup, so part number one is looking for different cardiac manifestations. So EKG and echo are very common. And then some of the, looking for biomarkers, specifically troponin and often BNP. Those are often standard in cases where myocarditis is suspected or there's a big concern. For the MRI, that sometimes can be institution dependent. Some places will do that too if they're unsure of the diagnosis or if they want to use it for monitoring purposes, either in the acute phase or in the long-term phase, just to look for evidence of any inflammation in the heart.
Okay, and recognizing that the clinical trial did not reveal any myocarditis in this age group, is it believed to be less likely for kids age 5 to 11 to develop myocarditis? Vaccine-related myocarditis.
So let me answer that a certain way. I believe it's less likely that the 5 to 11-year-olds will have, myocarditis, although we will watch and see for sure. And they may have some, but I don't think it's going to be nearly to the extent of the older adolescents and young adults. But I believe that based on the epidemiology that we have seen so far of this vaccine-associated myocarditis compared to pre-COVID myocarditis. I don't think that the pediatric trials were powered enough to really see this because, if we're talking about something that even in the, highest risk groups that we've seen occurs in about 1 out of every, 10 to 20,000 individuals, then having 3,000, it's not enough to actually see it. So I don't base my expectations on the vaccine trials. I base that based on the general epidemiology of what we've seen for classic myocarditis and what we've seen for the vaccine-associated myocarditis.
Okay, and in your professional opinion, and to a reasonable degree of medical certainty, with the information you have today, does the benefits of vaccination in this age group outweigh the potential risk of vaccine-related myocarditis?
In my opinion, yes.
Thank you.
Thank you. Dr. Brooks, you get the last question, and then we'll move on.
Oh, thank you. So if you could go back to it's numbered slide 4. It has your the VAERS reporting for 1 million. No, it's the one that has the orange and the non-orange.
I think it's slide 3. Yep.
So again, this is the pivotal slide for me. So first of all, I think a point is that when we make have this discussion about myocarditis, it's almost relevant only in males. Now we see these 3 female age groups of 12 to, if you will, 24. But first of all, I just want to make that as a comment. But the other question I have, I've been looking through these slides and I'm trying to get clear what the background rate is. This slide has some information per 100,000 annual, then there's the 7-day risk. So when a parent asks me, what's the chance of my child, my 16-year-old, well, let's say, no, 12-year-old, 11-year-old child getting myocarditis from the vaccine, I want to be clear on what the background is, and I'll figure it out from there in terms of the increased incidence.
Yeah. So we have there at the bottom of that slide that per 1 million person years, and 1 million people in a 7-day risk. And this can vary a little bit by age, but it makes the slides too busy. But at the higher end, about 1.9, that's 1.9 per million at the baseline. Those that are shaded, those you see, are well above that background risk, especially in the adolescent young males, as you mentioned. For what that overall risk is, though, so that's kind of the 1 in 10 to 20,000 per vaccine. If you're just trying to put this in relative terms, for someone who's wondering about the chance specifically, for their individual child.
Right. Thank you.
Thank you. And with that, we will thank Dr. Oster for his presentation and move on to Dr. Tom Shimabukuro, who will present on vaccine safety surveillance efforts in children. So now we will be looking ahead. Dr. Shimabukuro.
Thank you, Dr. Lee. Today I'll be discussing vaccine safety monitoring with focus on children. Next slide. So I'll be covering at a fairly high level CDC surveillance systems and processes for monitoring vaccine safety in children. And I'll be briefly mentioning systems from the FDA, the Indian Health Service, and the Department of Defense. And then I'll also briefly describe the role of the Vaccine Safety Technical Work Group, or the VAST. I'll mention that the VA is also a surveillance partner. However, they don't have children in their population. Therefore, I'm not including the VA monitoring systems in this presentation. Next slide. So COVID-19 vaccines are being administered under the most intensive vaccine safety monitoring effort in history. And below you see CDC's main monitoring programs. And I'll cover those individually in the coming slides. Next slide. I'll start with vSafe. This is the CDC's smartphone-based active safety monitoring system that was developed for COVID-19. It uses text messaging and secure web-based surveys. It's now available to enroll children and also available for 3rd dose reporting. Next slide. So participants can register themselves. It's a voluntary self-registration process. themselves or their dependents after dose 1, 2, or 3. Dependents can be added even if the primary smartphone account is not a vSafe participant. The parent or guardian must create a profile and then add the dependent. The text messaging is directed to the parent or guardian. The vSafe check-in schedule is the same for all ages. It's once a day, days 0 through 7, and then after that, once a week through 6 weeks, and then at 3, 6, and 12 months, and the schedule restarts after each dose received. And on the right there, you see a simulated screenshot of what it looks like when you're in there and you're going through the process of adding a dependent. Next slide. As far as the analytic plan, vSafe will aggregate data from health surveys completed on days 0 to 7 after vaccination for children aged 5 to 11 years. We'll describe the data based on demographics and also describe local and systemic reactions and health impacts by dose received. We'll compare the reactogenicity profile of children aged 5 to 11 years to adolescents aged 12 to 17 years. Reports to VAERS solicited by active telephone follow-up of vSafe participants are included in VAERS analyses. Next slide. Now I'll cover the vaccine adverse event reporting system, which is a jointly operated spontaneous reporting or passive surveillance system operated by CDC and FDA. Next slide. VAERS accepts reports from anyone regardless of the plausibility of the vaccine causing the event or the clinical seriousness of the event. Its key strengths are it can rapidly detect potential safety problems and can detect rare adverse events. As a passive surveillance system, the limitations are inconsistent quality and completeness of information, reporting biases, and the main limitation, generally we cannot determine causality or cause and effect from VAERS data alone. Next slide. So these are the VAERS pre-specified adverse events of special interest as of October 27th. The assessment of these adverse events of special interest includes a clinician review of the VAERS report, follow-up to obtain and review medical records, application of case definitions, and adjudication to classify the report with respect to the case definition. Next slide. We will be specifically focusing on myocarditis and pericarditis in this age group. Potential reports are identified through a MEDRA standardized code search that assigns a report that indicates a report could be a potential myocarditis or pericarditis case. Clinical abstraction includes review of the initial report, outreach to the healthcare provider involved in the reported patient's care, request and review of medical records, and will compare abstracted data elements against the CDC case definitions for myocarditis and pericarditis. Next slide. So moving on to the vaccine safety data link, which is an EHR-based system that includes 9 participating integrated healthcare organizations with data on over 12 million persons per year. Next slide. The VSD conducts rapid cycle analysis. The aims are to monitor the safety of COVID-19 vaccines weekly using pre-specified outcomes of interest and to describe the uptake of COVID-19 vaccines over time. Surveillance in the VSD began in December 2020. Next slide. This is a reference slide which shows the pre-specified VSD rapid cycle analysis surveillance outcomes, the settings in which we're monitoring, the risk window, and exclusion criteria. Next slide. So as far as the VSD analytics strategy, statistical analysis will be similar to what's being done for other age groups, but will include stratified analyses on 5 to 11-year-olds. For the primary analysis, the number of outcomes observed in a risk interval after vaccination will be compared to the number of expected. The risk interval is 0 to 7 days for myocarditis and pericarditis and seizures, and 1 to 21 days for other outcomes. The expected is derived from vaccinated concurrent comparators who are in a comparison interval that's 22 to 42 days after COVID-19 vaccination. So we use a vaccinated concurrent comparator. We're comparing vaccinated individuals to other vaccinated individuals looking at cases in the risk interval compared to cases in a comparison interval. Next slide. VSD will continue to review medical records and adjudicate any potential cases of myocarditis and pericarditis identified within 1 to 98 days following any COVID-19 vaccination. In addition, VSD will conduct chart review of all identified cases of Guillain-Barré syndrome, acute disseminated encephalomyelitis, transverse myelitis, anaphylaxis, and cerebral venous sinus thrombosis within 1 to 98 days following any COVID-19 vaccination. And VSD is able to capture information on simultaneous vaccinations. Next slide. The last CDC system I'll cover is the Clinical Immunization Safety Assessment Project, which is a collaboration between CDC and 7 participating medical research centers. Next slide. The CSEC COVID-19 vaccine core activities include clinical case reviews and clinical consults on complex cases of vaccine adverse events, technical consultation on clinical guidance and clinical considerations for use of COVID-19 vaccines, contributions to enhance surveillance for adverse events, and clinical research, including in pediatric populations. Next slide. Now I'll mention some of our federal surveillance partners. This includes FDA, which conducts active surveillance, which includes the BEST system, and collaborations with federal partners. Next slide. Our colleagues in the Indian Health Service conduct passive surveillance and vaccine adverse event system reports through a collaboration with CDC. They also have Indian Health Service Safety Tracking and Response System. IHS also does active surveillance, and that's in the Indian Health Service Sentinel survey. Next slide. Our colleagues in the Department of Defense also monitor DoD VAERS reports through a collaboration with CDC. They have a system known as the Vaccine Adverse Event Clinical System, or VEX, and the DoD Electronic Health Record and Defense Medical Surveillance System. I just want to mention that it was the Department of Defense that detected the initial safety signal for myocarditis through monitoring in their active duty population, and are a key partner in safety monitoring. Next slide. Finally, I want to describe the the Vaccine Safety Technical Work Group, otherwise known as the VAST. The VAST serves as the central hub for technical subject matter expertise from federal agencies conducting post-authorization and post-approval safety monitoring. They meet weekly or bi-weekly to review data on adverse events of special interest. There's shared learning, including all members, federal partners, and subject matter experts. They review, evaluate, and interpret post-authorization safety data and advise the federal agencies on monitoring, analyses, and interpretation of data. There's also independent discussion of findings by the VAST members. As far as VAST plans for the 5 to 11-year-old group, they will review safety in this age group as soon as possible, continue close review of myocarditis data, and provide updates to the ACIP COVID-19 Vaccines Working Group and ACIP on COVID-19 vaccine safety. Next slide. So finally, to wrap up, I want to make a pitch to our healthcare and public health partners and to the public, especially parents and guardians of children, but also folks coming in to get booster doses. We want you to participate in vaccine safety. You can help CDC by getting involved. Your participation does matter. So what can you do? You can report adverse events following vaccination to VAERS, even if you aren't sure if the vaccination caused the adverse event. You can enroll yourself in VSafe. Healthcare providers, you can encourage your patients to enroll in VSafe. And parents and guardians, you can enroll your children in VSafe. Thank you, and that concludes my presentation.
Thank you, Dr. Shimabukuro. Are there any clarifying questions for Dr. Shimabukuro at this time? Dr. Daly.
Yeah, thanks so much for that presentation, Dr. Shimabukuro. This is more of a comment than a question, but I think it's very helpful for us to look forward and hear what's planned for this age group. But I also think it's important to look back, and since December of 2020, these systems have really shown that they have the ability to detect rare adverse events that can happen following vaccination. And then they're designed to assess the situation rapidly, and then the findings are communicated, transparently to the public and the policy-making folks at FDA and CDC. So, while I know that data from these systems have been deliberately misrepresented, which can cause concern and confusion among the public, I think that definitely represents a challenge. But at the same time, I just feel very reassured to know that we have these multiple systems. They're large, they're distinct, and they're going to be constantly evaluating the safety of COVID-19 vaccines, including for new groups such as the age group we're discussing today. So that's a comment that you don't need to respond to unless you want to. Thank you.
Thank you, Dr. Daly. Dr. Paling?
My comment is, first of all, thank you for a fantastic presentation, and thank you for setting up the most intensive vaccine safety monitoring effort we've ever seen. It's very important. I think I wanted to reinforce a point that's quite similar to what Dr. Daly said, and it's highlighting that VAERS is a very important system to identify potential signals, but it cannot determine cause and effect. And I just wanted to give you a chance to talk about why we have so many other systems and how that's actually done. Thank you.
Sure. So VAERS is the nation's early warning system for vaccine safety, and is a spontaneous reporting or passive surveillance system. It is basically open to anyone. We accept reports from anyone, again, regardless of the plausibility of the vaccine causing the adverse event or the seriousness of the event. And we encourage people to report to VAERS. We depend on people to report to VAERS. Maybe it's important just to walk through what is in VAERS, so that the timeline of a VAERS report. An individual gets vaccinated. At some point in the future, an individual experiences an adverse health event, and then there is a decision to report that to VAERS, whether by the patient or the parent or the healthcare provider. Some reports to VAERS may be true adverse reactions. Some reports may be coincidental events and not related to vaccination at all. VAERS is not designed to determine whether a vaccine caused an adverse event. VAERS is designed to detect unusual or unexpected patterns, which may lead us to believe we have a potential safety problem, or lead us to believe we need to look at a potential safety problem. We can do that in VAERS, or we can also go to more robust data systems like the Vaccine Safety Data Link. In the Vaccine Safety Data Link, we use electronic health records and records with demographic information. And in a system like the Vaccine Safety Data Link, we have complete or near complete information on individuals, including vaccination and including encounters with the healthcare system and medical diagnoses. In the VSD, we are able to calculate rates and assess risk. And we also have systems like the Clinical Immunization Safety Assessment Project, which allows us to do deep dives into individual cases. So basically, we have multiple complementary systems which work together to help us rapidly assess the safety of vaccines. The VSafe system is probably the most responsive system and has been instrumental in characterizing and confirming the basic safety profile of these vaccines. VSafe is unique, at least to COVID-19. It was stood up just for COVID-19. And then again, I mentioned all the federal partners involved in safety monitoring systems. So it really is multiple agencies, multiple systems that work in different ways that allow us to rapidly assess the safety of these vaccines. And if we do detect potential problems, we can rapidly assess them and communicate that in a transparent way. So thanks for the opportunity to explain that.
Thank you so much, and thank you for the presentation, Dr. Shimabukuro. Just to put a period on the end of that sentence, there have been over 420 million doses administered in the U.S., and so that is an extensive amount of safety data to date. We're going to move over to Dr. Kevin Chatham-Stevens, who will provide a presentation on implementation of COVID-19 vaccine pediatric program. Dr. Chatham-Stevens, the floor is yours.
Great, thanks so much. I really wanted to thank everyone for the opportunity to describe some of our work preparing for the vaccine for 5 to 11-year-old children. Next slide, please. So I'd really just like to start off with some of the high-level implementation goals we've had for the 5 to 11-year-old vaccine program during the past several months. The first goal was really to reach the most and meet families and children where they are as much as possible, enabling access to and availability of vaccine providers where populations are most likely to seek vaccination. Second, we wanted to ensure vaccine access for vulnerable and underserved pediatric populations. The third goal was to minimize any potential delays between FDA authorization of the vaccine and the initial rollout. And finally, the fourth goal was to disseminate timely clinical guidance to jurisdictions and providers. To achieve each of these, we were harnessing the existing robust pediatric vaccination network in the U.S., complementing that network with additional sites, and building on successes and lessons learned from the adult and adolescent vaccine programs. Next slide, please. So now I'll walk through our approach for reaching children through a variety of different clinicians and settings. In that first row, we have pediatricians and other pediatric providers, such as family practice docs and nurse practitioners, caring for patients in a medical home, which is the optimal location for many children to be vaccinated. Clinical settings such as federally qualified health centers, or FQHCs, rural health clinics, health departments, Indian Health Service clinics, among others, can help ensure vaccine equity and broad coverage. We know that not every 5 to 11-year-old has a medical home, so the medical home will be complemented by other vaccine providers. For example, in the second row, pharmacies will be leveraged to administer vaccine to children who may not seek or have access to care in a pediatric practice. In addition, schools can partner with vaccine providers, such as health departments, pediatric clinics, FQHCs, and pharmacies, to host vaccination clinics at school. These school-located vaccination clinics can provide a convenient option for parents and caregivers who may experience challenges taking their child to a clinic. Next slide, please. As announced by the White House recently, as part of several key initiatives, more than 100 children's hospitals will set up vaccination sites. This will be a critical part of efforts to provide vaccine access for children, especially those with underlying medical conditions. To complement all the previous settings, jurisdictions may also use temporary community clinics, leveraging experience with these clinics from the adult and adolescent vaccine programs. Next slide, please. So now we'll dive into a couple slides about how jurisdictions are planning for the 5 to 11-year-old vaccine. In late September, we surveyed jurisdictions to learn more about how they plan to use different types of vaccine providers and settings. 58 jurisdictions responded to this question regarding which providers they planned on using to deliver the vaccine. Please note that these options were not mutually exclusive. As you can see, jurisdictions seem to be using an all-of-the-above approach, with most jurisdictions planning on using large pediatric providers, VFC providers, pharmacies, temporary community vaccine clinics, and school-located vaccine clinics. Next slide, please. In a follow-up survey, we asked jurisdictions to rank the settings in which they anticipated most 5 to 11-year-olds would be vaccinated. Here we're showing the settings that were ranked either number 1 or number 2 by jurisdictions out of 8 different options. Pediatric providers were the most highly ranked, followed by FQHCs and rural health centers, health departments, and pharmacists. Next slide, please. Next, we wanted to show some data from a parental survey conducted by the University of Iowa, RAND, and CDC in late September, early October. Among just over 1,000 parents of children 5 to 11 years old, almost 2/3 felt comfortable having their child vaccinated in their regular doctor's office or clinic, followed by the pharmacy and another doctor's office or clinic. Approximately a quarter of parents felt comfortable having their child vaccinated at school with the parent present, and about 15% without the parent present. So surveys of both jurisdictions and parents indicate 5 to 11-year-old children will likely be vaccinated across a variety of settings. Next slide, please. And I'll finish up with a couple slides describing some of the support we've provided to jurisdictions. As mentioned previously, we've conducted 2 jurisdictional surveys to help guide outreach and planning and identify key issues. We've also disseminated an operational planning guide and preliminary information about the Pfizer BioNTech vaccine. The operational planning guide included some key information about the vaccine, assumptions to inform planning, and strategies for jurisdictions to consider implementing. For example, A checklist in the document included various tasks, such as jurisdictions routinely evaluating the adequacy of the provider network, identifying gaps in whether additional vaccination locations, such as FQHCs, pharmacies, school-located vaccination clinics, or rural health clinics, may be needed to further increase equitable access and ensure vaccine equity. This particular planning document is available on the CDC webpage pictured on the right. The document about the Pfizer-BioNTech vaccine included a side-by-side comparison of the adult-adolescent formulation and the formulation of 5 to 11-year-olds. Next slide, please. CDC is also working to provide guidance on and support of school districts partnering with pharmacies to conduct school-located vaccine clinics. Some of our resources for schools are available on the webpage pictured on the right. We've also conducted numerous listening sessions with a variety of public health, clinical, and other partners to hear about potential challenges in the rollout of the vaccine and what resources CDC or others could provide to help facilitate the rollout. And with that, I'll end and just wanted to acknowledge the variety of folks across the agency and out in the jurisdictions who are helping ensure that this vaccine rollout is successful. Thanks so much.
Thank you, Dr. Chatham-Stevens. Since we're running fairly far behind today, I'm just going to ask for clarifying questions related to this presentation only. But we'll ask Dr. Chatham-Stevens if he'd be willing to be available to answer some general implementation questions after we're able to get through the next session. So Dr. Daly.
Yeah, thanks so much for that. I have a question that either if we can address now or down the road a little bit, but just about what the communications plan is, because I am thinking that for many parents, the considerations around myocarditis may be the focal point, and I just want to think ahead about how we communicate that to providers and the public. Thank you.
Sure. Our communications experts have done a fantastic job of laying out a plan to make sure we're communicating to key populations, including parents, obviously, but also our providers, so that they can then amplify the appropriate messages, and then our partners as well, including health departments and academic professional societies as well. So I think it's a matter of some of the key points are that have so eloquently been laid out previously, that COVID-19 does present a risk to children, and that we have to balance that risk and the potential side effects when discussing this particular decision with families. And I know a lot of this information, the communications materials, will be disseminated in the coming days on this topic.
Thank you, Dr. Chatham-Stevens. I don't see any additional hands raised for the moment. Oh, okay, Dr. Paling.
I'm sorry, thank you for this presentation. I wanted to ask about input in this implementation planning, and were people who were historically marginalized populations included in this planning process? Thank you.
Sure. Thanks for that comment. And I know this vaccine equity is definitely top of mind for our jurisdictions, our folks out in state, territorial, local, and tribal health departments, as it is for us here at CDC. And I think this is really our opportunity to build on some of the lessons learned and successes from the adult and adolescent rollout. We have numerous resources online that, including various toolkits, that are aimed at various different partners to help ensure that we're engaging in equity work across the vaccine program. And I will say each of the particular settings that I walk through can contribute to this. We know that the VFC program, historically has done a great job of providing vaccine to those children who may not otherwise be able to afford the vaccine. FQHCs, rural health clinics, and tribal health care providers can also help ensure that vaccine is available for their particular populations, as well as school-located vaccine clinics. We know some families, because of transportation challenges or other reasons, can't necessarily make it to a clinic during regular business hours. So making sure that we have pharmacies and school-located vaccine clinics available can help ensure that the vaccine is widely available to various populations.
Thank you so much. Thank you for the excellent presentation. And our committee will recess until 3:15 p.m. So you have 9 minutes for a break, and we'll see you back at 3:15. Thank you, everyone. We will now reconvene the ACIP meeting and move on to the next session for the afternoon. Dr. Kate Woodworth will provide a presentation on clinical considerations for COVID-19 vaccination in children. Dr. Woodworth.
Thank you. The interim clinical considerations provide additional information to healthcare professionals and public health officials on the use of COVID-19 vaccines and are informed by ACIP and CDC's recommendation, data submitted to the FDA, and other data sources such as general best practice guidelines for immunization and expert opinion. Next slide. I'll start by reviewing the Pfizer-BioNTech COVID-19 vaccine formulation and dosing for children ages 5 through 11, and then I will go into our proposed considerations for vaccine recipients and patient and parent and guardian counseling, and end with vaccine administration. Next slide. Next slide. So the Pfizer-BioNTech COVID-19 vaccine for children ages 5 through 11 years is a new and different formulation than the current formulation for those 12 years of age and older. The 5 through 11 year formulation comes in an orange capped and labeled vial as opposed to the purple vial for those 12 and older. The dose will be 10 micrograms, a third of the concentration of the mRNA in the purple capped 12 year and older formulation. This formulation also requires a different injection volume and amount of diluent. The orange 5 through 11 formulation will contain 10 doses per vial. Next slide. The 5 through 11 year orange cap formulation is stable at ultra-low temperatures for up to 6 months and can be stored at routine refrigerator temperatures for 10 weeks. Next slide. Similar to the 12 years of age and older population, children 5 through 11 would receive 2 doses spaced 3 weeks apart. Currently, children ages 5 through 11 years with moderate and severe immunocompromise are not recommended to receive an additional or third primary dose. ACIP and CDC will continue to evaluate the data to update these recommendations if needed. Booster doses are not recommended for anyone under 18 years of age. Next slide. Children should receive the age-appropriate vaccine formulation regardless of their size or weight. As opposed to many medications, vaccine dosages are based on age, not weight or body size. In general, the formulation and dosage should be based on the child's age and the day of vaccination. However, currently, if a child turns from 11 to 12 years of age in between their first and second dose and receives the 5 through 11 year 10 microgram orange cap formulation for their second dose, they do not need to repeat the dose, and this is not considered an error under the EUA. Next slide. Some considerations for vaccine recipients. Next slide. So children with underlying medical conditions may be at increased risk for severe illness from COVID-19. However, as we heard in the earlier presentation, severe COVID-19 can occur in children with and without underlying medical conditions. As the policy question for ACIP currently stands, COVID-19 vaccination would be recommended for everyone ages 5 years and older, regardless of underlying medical conditions. Next slide. People with known current SARS-CoV-2 infection should defer vaccination at least until the person has recovered from their acute illness if the person has symptoms and they have met criteria for discontinuing isolation. Serologic testing to assess for prior infection is not recommended for the purpose of vaccine decision-making. Next slide. As the policy question for ACIP currently stands, COVID-19 vaccination would be recommended for everyone ages 5 years and older, regardless of a history of symptomatic or asymptomatic SARS-CoV-2 infection or seropositivity. More than 7 million adolescents aged 12 to 15 years have been fully vaccinated with the Pfizer-BioNTech COVID-19 vaccine in the United States, and in the general population, there have been no safety concerns associated with vaccination of those who have had prior infection. Next slide. Additionally, data from clinical trial in children 5 through 11 years indicate that the Pfizer-BioNTech COVID-19 vaccine can be safely given to those with evidence of prior SARS-CoV-2 infection. Current evidence suggests that protection from reinfection is high after initial infection, but decreases with time due to waning immunity. Substantial heterogeneity exists in the individual immune responses to infection, and in adults, asymptomatic infection leads to lower antibody levels. Growing epidemiologic evidence from adults and adolescents indicates that vaccination following infection increases protection from subsequent infection, including in the setting of more infectious variants. Next slide. There are numerous limitations to antibody testing. Antibody tests cannot determine when a person was infected. Antibody tests greatly vary in their sensitivity, particularly more than 3 months after infection. People can test positive on commercial antibody tests even after other markers of immunologic response, such as neutralizing antibodies, have waned. At this time, there is no FDA authorized or approved test that providers or the public can use to reliably determine whether a person is protected from infection. Next slide. So for children with a history of multisystem inflammatory syndrome in children, or MISC, the benefits of COVID-19 vaccination are likely to outweigh any theoretical risk of an MIS-like illness or known risk of COVID-19 vaccination if they meet all of the four following criteria. They have recovered from their clinical illness, including a return to normal cardiac function. It has been at least 90 days since their diagnosis. They are in an area of high or substantial community transmission of SARS-CoV-2 or otherwise have an increased risk for SARS-CoV-2 exposure and transmission, and the onset of MIS-C occurred before any COVID-19 vaccination. Next slide. COVID-19 vaccination may also be considered for children with a history of MSC who do not meet all of the prior criteria. However, experts view clinical recovery, including return to normal cardiac function, as an important factor when considering COVID-19 vaccination. Additional factors when considering individual benefits and risks may include an increased personal risk of severe COVID-19, such as age and underlying conditions, and timing of immunomodulatory therapies. Next slide. If a child did develop MIS-C or a similar clinical illness after receipt of a COVID-19 vaccine, referrals to a specialist should be considered. Because MIS-C is a condition known to occur with SARS-CoV-2 infection, these individuals should be assessed for laboratory evidence of current or prior SARS-CoV-2 infection. Any cases should be reported to the Vaccine Adverse Event Reporting System, or VAERS, and consultation from the Clinical Immunization Safety Assessment Project is available to healthcare providers and health departments. Next slide. So moving on to counseling for patients and parents or guardians. Next slide. Based on the clinical trial data presented earlier today, children may experience fewer side effects than adolescents or young adults, and children with evidence of prior infection may have fewer side effects than those without evidence of prior infection. The expected side effects are similar to those seen in adolescents and include local reactions such as pain, swelling, or erythema at the injection site, or systemic reactions such as fever, fatigue, headache, chills, myalgias, arthralgia, and lymphadenopathy. While preemptive medication prior to vaccination is not routinely recommended, routine antipyretic or analgesic medications can be taken for the treatment of post-vaccination local or systemic reactions if medically appropriate. Next slide. Myocarditis and/or pericarditis have occurred rarely in some people following receipt of mRNA COVID-19 vaccines, typically within a few days following receipt of the second dose. What we know about this risk comes from post-marketing data available from adolescents and adults. The highest risk is observed in males 12 to 29 years of age. The risk of myocarditis or pericarditis after receipt of an mRNA COVID-19 vaccine in adolescents and adults is lower than the risk of myocarditis associated with SARS-CoV-2 infection in adolescents and adults. Next slide. As for what we know in children, there were no cases of myocarditis or pericarditis reported in the clinical trial for children ages 5 through 11, which included 3,082 children followed for at least 1 week after dose 2, but the study was not powered to assess the risk of myocarditis. As discussed earlier today, the baseline risk of myocarditis prior to the COVID-19 pandemic is much higher in adolescents 12 to 17 compared with children ages 5 through 11. Next slide. The FDA has authorized the Pfizer-BioNTech COVID-19 vaccine in children ages 5 through 11 based on the determination that the benefits of COVID-19 vaccination outweigh the risks in this population. People receiving mRNA COVID-19 vaccine, especially males aged less than 30 years, should be made aware of the possibility of myocarditis or pericarditis following receipt of mRNA COVID-19 vaccines, and informed to seek care for symptoms of chest pain, shortness of breath, or feelings of having a fast beating, fluttering, or pounding heart. Any cases of myocarditis or pericarditis after vaccination should be reported to VAERS. Next slide. Next slide. COVID-19 vaccines may be administered without regard to timing of other vaccines. This includes simultaneous administration of COVID-19 vaccine and other vaccines on the same day. I just want to note that this is all the more important as we begin influenza season to ensure children are protected against both influenza and COVID-19. If multiple vaccines are administered at a single visit, they should be administered at different injection sites, separated by 1 inch or more. For younger children ages 5 through 10 years, if more than 2 vaccines are injected into a single limb, the vastus lateralis muscle of the anterior lateral thigh is preferred site because of greater muscle mass. Next slide. With a new formulation for this age group, I'd like to highlight a couple of possible administration errors. Importantly, the formulations of the Pfizer-BioNTech COVID-19 vaccine are not interchangeable. If a child ages 5 through 11 years inadvertently receives a Pfizer-BioNTech purple-capped 30 microgram dose for their first dose, they should receive a single age-appropriate 10 microgram dose for their second dose 21 days later and should be considered as having completed a primary series. If a child ages 5 through 11 years inadvertently receives a 30 microgram dose for their second dose, they should be considered as having a completed series. These errors should be reported to VAERS. Next slide. The Clinical Considerations website listed here provides a much longer table with additional possible administration errors, as well as actions to take after an error has occurred. Next slide. We are updating many current tools to help providers get the information they need to provide these vaccines safely. And as a reminder, that all the information discussed here can be found at the interim clinical considerations for use of COVID-19 vaccines, which will be updated to include information on children ages 5 through 11 in the coming days. Next slide. I'd like to thank the many individuals who worked on these considerations. Next slide. And thank you for your time, and I'm happy to take questions.
Thank you. Before we open this session or presentation for questions, Dr. Amanda Cohen would like to say a few words.
Good afternoon. I just want to let everybody know that this presentation was given prior to the evidence to recommendations because there are so many clinical considerations which ACIP members have brought up already today. And so we thought that it would be helpful to see what this would look like. But this would all be predicated on ACIP voting to recommend a population of 5 to 11-year-olds for vaccination. So I just wanted to reiterate that fact before the questions.
Thank you. I see Ms. Stinchfield has her hand raised. Please go ahead.
Yes, Kathy Stinchfield representing NAPNAP. Quick question about vaccinating before someone's eligible birthday. Is the 4-day grace period rule that we use for other vaccines in place for this, or is there any other leeway that will be recommended?
Thank you. The 4-day grace period would apply to this population as well.
Thank you. Ms. McNally.
Thank you. Can you discuss whether or not parents are given an EUA fact sheet, or if this would come under a vaccine information statement? Please, thank you.
Yes, thank you. So parents or guardians would be given an EUA fact sheet prior to vaccination.
And this is Amanda. We are working on other parent educational materials that distill that provider fact sheet into sort of the key messages that would be important for parents to understand prior to the vaccination.
Thank you. Can either CDC or FDA address the issue of myocarditis in this age group and what will be said regarding it on the EUA fact sheet? Thank you.
Dr. Fink, are you able? Thank
yes.
you.
Hi, this is Doran Fink. So the EUA fact sheet for vaccination providers and the EUA fact sheet for vaccine recipients and caregivers for this new lower dose formulation for use in ages 5 through 11 has the same language regarding the risk of myocarditis as currently appears in the fact sheet for the 30 microgram formulation that is authorized for use in ages 12 and above. So to summarize, it notes that a risk of myocarditis following the vaccine, in particular following in the week following dose 2, has been observed, and that this risk appears to be greatest in males under the age of 40.
And Ms.
Go ahead, sorry.
Oh no, please go ahead, Dr. Vink.
No, just to finish summarizing what the fact sheet says in the warning. statement that most cases that symptoms have resolved with conservative management, but that longer-term follow-up is limited.
And Ms. McNally, we'll make sure that our communication materials do include information about this adverse event, myocarditis specifically, for all parents of minors, including 5 to 11-year-olds and 12 to 17-year-olds.
Thank you. Dr. Lee, one more quick question.
Yeah, please go ahead.
Any potential claims that may exist for this age group, those would also go through the vaccine injury compensation, the countermeasure injury compensation program. Is that correct?
Yes, that's correct.
Okay, thank you for clarifying.
Dr. Cotton?
Thank you very much for an excellent presentation. I was wondering if you could elaborate on the 2-dose series for immunocompromised children and the fact that we're not going to give any additional doses or booster doses. And maybe it's just too early to know what we're going to do. Is that how that clinical guidance was derived?
Yeah, thank you for that. We do certainly recognize that this will be a recommendation that we continue to evaluate and hope to have additional data in the coming months in order to sort of make a more informed recommendation. But at this time, they would not be recommended.
Thank you.
Thank you. Dr. Sineas? Dr. Sineas? Okay, we'll move to Dr. Long.
Yes, thanks so much. I was wondering about including in the clinical considerations that unusual case that I mentioned, and would be what the situation would be. A patient develops myopericarditis after dose 1, whether it be soon after dose 1 or 20 days after dose 1, that I think that would be a reason not to give dose 2. In the clinical case reports, I remember there was evidence in the patient who developed the myopericarditis after dose 1 that he had been previously infected. So I suspect, depending on the timing of when that could be and what their antibody levels might look like, that this is feasible, that you could get myopericarditis vaccine associated after dose 1 when there was higher prevalence of seropositivity, which we think we are currently facing. And also for those that develop it late after or any time between dose 1 and dose 2, if it were a typical vaccine-associated like case, I would think one would not give dose 2. And I don't think it would be very unusual for any of this to occur, but probably there should be some guidance about that.
Hi, this is Sujin Reddy. I thank you for your question. Just to repeat it, it's basically the scenario is people that had myocarditis after their first dose of an mRNA vaccine. And you're right, we do have some clinical consideration. In our clinical considerations document, we do address that situation. We are updating that a little bit, but I think that basically the same scenario would apply for adults as well as kids that may develop myocarditis after their first dose. And as you say, I think we would want to probably defer that second dose, but it will take some discussion with our clinical team to decide what if a second dose should be administered and under what scenario. But we'll be updating that guidance. Thank you for your question.
Thank
Great,
you.
that sounds perfect.
Thank you, both. Dr. Sineas, are you able? There we go.
Yes, sorry about that earlier. I was wondering if you could clarify when the vastus lateralis should be used as a preferred site for administration, and then also if the observation period for vaccine is the same as for other age groups.
I'm sorry, could you repeat that? We just couldn't hear it clearly.
I think she was asking about the 15-minute observation period.
Yeah. Okay. So clarification about the vastus lateralis. So for all children 5 through 11, as well as the adults, the deltoid is a preferred site, but the vastus lateralis muscle is an alternative. Specifically regarding co-administration, if for whatever reason 2 separate injections are needed to be given in the same limb, they can be given in adults both in the deltoid muscle, but in children 5 through 10 years of age, the vastus lateralis muscle is preferred because it has greater muscle mass. So that's just if 2 injections are needed to be given in the same limb. As for the observation period, the same observation period as we've been using for adults would be applied to children. So that 15-minute observation period for the vast majority of children.
Okay, thank you. Did you have another question, Dr. Sinais? Anything else?
No?
Okay. Thank you. So I think I don't see any hands raised for the moment. I recognize the questions are not actually over, but it would be great if we can move on to the next presentation, which is, I'm looking at the wrong sheet. Here we go. Oh, ETR, Dr. Sarah Oliver. Back to Dr. Sarah Oliver for the evidence to recommendations framework for the question at hand. And then we will open up the session for questions on any of the presentations.
Thank you so much, Dr. Lee. Next slide. So today we'll walk through the evidence to recommendation framework for the policy question here. Should vaccination with the Pfizer BioNTech COVID-19 vaccine be recommended for children 5 through 11 years of age under an EUA? Next slide. This walks through our PICO question with the intervention as 2 doses of the Pfizer vaccine at 10 micrograms. And the outcomes are listed here. Next slide. As you all are now quite familiar with, these are the ETR domains and questions updated for our current policy question. Next slide. First, for the public health problem. Next slide. This is our current EPI curve. We've had over 45 million cases reported in the US to date. Our current 7-day moving average is around 70,000 cases per day. Next slide. We heard from Dr. Jones earlier today on the EPI of SARS-CoV-2 in children aged 5 through 11 years. To summarize, there have been over 1.9 million cases reported in this age group. Infections in children are less likely to be reported as cases than infections in adults. We know children 5 through 11 years of age are at risk for severe illness from COVID. The cumulative hospitalization rate for COVID is similar to pre-pandemic influenza seasons, and this is in the setting of intense mitigation efforts in place over the course of the pandemic. Severity is comparable among children hospitalized with flu and COVID, with approximately 1/3 of hospitalized children 5 through 11 years requiring ICU admission. In addition, MIS is most frequently reported among children this age. Post-COVID conditions have been reported in children, and secondary transmission from these young school-age children can and does occur in household and in school settings. Next slide. So then to put this EPI into other context, here we have additional hospitalizations per year prior to the recommended pediatric vaccines. You can see that it varies by disease, but COVID just in the 5 to 11-year-old population is in line with many of the diseases we recommend routine vaccination for. Next slide. This slide shows the average deaths per year prior to recommended pediatric vaccines. Overall, again, it varies by disease, but again, COVID in just this 5 to 11-year-old age group only is among the highest deaths across these now vaccine preventable diseases. Next slide. Through collaborations with the CDC modeling team and the COVID-19 Scenario Modeling Hub Consortium, multi-model projections were created to evaluate the impact of vaccination of children 5 through 11 years of age on COVID cases and hospitalizations in this population. They assumed vaccination started November 1st and would have similar uptake rates as the 12 to 17-year-olds. Scenarios projected cases prevented in the presence or absence of pediatric vaccination, and in the presence or absence of a new, more transmissible variant. Their pooled projections showed that vaccination among 5 through 11-year-olds is expected to accelerate the decline in cases we're currently experiencing, reducing the cumulative incidence nationally by an expected 8% from November of 2021 through March of 2022. This is estimated to be a reduction of around 600,000 cases. Obviously, the emergence of a more transmissible variant could impact future COVID-19 epidemiology and projected impact. The models estimate that vaccination of the 5 through 11-year-olds would dampen but not prevent a resulting resurgence. Next slide. In addition to the severe outcomes of hospitalization, ICU admission, and death, missed school is another potential adverse outcome of COVID-19 illness and exposure among children. Numerous reports have described the negative impact on social, emotional, and physical health of children, with disproportionate impacts on children of color. Here we're showing data from the School Dismissal Monitoring System, which performs daily systematic searches of Google, Google News, and Google Alerts to assess information on unplanned school closures, including the number of districts and individual schools, as well as students and teachers impacted. In this school year to date, over 2,000 schools had unplanned closures, impacting nearly 1.2 million students. You can see from the map on the right the range of school closures by states. We also know for the 2020-2021 school year, at least 19,000 school closures occurred in all 50 US states, affecting at least 12 million students. Next slide. And a larger and growing body of literature describes the numerous indirect impacts from the COVID-19 pandemic on children. While a few are highlighted here, this is by no means an exhaustive list. For all of these listed, children of color have been disproportionately impacted. Children have experienced worsening of mental and emotional health, widening of already existing education gaps by race and ethnicity. Children have also experienced decreased physical activity and increased BMI, doubling hospitalizations for new onset type 2 diabetes, decreased healthcare utilization and routine immunizations, and an overall increase in adverse childhood experiences, including an estimated 140,000 children that have lost a caregiver to COVID-19, with significant disparities by race and ethnicity. Next slide. So in summary, we know children 5 through 11 years of age are at increased risk of severe illness from COVID. This includes hospitalization as well as MIS-C. Other post-COVID conditions have been seen in children. COVID in children leads to missed school for themselves and their communities, and wide use of an effective vaccine would reduce the public health burden of COVID in children 5 through 11 years of age. Next slide. So the work group felt that COVID among children in this age group was an important public health problem. Next slide. Now to benefits and harms. Next slide. For this, we'll give an overview of our grade outcomes, then walk through other benefit-harm considerations, including the balance in seropositive children and the potential risk of myocarditis. Next slide. The components of the PICO question are again shown on this slide. We conducted a systematic review to identify evidence related to the policy question, and one clinical trial record was included in our evidence synthesis. Next slide. We had data from the trial described earlier for the critical outcome of the prevention of lab-confirmed symptomatic COVID-19. There was a 2-to-1 randomization of vaccine to placebo, and a median follow-up time was 3.3 months. We chose as our primary efficacy endpoint to use the estimate among children with or without prior evidence of SARS-CoV-2 infection, as it best reflects what we may see as a real-world estimate. There were 3 COVID cases occurring at least 7 days post-dose 2 among 1,400 children in the vaccine arm, and 16 cases among 700 children in the placebo arm, which resulted in a vaccine efficacy estimate of 90.9. The phase 2-3 trial was designed and powered to use immunobridging to evaluate efficacy. Immunobridging studies compare immunogenicity in a group of interest, for example, those aged through 11 years, with a comparison group in which efficacy has been demonstrated in clinical trials, for example, those 16 through 25 years. The immune response to vaccine in children aged 5 through 11 was at least as strong as the immune response in young adults aged 16 to 25 years, based on SARS-CoV-2 neutralization titers, measured 1 month after dose 2 in participants without prior evidence of SARS-CoV-2 infection. Next slide. Here's the grade evidence table for the outcome, symptomatic COVID-19. Indirectness was noted due to the short duration of observation. The VE observed with a 3-month follow-up may differ from the efficacy observed with ongoing follow-up. However, for grades specifically under an EUA, this was deemed not serious, leaving us with a final certainty of type 1. Next slide. Data on serious adverse events from the initial enrollment group were reviewed for all randomized participants who received at least 1 dose. SAEs on a safety expansion group in the box is also shown with an additional 1,500 children in the vaccine arm and 700 children in the placebo arm. The median follow-up time for the safety expansion group was 2.4 weeks. Due to the short follow-up time in the safety expansion group, SAEs in this population are noted and described, but not pooled for grade purposes. In the initial enrollment group, there was 1 SAE of limb fracture in 1 child in the vaccine arm and 2 SAEs, pancreatitis and abdominal pain related to injury, in 1 child in the placebo arm. In the safety expansion group, there were 3 SAEs, an infective arthritis, foreign body ingestion of a penny, and epiphyseal fracture in 3 children in the vaccine arm and none in the placebo arm. No SAEs were assessed by the investigator to be related to the study intervention, and no deaths were reported in any trial participants. Next slide. The grade table for SAEs is shown here. The relative risk for serious adverse events between vaccinated and placebo was 0.49. Serious concern for indirectness was noted due to short follow-up time and sample size. There was also serious concern for imprecision due to the wide confidence intervals, leaving us with a final certainty of type 4. Next slide. Local and systemic events were solicited from participants or their parent or legal guardian via an electronic diary for 7 days following each dose. Grade 3 or higher local reactions or systemic events were reported in 2.7% of children in the vaccine arm and 1.1% of children in the placebo arm. Most of these events were grade 3, with 1 grade 4 event of pyrexia reported in a vaccine recipient. Events were more common after dose 2. Pain at the injection site, fatigue, and headache were the most common events. Next slide. The relative risk for any grade 3 or 4 event was 2.5. There was serious concern for imprecision given the wide 95% confidence interval, which cannot exclude the possibility of no difference between vaccine and placebo. The final certainty was type 2. Next slide. So the conclusion for grade is the phase 2-3 randomized control trial for the Pfizer COVID-19 vaccine was conducted among persons 5 through 11 years. Over 3,000 children were vaccinated with BNT162b2, and the efficacy estimate against symptomatic lab-confirmed COVID for children with and without prior infection with SARS-CoV-2 was 90.9%. The certainty for this critical benefit was high. Serious adverse events were rare, but the certainty estimate was low for this evidence. No serious adverse events were judged to be related to vaccination, and there were no deaths. Grade 3 or 4 local or systemic reactions were reported by 2.7% of children who were vaccinated, and the certainty estimate for this important harm was moderate. Next slide. So now we'll move to these other considerations where we weigh benefits and risks. Next slide. So this slide shows the immune response from the trial by serostatus, including the geometric mean titers, or GMTs, and the geometric mean fold rise, or GMFRs. The GMTs were higher in those with prior infection, although note that the GMTs pre-vaccination among seropositive individuals were substantially lower than GMTs seen post-vaccination in either population. The fold rise was less in the seropositive population, likely due to the slightly higher GMTs initially. Next slide. So this slide summarizes what we know around COVID-19 vaccines and seropositivity with a focus on children. First, from the phase 3 clinical trial, around 9% of children in the clinical trial were baseline SARS-CoV-2 seropositive. Post-vaccination antibodies were higher in children who were seropositive, and rates of local and systemic reactions, as well as adverse events, were lower in children who were seropositive. Then from broader US studies, we've heard previously that approximately 38% of children 5 through 11 have evidence of prior infection based on seroprevalence estimates from residual commercial lab sera. Prior infection can result in some protection against infection, but not 100%, and likely decreases over time. And we know that children have a greater proportion of asymptomatic infection relative to adults. Asymptomatic infection can result in lower antibody levels compared to severe disease. Next slide. So when we consider the balance of benefits and risks by seropositive status, we know that the Delta wave surges of pediatric COVID hospitalizations occurred even with the known seroprevalence, suggesting that this alone is not sufficient to provide broad protection for children. We have limited data on rates of reinfection in children. Protection against asymptomatic or mild infection is still an important outcome in children. MIS-C typically occurs after asymptomatic or mild infection, and additional post-COVID conditions can also occur after mild infection. We've administered over 400 million doses of COVID-19 vaccines to those 12 years of age and over, and no concerns have been identified in post-authorization safety surveillance with seropositive adolescents and adults. And we'll note that individuals 12 through 64 years have seropositivity over 30%. Vaccine recommendations that require serologic testing would place unnecessary barriers to vaccination and would be quite difficult to implement. While we may have limited data to estimate the direct impact of vaccination on seropositive children, the risks are minimal. Based on that, the balance of benefits and risks is favorable for vaccination of all children 5 through 11 years. Next slide. Next, to move to vaccine-associated myocarditis. Identified rates of myocarditis are based on data from adolescents and adults receiving a 30 microgram dose of a Pfizer COVID-19 vaccine, which is different than the dose proposed for this age group. It's a rare event, but most common in males 12 to 29 years of age. No cases of myocarditis occurred during the clinical trials in this pediatric population. Next slide. As we've done with previous vaccine policy decisions, previously we've conducted a formal benefit risk assessment, and we'll walk through some considerations for this population now. Next slide. So this slide shows the estimated benefits for every million Pfizer vaccine given in children 5 through 11 years of age using recent incidence. We're projecting out over 6 months and using epi data from mid-September. You can see for 1 million vaccinations, we would be preventing over 50,000 cases, hundreds of hospitalizations and MIS-C cases in children. Next slide. However, we acknowledge that the recent epi estimate pulls from epi close to the peak of the recent Delta surge, so we wanted to include other epi estimates for context. We know we're not always great at predicting COVID epi in the future, so we looked back at the pandemic average, smoothing out all the previous peaks and troughs. These are the rates that are shown here on the right for the pandemic average. Using this epi, we would still be predicted to prevent nearly 20,000 cases of COVID, 80 hospitalizations, and 40 MIS cases. Next slide. When we think about the risks for children 5 through 11 years of age, the rates of myocarditis after vaccination in 5 through 11 years of age are unknown. No cases occurred in the trial. As we saw in Dr. Oster's talk, the underlying epi of viral myocarditis varies greatly between children 5 through 11 and 12 to 17 years. Myocarditis is substantially lower in children 5 through 11 years of age. In addition, the dose in those 5 through 11 years is a third of the one used in adolescents. Both of these factors predict that if seen, any rates of myocarditis after vaccination in 5 through 11-year-old population will likely be lower than what was seen in those 12 to 15 years. So given these issues, we can't conduct a formal benefit risk assessment in those 5 through 11 years of age. Next slide. However, this slide shows estimated rates of myocarditis after vaccination in adolescents 12 to 15 years of age per million second doses. We also know that the outcomes for vaccine-associated myocarditis are reassuring. Next slide. Therefore, when we think through this benefit-risk balance, we can include not only the known benefit of the prevention of COVID cases documented in the trial, but many broader benefits, prevention of hospitalizations, MIS-C, and deaths, as well as the prevention of additional post-COVID conditions. There could also be possible prevention of transmission and a greater confidence in a safer return to school and social interactions. For the risk, we have data on short-term reactogenicity that's reassuring, and also the possible risk of myocarditis or other rare events after mRNA vaccines. Next slide. We've also evaluated the number of children 5 through 11 years needed to vaccinate to prevent a case of COVID, a COVID-associated hospitalization, or an MIS-C case. You can see that the absolute numbers depend on the epidemiology, but using our current epi, we need to vaccinate less than 10 children to prevent a case of COVID-19 in a 5 through 11-year-old. Next slide. So in summary of the benefits and harms, the clinical trial demonstrated that the Pfizer-BioNTech COVID-19 vaccine is safe, immunogenic, and efficacious in children 5 through 11 years of age. The trial wasn't powered to assess the rate of rare adverse events, but no cases of myocarditis in over 3,000 vaccinated children were seen. As with all analyses we've done previously, the balance of benefits and risks varies by COVID incidence, with the largest benefits in the higher incidence settings. But the balance of benefits and risks is favorable regardless of seropositivity rates. While many children 5 through 11 years may be seropositive, there's an unknown duration of protection for asymptomatic infection in children, and safety data are reassuring in the seropositive population. Next slide. So the work group felt the desirable anticipated effects were large. Next slide. The undesirable anticipated effects were small. Next slide. And therefore the balance favors the intervention. Next slide. Moving to values. Next slide. There have been several parental surveys to assess intent to have children vaccinated. Among parents surveyed, 34 to 57% plan to get their children vaccinated. The parental intent varies by several factors. 90% of parents who are very worried their child would get COVID report an intent to vaccinate their child, compared to 7% of parents who aren't worried at all. In addition, 82% of fully vaccinated parents report an intent to vaccinate their child, compared to 1% of parents who are unvaccinated and do not plan to get vaccinated. And recommendations from a child's healthcare provider is important. Among parents of teens who discussed vaccination with their pediatrician, 3/4 of those whose pediatrician recommended vaccination say their child received at least one dose. Next slide. We know that those intending to vaccinate their child, shown in the green colors on this figure, vary by age of the child, as well as by race and ethnicity. Next slide. This is data from a survey of 1,000 U.S. parents of children aged 5 through 11 years in September. 57% of parents in this survey stated they would definitely or probably get their child vaccinated. The figure shows concerns of parents who did not say that they would definitely get their child vaccinated. Frequently, parents report concerns for long or short-term side effects. Others report that they don't trust the vaccine, are unsure if it will work, or that their child does not need the vaccine. Next slide. 37% of parents reported side effects as a reason for not wanting a COVID vaccine for their child. And the side effects parents listed are here, shown on the slide. Next slide. So in summary, around half of parents say they're likely to get their child vaccinated. Many parents cite concerns for short or long-term side effects, such as fever, anaphylaxis, or myocarditis, in their decision to vaccinate their child. Other factors include the parent's own vaccination status and a provider recommendation. Next slide. The work group determined that the target population felt the desirable effects were moderate compared to the undesirable effects. Next slide. And that there was probably important uncertainty or variability in how people value these outcomes. Next slide. Moving to acceptability. Next slide. Dr. Chatham-Stevens outlined the jurisdiction implementation planning, so I won't go over those in detail again, but we know that over 70% of Vaccine for Children's or VFC providers were enrolled as a COVID-19 vaccine provider. And these providers represent over 80% of VFC vaccines distributed in 2019 for influenza and MMR vaccines. As an AAP survey demonstrated, 75% of primary care pediatricians reported their main work setting is enrolled as a COVID provider, and 70% are already giving vaccine to those 12 years of age and over in their practice. Next slide. So in summary, we know that most jurisdictions plan to utilize a variety of implementation strategies to vaccinate children 5 through 11 years of age. Parents report the greatest comfort with receiving a COVID vaccine at their primary care provider's office, and jurisdictions anticipate that most children will be vaccinated at these providers. And over 70% of VFC providers are already enrolled as a COVID provider. Next slide. The work group felt that the Pfizer vaccine was acceptable to key stakeholders for children. Next slide. Next, feasibility. Next slide. Again, we heard earlier around the implementation goals to reach the most children, including those who are hard to reach. There are around 28 million children 5 through 11 years of age in the US. Next slide. There are some feasibility concerns around the formulation of the vaccine for those 5 through 11 years. This different vaccine formulation may lead to administration errors, and provider education around this is ongoing, with materials color-coded as shown here and described earlier. In addition, this new formulation can be stored at refrigerator temperatures for up to 10 weeks prior to use and has a 100-dose minimum order size. Next slide. The work group felt that the vaccine was feasible to implement among children 5 through 11 years of age. Next slide. Now for resource use. Next slide. We presented this information previously, but in this setting, the US government has purchased enough vaccine to support vaccination of the pediatric population, so the vaccine will be available at no cost. Cost effectiveness may not be a driver in the pandemic, but will be reassessed in the future. And the use of COVID vaccines in as many populations as possible will likely have a positive economic impact as we try to return to pre-pandemic activities. Next slide. So the work group felt the vaccine was a reasonable and efficient allocation of resources. Next slide. And finally, equity. Next slide. This slide highlights children that could be disproportionately affected by both COVID-19 or access to healthcare. Next slide. This slide shows the results in adolescent COVID-19 vaccine coverage through the NIS Teen Survey conducted in September. The darkest blue colors show those who are vaccinated already. The middle to lighter blue shows that unrealized intent, those who definitely or probably will get vaccinated but haven't yet. You can see that this proportion varies by sex, age, and race. Next slide. This unrealized intent is also quite high for those living below poverty and those living in rural areas, as shown here on this slide. Next slide. While we don't have data on inequities with the vaccine in children 5 through 11 years, we can look at lessons learned from the adolescent population. Nearly 5 months after the adolescent vaccine rollout, there remains unrealized intent, largest for those living in poverty and in rural areas. It's critical for CDC and public health partners to redouble efforts for equitable access to COVID vaccines. And this can include novel strategies such as school-located vaccinations. Next slide. There are a variety of other opportunities to increase the equitable access, including utilizing trusted providers in the medical home, partnering with school-located clinics to reach those without a medical home, and utilizing the broad reach of pharmacies. Next slide. As with previous ETR presentations, the workgroup struggled with the impact of a Pfizer vaccine among children on equity. Broad prevention of disease, especially a disease that's disproportionately impacted communities of color and lower income communities, can provide equity, but only if we make every effort for the intervention to be accessible to all. Next slide. So in summary, next slide. This slide shows the conclusion for each of the workgroup judgments. Next slide. The workgroup discussed that the vaccine policy decisions are made on the balance of known benefits and risks to the individual. Other benefits, such as the prevention of transmission, greater confidence in return to school or social interactions, and risks, such as extrapolation of myocarditis risks from other ages, is a part of a broader picture. We have experience with over 400 million doses of mRNA vaccines administered to people 12 years of age and over with a reassuring safety profile. And overall, the benefits outweigh the risk regardless of seropositivity rates. Next slide. So as we think through the direct impact of vaccination of a child 5 through 11 years, we know we have over 90% efficacy in the prevention of COVID cases. And we likely have prevention of COVID-19 related post-COVID conditions, MIS, hospitalizations, ICU, and death, and the possibility for more social interactions and uninterrupted school. Next slide. Then this child is also a part of a family. Vaccination of this child could possibly prevent transmission to vulnerable family members. And if their children aren't getting sick, parental participation on a workforce may be more stable and predictable. Next slide. Then this child is also within a community. Vaccination of this child could result in lower transmission within schools and a community, and could have a more confident return to all in-person learning. Next slide. As we think through next steps, as with all ages and vaccines, close monitoring of post-authorization safety surveillance is critical and ongoing. As we did for the Pfizer vaccine recommendations in those 16 and over, the vaccine recommendations made under EUA are interim and will be reviewed at the time of BLA submission. At that time, we'll have longer follow-up time for children enrolled in the clinical trials. We can update the benefit risk analysis with additional data from the clinical trials as well as post-authorization safety surveillance. And as always, we can continue to evaluate ways to mitigate risks of rare events after vaccination. Next slide. Dr. Shimabukuro described the platforms to monitor safety in this population. I won't go over everything on this slide, but just wanted to highlight that there are already plans in place for post-authorization monitoring of vaccine effectiveness as well. We may get estimates as early as 90 days after authorization, but as always, it will depend on both vaccine coverage as well as rates of disease. Next slide. Since the beginning of the COVID-19 pandemic, among US children 5 through 11 years of age, there have been 1.9 million cases, 8,300 hospitalizations, over 2,000 MIS cases, and at least 94 deaths. Next slide. COVID-19 is now vaccine preventable. So we now have the ability to prevent this burden of disease, future hospitalizations, and deaths from COVID-19 in children 5 to 11 years of age. Next slide. Considering the totality of the data, the workgroup felt that the desirable consequences clearly outweigh undesirable consequences in most settings. Next slide. and the work group proposed to recommend the intervention. Next slide. As always, I want to acknowledge the many people on our team as well as across CDC who provided data for this presentation. And I will turn it back over to Dr. Lee.
Thank you very much, Dr. Oliver. Before we open this presentation and other presentations in the session for questions, I believe we have a few liaison organizations who wish to make some statements. So I'm going to ask if Dr. Bonnie Maldonado is on the line and can provide a statement on behalf of the American Academy of Pediatrics.
Yes, thank you, Dr. Lee, and thank you, Dr. Oliver, for that comprehensive review. So I'd like to read a statement on behalf of the American Academy of Pediatrics in my role as chair and representing the Committee on Infectious Diseases for the Academy. And this is our policy, our stand on COVID-19 vaccines in children and adolescents. Vaccines are safe and effective in protecting individuals and populations against infectious diseases. New vaccines are evaluated by a long-standing, rigorous, and transparent process through the U.S. Food and Drug Administration and the Centers for Disease Control and Prevention, by which safety and efficacy data are reviewed before authorization and recommendation. The American Academy of Pediatrics recommends the following related to coronavirus disease 2019 or COVID-19 vaccine in children and adolescents. The AAP recommends COVID-19 vaccination for all children and adolescents 5 years of age and older who do not have contraindications using a COVID-19 vaccine authorized for use for their age. Any COVID-19 vaccine authorized through emergency use authorization or approved through a biologics license application by the U.S. Food and Drug Administration, recommended by the CDC, and appropriate by age and health status can be used for COVID-19 vaccination, primary series, additional doses, or booster doses, according to CDC guidelines for children and adolescents. Children with prior infection or disease with SARS-CoV-2 should receive COVID-19 vaccination according to CDC guidelines. Given the importance of routine vaccination and the need for rapid uptake of COVID-19 vaccines, the AAP supports co-administration of routine childhood and adolescent immunizations with COVID-19 vaccines or vaccination in the days before or after for children and adolescents who are behind on or due for immunizations based on the CDC AAP recommended child and adolescent immunization schedule and or at increased risk from vaccine preventable diseases. Pediatricians are encouraged to promote vaccination through ongoing proactive messaging, for example, reminder recall, vaccine appointments, and clinics, as well as to use existing patient visits as an opportunity to promote and provide COVID-19 vaccines. Pediatricians' role in promoting vaccination among their patient population and in their community is critical, especially among those at highest risk for severe illness, hospitalization, and death from COVID-19, as well as their household contacts. Parents, caregivers, and patients might have questions that need to be addressed related to the vaccine. Pediatricians play an essential role in helping answer these questions, as well as in reducing existing disparities and addressing any barriers to accessing COVID-19 vaccine in the community. For additional guidance on the administration of COVID-19 vaccines, storage, handling, and reporting, and patient education for each specific visit, please visit the appropriate CDC and AAP websites at aap.org. Thank you so much.
Thank you, Dr. Maldonado. Next, we have Dr. Pamela Rockwell from the American Academy of Family Physicians, AAFP. Dr. Rockwell, are you on the line?
Yes, I am. Thank you, Dr. Lee. This is Pamela Rockwell, liaison to the American Academy of Family Physicians. The AAFP strongly supports COVID-19 vaccination in all eligible children 5 to 11 years of age as authorized by the FDA. Vaccination will provide children protection from the very real and significant harms of COVID-19 infection. And speaking as a family physician with 30 years of clinical experience treating both children and adults in my practice, I have seen the devastating effects of COVID-19 infection, not only in my patients who have died from the disease, but also in those who have survived and now suffer from long-term effects of COVID-19. They suffer physical, mental, and emotional effects of long-haul COVID. And as we have seen in the presentations today, long-haul COVID also occurs in children, and data are still emerging. Vaccination of children ages 5 to 11 years will not only help prevent COVID-19 infection and serious consequences of infection in this age group, but it will also help children emotionally and socially to improve their development. It will help reduce inequities in the impact of COVID-19 on our population, reduce the need for future school closures, disruptions, and obligatory times of quarantine, allowing sports, after school, and other school-based and social activities to occur without risk and anxiety, and help improve our children's quality of life, not just prevent COVID-19 illness and death in children and all the adults around them. Thank you.
Thank you, Dr. Rockwell. Next, we have Ms. Patsy Stinchfield from NAPNAP. Ms. Stinchfield.
Thank you, Dr. Lee. As the ACIP liaison representative for America's pediatric nurse practitioners, I want to offer our strong support of the use of the Pfizer-BioNTech pediatric formulation equitably distributed to all children 5 to 11 years of age, as you heard during our public comment from our NAPNAP president. We cannot reliably predict which child will have severe disease, with 1/3 of those children admitted to hospitals not having any underlying condition. We've heard the national data today, which includes the nearly 800 deaths of children, which is 4 times that of the annual influenza deaths, 94 children in the 5 to 11-year-old age groups. And just for parents and clinicians, there is an urgency to act, to look at this at a local level at just one of the United States 250 children's hospitals. Last week alone, as an example, Children's Minnesota tested 107 children positive for COVID. 18 of those children were admitted to the hospital. Half of them went to the ICU. None of them were vaccinated, and half of them were not age eligible for vaccine. We must protect our kids directly, which in turn protects families and the community at large against both direct and indirect harms from COVID disease. Having been called to the PICU over my 34 years as a pediatric nurse practitioner in infectious disease to talk to parents of children on life support for vaccine preventable diseases such as Hib, measles, and influenza, the common sentiment parents in that situation express is regret. Their question is, why didn't we vaccinate? We didn't know that children could get this sick. While hospitalization and death in children from COVID is rare, even one child and family loss is one too many when we have a safe and efficacious vaccine. We urge the committee to vote to recommend COVID vaccine for all children and encourage all families to enroll your child in the VSafe program. We must remove all barriers and not put up more new ones. We encourage all clinicians to report anything unusual to VAERS. All things considered, this is ultimately a risk-benefit decision for ACIP, for parents, and clinicians. And we agree, all measures point to COVID vaccine in 5 to 11-year-olds is of greater benefit than the real risk of children being unvaccinated. Pediatric nurse practitioners will be strongly recommending vaccination to our patients. Thank you for your commitment.
Thank you, Ms. Stinchfield. We have our colleague, Dr. Sean O'Leary, representing the Pediatric Infectious Diseases Society, who'd like to make a statement.
Thank you, Dr. Lee, and thanks to all of the great presenters today. So this is on behalf of the Pediatric Infectious Diseases Society. So the Pediatric Infectious Diseases Society, the world's largest organization of pediatric infectious diseases specialists, strongly supports a universal recommendation for COVID-19 vaccination of children 5 through 11 years of age as authorized by the FDA. PIDS also strongly encourages efforts to ensure equitable access to pediatric COVID-19 vaccines. More than 28 million children will be eligible for vaccination against COVID-19 with this recommendation. To date, over 6 million children have been diagnosed with COVID-19. Vaccination will provide children with critical protection against serious disease and long-term complications of COVID-19, and it will help bolster overall immunity in the community. Vaccinating school-aged children has other benefits, such as limiting disruption in school attendance, which allows children to participate in learning and other activities that are crucial for mental health and development. PIDS is encouraged that the federal government has developed a vaccine implementation plan that includes pre-purchasing vaccine doses for children and outlining a multi-pronged distribution strategy. The federal government and state and local partners should collaborate with trusted community-based organizations to ensure equitable vaccine access and uptake. This is a good time for parents to ensure that children are also up to date on all of the other recommended vaccines of childhood, including seasonal influenza. Don't procrastinate, vaccinate. Thank you.
Thank you, Dr. O'Leary. And now I'd like to open this presentation for questions. Since we are, headed into a vote after this session, I'm hoping we can encourage individuals to ask questions related to the ETR presentation and the vote, but we are happy to take any questions related to clinical considerations or other issues as well. So please go ahead and raise your hands if you have any questions or comments you'd like to make. Dr. Paling.
Hi, thank you for a fabulous presentation. I just wanted to ask you to go back and show us the data on the intentions to vaccinate by race and ethnicity. It came by so quickly, I just needed a moment to look at it. Thank you.
Is it this slide?
That was the one. Thank you very much.
Sure, thank you.
Dr. Lair?
Thank you for a wonderful presentation. I'm going to have you jump between a few slides. One quick question and one longer question. Could you go to slide 31, please? This is 1 million vaccinations. Does that mean 500,000 children being vaccinated or 1 million people being vaccinated?
Yes, 1 million vaccinations, which would be 500,000 children fully vaccinated.
Okay, so my concern is that I'm worried that the hospitalizations and the MAS cases are being undercounted. If you go to slide 76, this is the data that we have now. And in 1.9 million cases over 18 months, even if you sort of back that down a bit, you're still having probably 1,000 to 2,000 hospitalizations, which is much higher than you have. Also, many, many more MIS-C cases than you have on slide 31 and 32. And so I'm just wondering if you can explain that because I can't get my head around the numbers. Thank you.
So I'll try, and then we have somebody else here that has worked on this. So I'll see if she has anything else to add when I'm finished. The numbers that you're seeing here is across the 28 million children, 5 through 11 years of age, and over the span of, since March of 2020, over the span of the pandemic, across this population. So it's not the benefit risk is taking kind of the recent rates and applying that to 500,000 children who have been fully vaccinated. So, they're similar numbers. They're all using the same data we have, but it's kind of taking it. This is children, the 28 million children and over the course of the pandemic. And then the benefit risk ratio is over 6 months. So we know that the benefits will extend beyond that. But since the epi is difficult to predict kind of beyond that, the benefit risk ratio is just 6 months.
Did that answer your question, Dr. Lair?
I would still disagree slightly because if you take 1.9 million cases over 18 months and drop it down to 500,000 cases and then drop it down to 6 months, you're still going to have over 1,000 hospitalizations prevented. And I have to do the math on the MAS-C cases. So I still suggest that they're underestimating the amount of hospitalizations and MIS-C cases that are going to be prevented by this vaccine. But it's not a huge deal. Thank you.
Thanks. We'll feel free to take that under consideration. Thank you.
Okay, Dr. Sanchez?
Thank you. And thank you, Sarah. That was really a great presentation. Really good. I just had a comment on 555 with feasibility. I think it's great. The new formulation can be stored at refrigerator temperature for up to 10 weeks, but I think we really need to also, I would include in that table, and also that I think after it is mixed, after the vial is opened, I think it has to be used within 6 hours, right? So I think that message also needs to be, as we have a lot of offices and pharmacies, certainly, hopefully mostly pediatric offices that are going to be giving out the vaccine once approved, that we just, to make them aware that it must be used within 6 hours, I believe. Is that not correct?
Hey, this is Kevin Chatham-Stevens. Thanks for noting that. And that's something that has definitely been communicated out to a variety of our health department and clinical partners, just to make sure that they're aware of that particular aspect to this vaccine and making sure they're incorporating that into their plans to implement the vaccine program.
Thank you. Dr. Long?
Thanks so much. I, believe it or not, have no questions. I have just a comment to say I am very supportive of this recommendation in its full extent, as a should, not a may, for all children in this age group. And I think we reflect that we are very grateful that that Pfizer has studied this and made a dose that is tailored to do what we know works in other age groups, that the FDA has looked at this so carefully, has modeled many things for us, and that the work group and the CDC has gone to the extent that they have to show us every bit of information that there is on this. And I think the data support that we have one more vaccine that saves lives of children, and that we should be very confident to employ it to the maximum to do what it is meant to do without significant concerns of serious adverse events. So I couldn't be more supportive. Thank you.
Thank you, Dr. Long. And I also encourage, questions and comments from other ACIP members who may wish to do that now or later. Dr. Brooks.
Yes, thank you. That was an excellent presentation, kind of summarizing everything. I want to confirm something that I believe you said, that it takes only vaccinating 10 children or less to prevent one case of COVID in that age group. Is that what you said?
The number needed to vaccinate over 6 months using our current EPI, that is correct. That was 9. The number needed to vaccinate was 9 to prevent one case.
So I think, and I don't know if you know whether or not that's similar to adults. That's maybe not a fair question.
I would have, we did the number needed to vaccinate for boosters, but I don't have the number needed to vaccinate using our current EPI and current hospitalization rates for adults right now, but we can prepare that for future meetings.
Okay, and then lastly, very quickly, when we look for herd or community immunity, when we speak of a number, 80%, 75, 90, whatever, we're looking at the total population of an area, like the country, I believe. So that were we to get this 5 to 11-year-old age group vaccinated, we would be getting closer to whatever the percent is that we need for herd immunity in the United States. Is that a proper extrapolation of the discussion?
Hi, it's Dr. Jones. Well, we would discourage a strict goal of a threshold where we think if we reach that community transmission will then cease. that it's going to be very complicated with waning immunity, and you have protection against infection versus protection against severe disease. I think thinking that we will be able to achieve some kind of threshold where there will be no more transmission of infections may not be possible.
I think that is a very fair statement. Thank you.
Thank you. Dr. Daly.
Yeah, thank you so much. I think this recommendation needs to stand on its own merit, meaning that we have to conclude that the benefits of vaccinating an individual child strongly outweigh the vaccination risks for that very same child. And, as we've discussed today, children in this age group in the U.S. are dying from COVID-19, and this includes children who were healthy and did not have any other underlying chronic medical conditions. And then we know from real world evidence in adults that death from COVID-19 is vaccine preventable. And frankly, I want to take a step back on that last point and just say, in any context, we should consider that as a tremendous medical breakthrough, that we can prevent death through vaccination. And then I just also want to highlight that the available safety evidence comes not only from the clinical trial in this age group, but from the safety knowledge that we've gained from vaccinating several 100 million adults and adolescents with this vaccine. So, I think we need to acknowledge the unknowns, but I think we've done that today. And we need to approach the decision with humility, which in many ways, for me, stems directly from acknowledging the unknowns. And then finally, I'd want to make one last point, which is, what's the risk of waiting 6 months to make this decision? Well, I think that's clear. If we wait, we miss the chance to prevent many cases of COVID-19 in this age group, and that includes some very severe cases. So for all these reasons, I'm fully in support of recommending vaccine use for children 5 to 11 years of age. Thank you.
Thank you, Dr. Daly. Dr. Hoag.
Thank you so much. This is Michael Hoag from the American Pharmacists Association. I have a comment and then a question that I'll end with. My comment, first of all, is that the American Pharmacists Association is very supportive of routine immunization of children 5 to 11 with the COVID-19 vaccine. We strongly believe that the benefits outweigh the risks. There was great presentations that we saw today. I do want to remind consumers who may be listening to this presentation that vaccinations are a part of a child's well development, and there are many things that pediatricians want to visit with you as a parent and your children about when you have a healthcare encounter. And so we would encourage you to have conversations first with your pediatricians and to follow up on well child visits that may have been missed during the pandemic, and to catch up on the vaccines that you need by working with your pediatric office. That said, community pharmacies are accessible in local communities and rural areas, and sometimes in places where it may be inconvenient or not possible to get to your primary care provider's office, and pharmacists are more than willing to help ensure vaccine is available and to administer those vaccine doses. We do want to advise parents, however, that you should expect to have to make an appointment at a pharmacy to get vaccinated, and you should expect that there may be a longer than normal waiting time. We're experiencing staffing shortages in pharmacies, much like the rest of the workforce is experiencing shortages of personnel. And so we just want to set a good expectation with consumers on being able to get vaccinated. Now, my question that I would like to ask, which I don't think is relative to Dr. Oliver's presentation, but maybe the previous one, similar to the Pfizer adult formulation, when it came first to market almost a year ago, a little less than a year ago, providers who were allocated vaccine through the federal program and through the states were promised that second doses would be automatically allocated and shipped based upon first dose orders. Is that also true for the new pediatric formulation? Can providers count on second doses being automatically shipped and reserved by the state, or do providers need to be concerned with or worry with ensuring their patients have access to the second dose?
Hey, thanks for that question. This is Kevin Chatham-Stevens. So the approach to this vaccine rollout is a little different in that there's a large initial bolus of vaccine that is going out to jurisdictions, pharmacies, and some of the federal entities as well. And then after that initial bolus, there will be more of a kind of titrated approach, weekly doses going out as well. So we have been encouraging jurisdictions and pharmacies and all the providers who are getting vaccine to take into account how they will manage their second doses as they're getting this initial bolus and those follow-up doses as well. So this time around, it's a little different, and we have been messaging on that to ensure that everyone is aware and planning for that contingency.
Thank you. We'll actually go to Dr. Cotton next.
Thanks for all the excellent presentations. I wanted to highlight one of the most dramatic numbers I saw, which is the number of deaths per year prevented compared with other standard childhood vaccines, which for this vaccine, it is 3 times the number of deaths per year compared to any other standard vaccine that all of us routinely gave to our children. In addition, vaccinating children helps prevent spread to other children and to adults in the community, especially those who would be less well prevented by vaccination. Too many children have either lost a parent or become orphaned in this pandemic, which is incredibly tragic. So as an infectious disease specialist and a mother who has vaccinated both of her children, I am fully supportive of recommending this vaccine for this age cohort. Thank you.
Thank you. Dr. Goldman.
Thank you so much. Not to repeat much of what has already been said, but clearly, the benefits of this vaccine far outweigh the risks. And I just wanted to make an observation for those who are vaccine hesitant or concerned. Certainly as a parent myself, I was fortunate that my children were old enough to be in the 12 and up group and got their vaccines. But if they were younger, I would absolutely vaccinate them without hesitation. But when I look at my patients, I don't just look at the patient in front of me, but I also look at how are they going to be in 10, 20, 30 years from now. So I want the vaccine hesitant to consider that while as a child at this age, for all the reasons they shouldn't get COVID, if they don't get vaccinated now, looking 10, 15, 20 years, if we still have COVID endemic in the country and in the world, and if they get it as an adult or later on, it certainly would be much worse. So for all the reasons stated, as well as prevention of future infection, I wholeheartedly support this vaccine.
Thank you, Dr. Goldman. Dr. Saneas?
Yes, hi, thank you for this presentation. As a pediatrician, I also fully support vaccinating this age group, and I am reassured by the data provided today, as well as the robust post-authorization safety surveillance in place. I do continue to have concerns about equity, as we heard earlier about the disproportionate rate of hospitalizations and MIC in vulnerable populations. And I hope that we will all continue to work to increase our reach to these populations so that we can have better outcomes. Thank you.
Thank you, Dr. Saneas. Dr. Paling.
Yes, thank you. I too am very supportive, appreciate the data and weighing the risk and benefits. I wanted to give a chance to for a correction, because there is a misperception that fertility is impacted, and that showed up on one of the slides. And I was hoping the ACOG or someone would be able to address this, since there's been a lot of work done to assess that. Thank you.
Do we have a representative from ACOG on the line right now? Okay. We'll come back to that. Thank you very much for that question. We'll make sure that we get back to that in a moment. We'll go on to Dr. Bell.
Sorry. Thank you. I wanted to, since I wanted to also give my own perspective on this issue and the impending vote. And, you know, I would say that I feel that I have actually a responsibility. We all have a responsibility to make this vaccine available to children and to their parents. We have excellent evidence of efficacy and safety. We have a favorable risk-benefit analysis. And we have many parents out there who really are clamoring and want to have their children vaccinated. So I think, as I say, I feel that I have a responsibility to make the vaccine available. If I had a grandchild, I would certainly get that grandchild vaccinated as soon as possible. And as I say, I think there are many people who share that perspective. Will we gain additional knowledge as time goes on? Yes, of course we will, and that is a very, very positive thing. But we do have a pretty robust view of the situation at the moment, and I think that this is a huge step forward for children and parents, and I fully support the recommendation.
Thank you, Dr. Bell. Ms. McNally.
Thank you. Dr. Oliver, I wanted to ask you if you could reflect on whether or not this opinion, the recommendation in favor for this age group, was a majority opinion shared by the work group.
Thanks for that, Ms. McNally. Absolutely. The work group reviewed the data and discussed it and felt strongly that they recommended that the vaccine be recommended for this population.
Thank you. And it's not lost on me. The work group members comprise several liaison representatives as well as additional consultants in the healthcare setting. And I would, for people who are listening, who are wondering really the organizations that are talking about the importance of this vaccine, I would direct them to slide 7 of Dr. Daly's presentation. And I also would really thank the American Academy of Family Physicians, the Pediatric Infectious Disease Society, and the American Academy of Pediatrics today for talking about the importance of this vaccine and for their members and their patients. Thank you.
Thank you. Ms. Bata.
Thank you. I hesitated to raise my hand because every time I thought of something to add, it's already been said. In listening to the information today and having read through some of the materials beforehand, I think we know more than what we don't know, and that there is a huge commitment to filling in those gaps. And there is huge data that we don't have in making other recommendations that shows how well used this vaccine has been and its safety and its efficacy. And for those reasons alone, I do support moving to a universal recommendation for 5 to 11-year-olds. Thank you.
Thank you, Ms. Bata. I'm going to go to Dr. Reddy to respond to the prior question.
Hi, this is Sujan Reddy. I just wanted to respond to that comment about fertility. And we have a lot of, as you know, a couple weeks ago, we reviewed a lot of data around safety in women who are pregnant, want to get pregnant, or recently have been pregnant and are breastfeeding. And all the evidence supports the recommendation to vaccinate women in all of those categories. And we can point to several web pages that go over the evidence and that recommendation. Thanks.
Thank you. We'll move to Dr. Long.
So as a mother and a grandmother, I always say to patients, I hope I take as good care of my own family as I do your family. So I really mean that. I'm committed to everyone's family. So we have 3 children and their 3 spouses who got this vaccine as soon as they were eligible. We have 9 grandchildren, and 5 of them became eligible for this vaccine and were immunized within days of the birthday of their eligibility. And this decision that we make today will make 3 more eligible. So we will have by next week 8 of 9 grandchildren vaccinated.
Thank you, Dr. Long. Dr. Sanchez.
Thank you, Grace. No, I just want to also voice my support for this recommendation. I think the data that have been presented really speak volumes in terms of the safety and efficacy, and certainly there will be continued post surveillance for after implementation. And really, I long to see the data in the less than 5 years of age. As a pediatrician, infectious disease specialist, and neonatologist, I think we need to take it down all the way to 6 months or younger. Thank you.
Thank you, Dr. Sanchez. We'll save that for another meeting. Dr. Brooks.
Yes, I too want to endorse use of the or recommendation of the vaccine. And again, it was a statement earlier about for that one child and the benefit, but I also do look at the community benefit. And with less children, less individuals infected, there's just less likelihood to develop a variant. So I think that that's really, really important. And I think the bottom line is the data showed here today that the vaccine is safe and effective. So children are dying, and we can reduce hospitalizations, cases, and deaths with a safe and effective vaccine that will benefit the community. So there's an excellent presentation that led me to this decision to endorse the use of this vaccine in 5 to 11-year-olds.
Thank you, Dr. Brooks. Dr. Daly. Dr. Daly, I don't hear you yet. Dr. Daly, your audio doesn't seem to be working, so I'm actually going to go to Dr. Freihofer, and then we'll come back to you, Dr. Daly, okay? Dr. Freihofer.
Sandra Freihofer, speaking as a practicing physician and as a mother. I've been very impressed today with the safety presentations that have been given, and the fact that it was pointed out that this vaccine has the most intensive safety monitoring in history. I greatly appreciate the detailed discussion of the natural history of pre-COVID myocarditis and the different types of myocarditis we're seeing during this COVID pandemic, the myocarditis from COVID infection, from MISC, and from vaccination, and the close follow-up so far. And I really do appreciate CDC's reach out to parents and to guardians to participate in our vaccine safety surveillance and to sign up for VSafe. And if something happens that doesn't seem right, to send in a report to VAERS. And I also thought the comparison of this vaccine to other vaccines that we already are administering to our children to prevent disease was very helpful. It sort of puts the disease burden in context. And I certainly hope ACIP will make this vaccine available so we can get these 5 to 11-year-olds back to school and back to a more normal life. Thank you.
Thank you. Dr. Daly.
Yeah, can you hear me now?
We can. Thank you. Go ahead.
Yeah. So I wanted to make a couple comments. So Dr. Brooks, I hope I wasn't overstating my point. I meant that there needs to be benefit to the individual child who's vaccinated, and then there's many benefits beyond that. So just to be clear that I wasn't trying to say that those were the only benefits, but just that it needs to benefit the child, and the benefits need to outweigh the risk for that individual child. So, I'm going to take this conversation in a slightly different way, which is just to talk about dissenting voices. I just want to make it clear that I personally feel like collectively we're stronger if we hear from dissenting voices. So I appreciate hearing from folks who disagree with my views on this, or our views on this. And then I also want to speak directly to parents of children who are 5 to 11 years old. You know, we also are getting hundreds of calls from parents who want to vaccinate their child on the first day that vaccines become available. But we really recognize that there's parents out there who have concerns about COVID-19 vaccination. And I just want to state, you know, we hear you loud and clear. Of course, we know that you only want what's best for your child. And it's understandable that you have questions and concerns. And this may be particularly true given what seems to be a deliberate campaign of disinformation out there. And so I would just encourage you to talk to your child's pediatrician or family physician, you know, ask your questions, tell them what your concerns are. You know, they know your child, they know his or her medical history, they know your family, and they can just help walk through this with you, but we're all here to listen. Thank you.
Thank you, Dr. Daly. I'm just going to go in order. So Dr. Whitley Williams.
Thank you, Dr. Lee. Can you hear me?
We can. Thank you. Please go ahead.
Okay, great. Again, thank you for this great presentation. I think while equitable access to vaccine was mentioned, and particularly at appropriate facilities such as the pharmacies and community health centers and children's hospitals, as well as physicians' offices, there are lessons that we learned through our experience with the rollout of the adult COVID-19 immunization. And it taught us valuable lessons. And if we really look at our experience, the community health centers and community-based vaccination sites made access more equitable, particularly in communities of color. Not all communities of color have the larger pharmacies based right in their community. If the top 10 children's hospitals, most of which are located in major cities and serve diverse populations of children, if they were to be a major player and successful in outreach, that would be extremely supportive. I think what's not taken into account, and that is that parents or guardians of children, especially in communities of color, may be working and necessary to work. We don't have the buy-in from all employers to protect the employment of those individuals, a loss of wages of those parents to take time off and to take their child or children to get vaccinated. So I think us to continue to monitor the equitable access issue. I think the other consideration is the need for children to be in school because of some of the children who are at highest risk depend on their schools as a safe haven, as well as a source of 2 meals a day, 5 days a week. So to get the 5 to 11-year-old school-age children vaccinated will provide protection, especially when they are in school, and hopefully they will continue to stay in school. So the National Medical Association will continue to provide education to its membership, many of whom practice in communities of color, and continue to conduct educational outreach programs to persons in communities of color. We certainly support the safe vaccination and rollout and continue to protect the public, particularly those who are most vulnerable. Thank you.
Thank you, Dr. Whitley Williams. I am going to, Dr. Daly, I apologize that I'm going to actually just state my opinion. I don't have a dissenting opinion, but I did want to make a statement because I'm going to forget later. The reason I'm voting for this is individual protection. I value preventing infection in children, and I think it can have a huge positive impact on their health, their social and emotional well-being, their educational outcomes, and their long-term trajectory. While we do have other ways to prevent infection, such as masking, we know that there is substantial variability in the use of masks in school settings and that transmission can occur. And vaccines are really the only consistent and reliable way that we can provide that protection other than cocooning them at home to minimize their risk. but then that is depriving them of many other sort of important aspects of their childhood. I'll also just emphasize that, we really need to continue to invest resources and effort in understanding the broader health and non-health impact of COVID infections in the pediatric population and in children in general. But I am hopeful that this will take us one step along that journey. And I do also want to highlight what Dr. Whitley-Williams just mentioned, which is that disparities continue to exist. Where we are going to make additional efforts, it should be in partnership with communities where the need is the greatest. And it seems to me that would be an incredibly important investment in our efforts, in addition to making sure that children are able to seek care in their medical home. And with that, I will turn it over to Dr. Duchin.
Thank you, Dr. Lee. I am really pleased that we can expect to see benefits both to the individual, family, and community. And I just wanted to remark on an observation that we made here locally, that among our vaccinated populations, we have seen a reduction in the disparities that existed among unvaccinated adults with respect to case incidence, hospitalization rates, and death rates among the vaccinated. So that vaccinated adults who are people of color are showing less of a difference, and actually we're in the process of reporting this, but a reduction in those disparities of those unwanted health outcomes once vaccinated. And so I'm hopeful that we'll see something similar in our pediatric population.
Thank you, Dr. Duchin. Are there any other members who wish to make a comment, or liaison members? I don't see any additional hands raised. So I wanted to ask if there would be any objections from committee members if we were to forego the break and proceed straight to a vote. Are there any objections to that? All right, I do not see any objections electronically, and I haven't heard any, so I would suggest that we move straight into the vote, and we'll ask our committee members to turn on their videos, please. So if everyone could take a moment to please turn on your videos. I will turn it over to Dr. Oliver to go ahead and take us through the policy question.
Thanks. So as a reminder, this is the policy question before ACIP today. Should vaccination with the Pfizer-BioNTech COVID-19 vaccine, which is 2 doses of 10 micrograms given IM, be recommended for children 5 through 11 years of age under an emergency use authorization? Next slide. And as a reminder, this was the work group interpretation, that the desirable consequences clearly outweigh the undesirable consequences in most settings, and that they propose to recommend the intervention. Next slide. And so the proposed vote language is that the Pfizer-BioNTech COVID-19 vaccine, acknowledging that it's 10 micrograms for this age, is recommended for children 5 through 11 years of age in the U.S. population under the FDA's emergency use authorization. Thanks.
Sorry, I just want to confirm, have all committee members been able to join by video? All right, I think I see most of the committee members on. So the ACIP vote is up on the slide there. I'm going to ask if any of our members would like to make a motion. I think I see Dr. Cotton's hand raised. Dr. Cotton?
I'd like to make a motion to vote on this interim recommendation.
Do I have a second? Ms. Bata.
I second that motion.
Thank you. It's been moved and seconded that we adopt the recommendation language presented to us by Dr. Oliver on the slide there. Before we move to a vote, I'm just going to ask if there's any additional questions or issues the committee would like to discuss before this vote. Okay, I'm not seeing or hearing any questions or comments people would like to make. And I would like to remind you that after the vote, please feel free to also comment on your vote if you, you wish to do so. So we will proceed to a vote. ACIP members, I'm going to ask you if you can please state your name, whether you have a conflict of interest, and then your vote. And today I am actually going to start with Ms. Bhatta because she's on the top of my screen right here. So Ms. Bhatta, your name, your conflict of interest, and your vote, please.
Lynn Bhatta, no conflicts, yes.
Thank you. Dr. Bell.
Bell, no conflicts, yes.
Thank you. Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Thank you. Dr. Chen.
Wilbur Chen. Let me mention one perception of conflict that has come up that I just want to make sure that I mention, is that I work for an institution, the University of Maryland, Baltimore, which has a grant from Emergent Biosolutions that supports the work that I am doing to develop a Shigella vaccine. And my vote is a yes vote.
Thank you, Dr. Chen. Dr. Sineas.
Sineas, no conflict, yes.
Thank you. Dr. Daly.
Matthew Daly, no conflicts, yes.
Thank you. Dr. Cotton.
Camille Cotton, no conflicts, yes.
Thank you. Dr. Lair.
Amy Lair, no conflicts, yes.
Thank you. Dr. Long.
Long, no conflict, yes.
Thank you. Ms. McNally.
Veronica McNally, no conflicts, yes.
Thank you. Dr. Paling.
Kathy Paling, no conflicts, yes.
Thank you. Dr. Sanchez.
Pablo Sanchez, no conflict, yes.
Thank you. Dr. Talbot.
Talbot, no conflicts, yes. Dr. Lee, did we lose you?
Okay, thank you. Did you hear my vote? No, okay. Lee, no conflicts, yes. And so we have a total of 14 yeses, 0 no's, and so the motion passes, and the interim recommendation is now a recommendation by the ACIP. I would like to take a moment actually to ask if any of our committee members wish to make any additional comments about their vote or the deliberations today. Please feel free to raise your hand. Oh, Dr. Talbot, please go ahead.
Yeah, I've said this many times before, but I think it bears repeating. I think there's this impression that we aren't parents and we aren't people. And many of us today have spoken up. We have reviewed this data, and I have vaccinated my kids because I feel like it's safe. And I would not recommend something if I did not feel that way. And so I think it's really important to just reiterate what many of us have said. We are parents, and we have given this to our children because we have seen the devastation of this disease, and we've seen the disruption in our kids' lives. And we are very looking forward to moving forward.
Thank you. Ms. McNally.
I also have a child in this age group, and I am going to take my child to get this vaccine, and I have gotten my other kids vaccinated as they are in the older age group. I am really doing this to prevent number 95, the 95th death So 94 parents have had to bury their child. 8,300 kids have been hospitalized, 1.9 million lives have been disrupted by cases, and 2,300 families have experienced a child with multiple organ failure. To say that this disease is not impacting kids is not an accurate statement, and I hope that people will understand that. I also just want to take a minute to talk to providers. If you are a provider caring for a child in this age group and you are not vaccinating this, if you are not recommending this vaccine, I just hope that you will understand the significance of that on a family and make sure that you're following the information closely. I'm very confident in our vaccine safety monitoring system, and I feel very comfortable as a parent and as the consumer representative recommending that we vaccinate in this age group. Thank you.
Thank you, Ms. McNally. Are there any other comments or hands raised from committee members? Dr. Brooks.
Yes, so just for a clarification, maybe to the public at large, the vote we took was based on the science and the recommendations that we personally felt brought us to this conclusion. The ACIP members have nothing to do with determinations regarding mandates or what happens once this recommendation is made. So I just want to make a clarification for those who may have some conflict in terms of, or misinformation in terms of that thought.
Thank you, Dr. Brooks. Any other? Oh, thank you, Dr. Bell.
Yes, thank you. I just wanted to reiterate what Dr. Daly said earlier. As you've heard, we all have a lot of enthusiasm for this vaccine in this age group, but we also understand that parents have legitimate concerns and legitimate questions, and that our vote is a way of telling the American public that based on our expertise and the information that we have, we're all very enthusiastic. We've all talked about how we're getting our kids and our grandkids vaccinated. But I think another point to be made to the American public is that we do understand that people have legitimate concerns and they have lots of questions. And we really encourage people to ask their providers, to visit the CDC website, to talk to their friends, their parents, and do what they need to do to feel comfortable with their decision.
Thank you, Dr. Bell. Dr. Lear? You're still muted, Dr. Lear.
Thank you. I'd like to echo many of the comments of my colleagues. I feel that this is a safe and effective vaccine with more benefits than risk. And I'd also like to offer a formal apology to Dr. Oliver and the modelers. I was doing my math wrong, and they are absolutely correct when they are saying the numbers, and I want to just reflect that their numbers were more accurate than my back of the envelope calculations. So please take that into consideration. Thank you.
Thank you, Dr. Lear. The team here thanks you. Any other comments or questions? Okay, I don't see any additional hands raised. I just want to take a moment to thank our committee members for their incredible and ongoing service to the country. I wanted to thank all of our speakers today for the outstanding presentations, and to all of our federal colleagues and our liaisons for the supporting us with this robust discussion today. I do not see or hear any objections to adjourning today's meeting. Dr. Wharton, is there anything additional?
No, Dr. Lee, I believe we can adjourn the meeting.
Okay, wonderful. So today's ACIP meeting is now adjourned. Don't forget, we have a non-COVID ACIP meeting day tomorrow. So I look forward to seeing everybody in the morning. Have a good night, everyone.